نبلش بهيدا شباب.
تستو
بنبلش بهيدا بعدين. أنا شفت.
ماشي. Good morning, everybody, and welcome to our symposium for today. So, on behalf of the Department of Anesthesia at the American University of Beirut and the Division of Pain, I'd like to welcome you to our first annual Beirut Anesthesia meeting, or Beirut Annual Anesthesia Symposium. Basically, it will be the first of a series that will follow, that it will be a yearly activity for our department, and that will cover the many subspecialties of anesthesia. So this year we're starting, and it is a very nice and exciting start with the pain medicine. So I'm sure we have had a very interesting program that Ghassan will be detailing for you. On a different note, I'd like to welcome you to this new auditorium at the ACC, Halim and Aida Daniel auditorium, which is the latest achievement of AUB, and that is hosting now a lot of centers of excellence in many specialties. And basically, very soon, like in the coming months, it will also be hosting one-of-a-kind pain clinic that will cover many pain conditions, that will be a state-of-the-art center, fully equipped with all the specialist required for this very challenging specialty. So again, welcome. I hope you'll enjoy the program, and I leave the floor for Dr. Kanazia to explain more.
Thank you, Marianne. It's a pleasure to have you all here. It's a pleasure to see so many people that are interested. You know, the whole thing, just to take a couple of minutes, you know, an idea that became a reality. You know, sitting one day in the office with Dr. Maroon, and we were discussing, you know, about the fact that we really need to do something for our department, our Lebanese society, different pain societies. And then it kind of came to us like, why don't you start with an annual meeting for the department? And as you could see, this is our first trial, and hopefully there'll be many more to have here. Again, I would like to thank everyone. I would like to thank the Lebanese Society for Anesthesia, the Lebanese chapter for the International Association for the Study of Pain. I would like also to thank the Society for Treatment of Pain, you know, for sponsoring us during this conference. One of the things that you could see here is the title of this conference. It's very important that we felt, or actually the discussions was like, you know, the treatment of back pain. And not only back pain specifically, but pain in general. This is becoming an extremely kind of like a sexy idea that everybody is interested in, and everybody wants to start, you know, working with pain patients and in general, and back pain in specific. What the concept here that are going to be discussed during this conference is, as the title says, you know, it's going to be evidence-based. So we are going to stress the importance of using evidence-based treatments in this conference. And I really hope you will enjoy it. And participate in the future conferences. A couple of announcements I'd like to make is that there are some changes in last-minute changes. As you all know, we have last-minute changes that happens in the program. The first session, Dr. Ashraf Makki has declined on a last minute due to personal reasons, so he will not be giving us the lecture on importance or role of nerve conduction studies and EMG in management of back pain. We will cut this session a little bit short, so we'll only go with 3 lectures with the first session. This way you can have a longer coffee break and enjoy yourself. The second session, also we have Dr. Marwan Razak that has also declined last minute due to personal reasons. And what we'll do is that we have asked Dr. Timothy Moss, and he was kind enough to add another, to replace it and fill in with a second lecture. And last thing, I would like to ask you to all turn off your beepers and put your cell phones on vibrate mode. First speaker, Dr. Fadila Naji. Dr. Naji comes from the Department of Family Medicine, and I made sure that we include somebody from family medicine and primary care in the treatment in this conference, simply because they are usually the first line that would see patients with back pain, and we'd like to see their perspective on this talk. So, Dr. Naji, welcome, and the floor is yours. ما في كليب اون؟
خلاص فينا ماشي. اوكي. Okay. Good morning. Thank you, Dr. Kanazi, for the invitation. It's a pleasure to be with you today. So we'll start today's discussion with the condition I'm sure we all see very frequently in our clinical practice, whether we are pain specialists, primary care physicians, neurosurgeons, the non-specific lower back pain, as we call it, and we'll try to shed light on some of its enigmatic aspects and one of its debatable causes, the myofascial back pain. So we'll start with a case presentation. A 40-year-old female housewife presents to your clinic with right-sided lower back pain of 5 years duration that got worse over the last 2 years. She describes her pain as a dull ache ascending from her lower back to her right flank area, or what she refers to as her kidney, and she reports that her pain is constantly felt with a baseline intensity of around 4/10, but it would get significantly worse with specific triggers like moving from the sitting to the standing position, sleeping on her right side, climbing stairs, coughing or sneezing. And over the last 2 years, her pain started to radiate to the right groin and buttock area without numbness, tingling or paresthesias, and she started feeling a sharp pain over the lateral aspect of her right hip and thigh, often reaching the ankle. She visited numerous physicians before coming to you. A lumbar spine MRI was requested given the chronicity of her pain and the presence of radicular symptoms. It was normal. Lab tests also requested on several occasions, including a basic rheumatology panel were normal as well. She was told she has non-specific lumbago and was asked to exercise, take painkillers when needed, and live with the residual pain. She was also prescribed antidepressants on multiple occasions, but she refused to take them because she thinks she is not depressed. And she tried physical therapy only once, but didn't pursue the recommended treatment course because also she felt it's time-consuming and not very helpful. Her physical examination was grossly unremarkable. What's your clinical impression so far? So I think the majority will say non-specific lower back pain or mechanical lower back pain, or maybe some will call it muscular or musculoskeletal lower back pain. These terms are being used very frequently and interchangeably, although they are not really synonyms, especially the term non-specific lower back pain that has become fixed in the current medical lexicon. So what is non-specific lower back pain and how common it is? Actually, specific causes of back pain are uncommon. They constitute less than 15% of all back pain cases, and the remaining majority are referred to as non-specific lower back pain, which is defined as a condition where the patient is complaining of back pain, but the clinical exam, imaging, and lab tests yield no abnormalities. Basically, studies show that different structures can contribute to the development of non-specific lower back pain, including joints, discs, muscles, and connective tissues. And I'll be focusing my talk today on these two elements because I think this aspect is not given the attention it deserves, although studies suggest that muscular ligamentous lower back pain is one of the most common causes of non-specific lower back pain. And muscular ligamentous lower back pain can be further subcategorized into paralumbar muscular pain, myofascial pain, spinal ligament pathology, lumbar instability, and piriformis syndrome. So is non-specific lower back pain really non-specific, or non-specific is just easier for us? So we just said that non-specific lower back pain can be muscular. It can be due to something else, but it can be very commonly muscular. But is muscular lower back pain non-specific? Okay. So, in other terms, is muscular back pain one or multiple entities? Here, let me ask you a question. What's the number of muscles that can directly cause muscular lower back pain? Approximate number of muscles that can be involved in muscular back pain? Any thoughts? 5. 15. Over 20 muscles, okay? If we want to classify these muscles according to their anatomical location, we can see that some of them belong to the torso, back, or even abdomen, where the quadratus lumborum and rectus abdominis muscles, for instance, are very common causes of muscular back pain, and some of them belong to the lower limb, hip, thigh, and even the leg. So paraspinal muscles are not the only source of muscular back pain. And if we want to classify these muscles according to the reported area of pain, we can see that certain muscles can cause lumbar pain, whereas other muscles can cause iliosacral and gluteal or low thoracic pain, for example. But does it really make a difference if muscular back pain is due to the iliopsoas muscle or the piriformis muscle, for example? We'll try to answer this question by end of this talk. So now let's move from the muscular pain concept to the myofascial pain concept, which is still questionable to many researchers and scientists. This concept evolved from the view that both muscle and fascia are likely to be contributors to the symptoms of muscular pain. Myofascial pain syndrome, or MPS, is defined as a regional muscle pain syndrome characterized by the presence of trigger points in fascia, tendons, and/or muscles. So what are trigger points? They are considered the heart of the myofascial pain syndrome. They're defined as focal hyperirritable spots, commonly recognized as muscle knots, located in a palpable hard band of skeletal muscle, which produces both referred regional pain and muscle stiffness and/or weakness. I'm sure we're all familiar with the common upper traps trigger point, which is a common source of tension headache and temporomandibular pain through the referred pain it produces. Now, although MPS is thought to involve a local muscular phenomenon, studies suggest that it's actually a complex form of neuromuscular dysfunction because trigger points are considered like constant sources of nociceptive input, okay, that can cause both peripheral sensitization and central sensitization, which is the cause of the referred pain. And that's perhaps the most enigmatic aspect of myofascial pain because the pain is felt somewhere, but the origin of the pain is somewhere else. So as we can see here, according to the American College of Rheumatology, myofascial pain and fibromyalgia are both considered conditions related to central sensitization. They are classified as peripheral and central nervous system dysfunctions rather than somatic dysfunctions. How to diagnose myofascial pain? Here lie most of the controversies because we don't have well-validated objective diagnostic criteria. What we have so far is based on expert recommendations, mainly on the hard work of Janet Travel and David Simons, two American physicians, pioneers in this field. They mapped all trigger points, pain patterns in the body, and authored the manuals of myofascial pain and dysfunction that are considered the Bible of myofascial pain today. According to them, the combination of a spot tenderness of a nodule in a hard band of muscle plus patient recognition of pain by pressure on this tender nodule are minimum acceptable criteria. But how about the sensitivity and specificity of these criteria? I came across a nice statement while preparing this presentation. If MRI is the gold standard for diagnosing structural spine pathologies, our hands are the gold standard for diagnosing muscular dysfunctions. This is a nice statement, but it ignores the fact that digital palpation lacks sensitivity and specificity, especially with the lack of adequate physicians' training in muscular exam and musculoskeletal medicine in general. We have a lot of studies showing inadequate physicians' training in musculoskeletal medicine. I wish I had more time to share some of these studies with you, but there's a clear discrepancy between the magnitude of the musculoskeletal problems and physicians' competence in musculoskeletal medicine. Now, interestingly, a systematic review showed that the identification of trigger points among experienced clinicians yielded substantial inter-observer agreement, while pairing experienced and inexperienced clinicians yielded moderate agreement, which again reflects the importance of a unified physicians' training in muscular exam and musculoskeletal medicine in general. So that was a quick review of MPS or myofascial pain in general. Now let's move to the myofascial lower back pain. So what is myofascial lower back pain? It is defined as back pain due to active trigger points in back muscles. Commonly affected muscles are the quadratus lumborum, gluteus medius, paraspinal muscles, with the QL and gluteus medius being the most frequently involved. So I'll be discussing mainly two muscles only because of the limited time. So basically the quadratus lumborum, named by Janet Travel the Joker of lower back pain. Actually, this muscle is considered the posterior abdominal wall muscle, is one of the most commonly overlooked muscular sources of lower back pain. And it's often responsible through satellite gluteus minimus trigger points for the pseudo-disc syndrome or pseudo-sciatica. According to Travel and Simons, there are two common trigger points locations in the QL, deep medial and lateral superficial. So according to them, as you can see here, the deep cephala trigger point refers pain to the area of the sacroiliac joint. The deep caudal trigger point can refer pain to the lower buttock area. The superficial cephala trigger point can refer pain to the area of the iliac crest, sometimes reaching the groin and the lower outer aspect of the abdomen. And the superficial caudal trigger point can refer pain to the area of the greater trochanter and the lateral aspect of the thigh. Now, the gluteus minimus the gluteus minimus muscle actually is considered a potent myofascial source of pseudo-radiculopathy or pseudo-sciatica. And usually the pain felt is so remote from the muscle that its origin can be easily overlooked. So according to Travel and Simons, anterior trigger points in the gluteus minimus can refer pain to the lateral aspect of the thigh and leg, mimicking an L5 pattern. And the more posterior trigger points can refer pain to the buttock, posterior aspect of the thigh and leg, mimicking an S1 pattern. So the clinical assessment of myofascial lower back pain is based on a thorough history and back exam, which are still the most useful diagnostic tools despite of their limitations. We all know how to take a pain history, how to ask about pain characteristics, how to ask about the red flags. But in this context, we need also to address specific other aspects, the perpetuating factors and the yellow flags, which we're discussing in a moment. And definitely a muscular exam is paramount in myofascial back pain assessment. What are perpetuating factors? As their name denotes, they are factors that can initiate and maintain myofascial pain. They are classified into ergonomic factors, mainly work-related and posture-related. Structural factors, anatomical abnormalities like small hemipelvis, scoliosis, lower leg length inequality, and some medical factors like hormonal imbalances, some chronic infections. These factors should always be considered and eliminated in case they were present in order to prevent pain recurrence. The yellow flags. I'm sure we're all familiar with the red flags, and we all make sure to rule them out at the very beginning of any clinical assessment because they can be signs of danger. But how about the yellow flags? Studies show that yellow flags are real determinant of chronic back pain severity, chronic non-specific lower back pain severity. There are psychosocial factors shown to be indicative of long-term chronicity and disability, a negative attitude that back pain is harmful or severely disabling, fear avoidance behavior, an expectation that passive rather than active treatment will be beneficial, a tendency to depression, social or financial problems. These factors should always be addressed, especially in patients who go through back pain chronification. Now, a few words on muscular back exam. So as we said, it is paramount in myofascial back pain assessment. How do you usually examine back muscles? I think that maybe many of us would just maybe palpate the soft tissue surrounding the spine, and this is not actually the correct way it should be done. A correct muscular back exam resembles a whirlwind where the patient should be positioned in 4 different positions in order to best access all muscles that can be involved in back pain, the prone position, side-lying position, supine, and semi-seated position. Definitely we need to be familiar with our muscle anatomy. Basic biomechanics, we need to be familiar with common trigger point locations, common pain referral patterns, and even if we don't have the time to do it, or even if we won't do it, at least we need to know that this is how back muscles should be examined. Coming to the last section, the treatment of myofascial back pain. So the treatment can be pharmacologic or non-pharmacologic. Non-pharmacologic treatment can be non-invasive or invasive. I'll be basically only discussing the invasive treatment of myofascial lower back pain or trigger points needling because of the limited time and because I'm sure we're more familiar with the other treatment modalities. So basically, trigger point injections, or what's known as wet needling, consist of the injection of some form of injectate into the trigger point through a needle inserted into the trigger point. Anesthetics are the most commonly used injectates, and mainly the lidocaine. Corticosteroid injections in general are not recommended. They're used, but they're not recommended because of their side effects. Botox trigger point injection look appealing because theoretically they can be considered like a long-acting trigger point injectate. Also, saline injections were introduced in 1955 trying to avoid the risks of local anesthetics. But which injectate is superior? So we had a lot of studies comparing the efficacy of different injectates and trigger points deactivation. I'll be sharing with you a couple of studies. So a double-blind RCT compared lumbar myofascial pain reduction at 90 days between Botox injection, normal saline, and bupivacaine, and found no difference. Another recent systematic review published in 2018, including 33 RCTs, found that local anesthetic injections were more effective than Botox injection at mitigating myofascial pain intensity in the short term. There was no difference in the long term, basically. And a Cochrane review published in 2007 showed that Botox use is sometimes effective in treating myofascial pain, but is not supported by evidence, and its effects do not exceed in removing trigger points those of anesthetics or an ACL. So, naturally, the effectiveness of needling without the use of anesthetics led to the question of whether any form of injectate is at all necessary for deactivating trigger points. And so the idea of dry needling started appearing. In 1979, Carl Lewitt was one of the first physicians to try needling without the use of any anesthetic or even saline, a technique that became known as dry needling. As dry needling became more popular, further studies were done comparing the efficacy of dry needling and wet needling in trigger point deactivation. And I will share with you the findings of a systematic review by Cummings and White, including 20 RCTs. They found that the effect of needling is independent of the material injected, and they found no evidence to support or negate the use of any injectate over dry needling. So they found they're equally effective. And another systematic review of 23 RCTs published in 2015 concluded that dry needling appears to be an effective treatment intervention for relief of trigger point-associated pain regardless of body region. And finally, a Cochrane review of 35 RCTs also concluded that dry needling may be a useful adjunct to other therapies for chronic lower back pain. However, the unclear pathogenesis of myofascial pain syndrome, the absence of clear-cut diagnostic criteria, the cross-trial heterogeneity of interventions when it comes to assess needling, location of needles, depth of needling, duration of treatment, and the different outcome measures also, not to forget the difficulty of double blinding when it comes to assess an invasive procedure like needling. All these have affected the quality of the trials we have and hence the level of evidence. So there is a continued need for research to help devise uniform diagnostic criteria, elucidate the nature and etiology of trigger points, and verify the efficacy of current treatments. Back to our patient. Do you now think there was anything missing in the evaluation? Maybe the muscular exam was missing. Maybe you should have inquired more about some specific risk factors, but will this make it a real difference? Will this change our clinical impression? I don't suggest labeling this patient as having myofascial back pain due to gluteus minimus and quadratus lumborum trigger point, because to many this may sound useless, especially to those physicians who don't believe in the MPS concept, or to those physicians who don't have the time to examine the muscles, or who will again prescribe NSAIDs or muscle relaxants or antidepressants or refer the patient to physical therapy, which are very helpful modalities in this case. I didn't have the chance to discuss these treatment modalities with you, the efficacy of these treatments in this context, but they are helpful treatments. But to these physicians, it won't make any difference if back pain is due to the iliopsoas muscle or the piriformis muscle. It won't make any difference. So to them, muscular back pain is a more acceptable diagnosis. And maybe to many of us, non-specific lower back pain is still the preferred diagnosis in such a case, because it's like a comfort zone for us. It just means that there's nothing dangerous, nothing serious. So, and sometimes we just stop there. Okay, so what will change then for those physicians who still prefer the diagnosis of non-specific lower back pain in similar cases that we encounter every day in our clinical practice? What changed then if even the treatment can be the same? Patient education. Patient education can make a whole difference in these cases. Patients need to hear a diagnosis. They need to understand the reason for their pain. They need to understand what to expect, to know what to expect from treatments. When we tell them there's nothing, it's just non-specific, they will keep asking and coming until they get a convincing answer. Patients need to understand that non-specific lower back pain can be due to specific structures in the back. They need to understand that the muscles can be a source of real, chronic, and sometimes severe pain. And they need to understand the concept of central sensitization, which is a real cause of exaggerated pain perception. They need also to understand the importance of their active involvement in the treatment, active muscle conditioning, physical therapy, home-based exercises. Sometimes a small explanation makes a whole difference. So to those physicians, patient education is very important. Now, to those physicians who like the MPS concept, they might consider myofascial back pain as a potential diagnosis in this patient, and they can consider more specific targeted therapies like trigger point injections or dry needling, or maybe even manual therapy. My take-home messages for today. Even if you don't believe in the MPS concept, don't forget the largest organ in the body, the muscles. The skeletal muscles. We have around 400 skeletal muscles. It's worth giving this organ a little more attention. Take non-specific lower back pain as seriously as you take any other back pathology, because patient suffering is the same, and patient suffering should always be taken seriously. myofascial lower back pain can be considered in any patient with an ill-defined, non-specific, enigmatic back pain case. Remember the concept of central sensitization before somatization. I think that we tend to have a very low threshold to label our patients as somatizers, as doctor shoppers, and we forget this central sensitization phenomenon, which is the common denominator of all stubborn, chronic, enigmatic pain cases. So we need to remember this. Always and always educate your patient. It makes a real difference. And a constant cliche theme, treat the patient, not the MRI, because non-organic doesn't necessarily equate fabrication or exaggeration of symptoms. And I finally would like to share with you a nice article from the Washington Post, written by a biologist who was suffering of chronic pelvic pain. And after years of suffering, she visited the doctor who diagnosed her with myofascial pain and treated her with dry needling and manual therapy, and this ended her suffer. This small paragraph maybe summarizes my main take-home message for today. Why did anybody notice? I asked my doctor soon after he correctly diagnosed the reason for my pain. Because doctors don't specialize in muscles, he said. It is the forgotten organ. Thank you very much.
Thank you, Dr. Naji. Questions will be, I'd like to spare them until the end of this session. Please, if you have any questions, keep them in mind, write them down, and we'll be more than happy to address them. Our next speaker is Dr. Rana Yamout. Dr. Yamout is a recent addition to our department, and we are very glad to have her. She's currently managing our acute pain service as well as the palliative care at the American University Medical Center. Dr. Yamout graduated from St. Joseph Medical School, and her interest in pain led her to do a master's in pain in Paris, and came back to Lebanon, worked at Clemenceau Hospital for some time, and we were lucky to snatch her from Clemenceau and get her to AUB. Dr. Yamout will be talking to us today about medical management from her perspective of patients with back pain. Welcome, Dr. Yamout.
Thank you, Dr. Kanaza. I'm very happy also and glad to be part of the department. So I will be talking today about back pain treatment, trends, and way forward. First, when you asked me to talk about back pain, I thought it would be very easy to talk about it. But actually, when I start presenting and preparing for this session, I realized that really it's not easy. There are no clear guidelines. The evidence-based articles are really contradictory. And you will see here why it's not easy to talk about this topic. During my presentation, I will try to answer these questions. Why it is important to talk about back pain, when to start a pharmacological treatment, what can be learned from other countries, and finally, the proposed way forward for Lebanon. Actually, lower back pain is one of the most prevalent musculoskeletal symptoms and the #1 cause of disability worldwide. 2 in every 10 adults present chronic back pain that can last for more than 12 weeks. And the 1-year risk of recurrence is estimated to be around 30%. And as Dr. Fadila said, up to 99% of patients present with low back pain in primary care has no specific nociceptive source of their pain. And among these patients, 50 to 70% receive analgesic medication. So as you can see, there is a high burden to disability, high direct medical treatment costs, and high indirect costs associated with absenteeism from work and productivity loss. So this is the review of most prescribed non-invasive pharmacological options between 2013 and 2014. And among 1,000 spinal problems, the most prescribed medication, unfortunately, was the opioids, followed by NSAIDs, then paracetamol, then muscle relaxants, and finally antidepressants and anticonvulsants. So is this really the best practice? In order to answer this question, we looked at the guidelines of 8 countries, And then we compared them to the findings from recent RCTs and review articles. And this will be concerning the 6 most pharmacological treatment: the paracetamol, the NSAIDs, the anticonvulsant, the muscle relaxants, the antidepressants, and the opioids. And we will talk briefly about each medication. Let's start by answering when to start a pharmacological treatment in back pain. Actually, 5 guidelines recommend that pharmacotherapy should be a treatment option that may be considered if required by the patients. And this recommendation is done by Australia, Belgium, Canada, Netherlands, and UK. American guidelines specifically recommend selecting non-pharmacological treatment with superficial heat, massage, acupuncture, or spinal manipulation over pharmacological treatment. Meanwhile, Netherlands and German guidelines specifically mention that analgesics are only used to support patients to return to their usual activity and not as first-line treatment. Concerning paracetamol, 4 guidelines out of 8 recommend paracetamol for acute low back pain, while the other 4 recommend against it. Belgium, Germany, UK, and USA do not really recommend the use of paracetamol for low back pain. Meanwhile, Australia recommended using it while referring that evidence shows that it's no more effective than a placebo. Canada recommends the use of paracetamol as a first-line treatment followed by NSAID. Denmark offered paracetamol to their patients with recent onset of low back pain. So here I'm talking about low back pain without neuropathic component, okay? What are the findings from RCTs and literature review? So again, this is a Cochrane review published in 2016. It states that there is no difference between paracetamol and placebo in the immediate term and short term. There is no effect on quality of life, function, global impression of recovery, and sleep quality. There is no difference between paracetamol and placebo for adverse events, patient adherence for use of rescue medication, and for chronic low back pain, there is low quality evidence for its effects on immediate pain reduction, and there were no trials evaluated for acute low back pain, and paracetamol finally remains the leading cause of acute liver failure worldwide. And I would like to mention here that the new recommendations regarding the maximum dose of paracetamol for chronic pain is 3 grams per day, not 4 grams. Concerning the NSAIDs, all guidelines recommend NSAIDs for acute low back pain. For the guidelines that recommends again the use of paracetamol, NSAIDs are the analgesic of first choice, except in US, where physicians are advised to choose between NSAID and skeletal muscle relaxant based on patient preference and risk profiles. The Danish guideline is the only guideline stating that there is no effect on low back pain is expected of NSAIDs. Netherlands guidelines state that NSAIDs are not expected to be more effective than paracetamol for low back pain. And finally, Australia, Canada, Germany, and the US mentioned the COX-2 inhibitors in their treatment for back pain. If we go back to the literature review, so this is another systematic review and meta-analysis published in 2017, states that 1 in 6 patients experienced clinically pain reduction after the use of NSAIDs, but with increased risk of GI complication. 3 out of 14 studies showed that we have reduced pain and disability, and there is increased risk of GI reaction by 2.5 times. Meanwhile, in chronic back pain, NSAIDs were associated with significant results on pain relief compared to placebo at both immediate and short term. Let's move to talk now about anticonvulsants. While some guidelines clearly recommend against the use of anticonvulsants, others have no recommendation. For example, Belgium, Netherlands, and UK recommend against its use. Australia only makes recommendation about anticonvulsants for those with neuropathic pain. Canada, Denmark, and Germany do not recommend, there is no recommendation for or against prescribing anticonvulsants. And finally, US states that there is no clear recommendation about the use of anticonvulsants. However, it states that insufficient evidence exists to make a recommendation. If we go back to the literature review, Now, we can see that for gabapentin and pregabalin, there is existing evidence for the efficacy of this drug for chronic, there is a limited existing evidence for the efficacy of this drug for chronic low back pain with the association of high-risk adverse events and high costs. Another study published in 2018 showed that when compared with placebo, patients using gabapentin were more likely to report fatigue, dizziness, difficulties and mental problems, and visual disturbance. I would like to remind you here that the approved medical use for pregabalin is basically mainly the diabetic neuropathic pain, post-herpetic neuralgia, partial seizure, fibromyalgia, and neuropathic pain associated with spinal injury. Meanwhile, the only approved medical use for the gabapentin is the post-herpetic neuralgia and partial seizure. And this is also away from the off-label use of this medication for alcohol use disorder, restless leg syndrome, insomnia, alcohol withdrawal, etc. And I would like to stress out also that the bioavailability of pregabalin is 90%, meanwhile that of gabapentin is around 30 to 60%, and that will explain the risk of addiction and the abuse liability that we recently heard a lot about it. So if we do sorry. So if we review the sorry for that. So recently we have heard, no, it's not working actually. So recently we heard a lot lately about the use and the risk of addiction and misuse associated with the use of anticonvulsants. So if we review the literature, we found that Smith et al. Studied this subject, and they reviewed 33 publications from US, UK, Germany, Finland, India, South Africa, and France. And they report that the prevalence of gabapentin misuse in the general population is estimated to 1%. And among misusers of gabapentin, 40 to 60% were having they had a legitimate prescription, and 15 to 20% are persons who abuse opioids. So select pregabalin and gabapentin users may experience a unique combination of psychological and physical effects that are perceived as pleasurable, including calmness, relaxation, good mood, euphoria, or increased sociability. And experiencing this effect may significantly increase the risk of future abuse and addiction to these medications. To this end, governments have been taking action to this. So actually, in 2017, the United Kingdom opted to modify the legal classification of pregabalin and gabapentin from standard prescription to Class C of medication, controlled substance. And the United States FDA has classified pregabalin as a Schedule V substance, while gabapentin remains available as a standard prescription. And this is mainly due to the high oral availability of pregabalin compared to gabapentin. And patients with chronic use of this medication will have some withdrawal symptoms when they stop this medication directly. They may experience anxiety, cognitive impairment, depression, fatigue, diarrhea, nausea, and rebound symptoms. So let's move now to talk about muscle relaxants. Concerning muscle relaxants, Belgium and Netherlands did not recommend the use of muscle relaxants for low back pain. Canada only recommends the prescription of muscle relaxant to patients with acute low back pain upon unsuccessful treatment with paracetamol and NSAIDs. And for chronic low back pain, the guideline from Canada states that skeletal muscle relaxants may be appropriate for symptomatic relief in patients with back pain. The US recommends this medication as a first choice analgesic together with NSAIDs. And they state that the choice between NSAIDs and muscle relaxants should be made depending on the patient's preference and risk profiles. And finally, UK recommends that more research should be done to assess the effect of this medication to back pain. So if you want to go back now to the systematic review concerning the use of muscle relaxant, we found that for benzodiazepine and muscle relaxant, there is clinically significant short-term effect of this medication on pain relief in acute low back pain. For chronic low back pain, the efficacy of this medication still remains unknown, and there is no evidence exists for the efficacy of benzo in low back pain. Concerning antidepressants, so Australian guidelines only makes recommendation about antidepressants for those with neuropathic pain. Meanwhile, Belgium advised against prescribing antidepressants for low back pain and against selective serotonin reuptake inhibitor for those with chronic low back pain, but keeps the prescription for TCAs and SNRIs for patients with chronic low back pain open for consideration. Canada did not have a clear guidelines to recommend for the use of antidepressants for acute low back pain. And Danish and German guidelines make no recommendation for or against prescribing antidepressants in low back pain. And the rest countries recommend against prescribing antidepressants for low back pain. Literature presents analysis on the effectiveness of the use of antidepressants only in case of chronic low back pain. So this is, again, a systematic review published in 2017, states that there is no difference in the effect found between TCAs, SSRIs, and placebo. No association with reduced depression or improved function, but small and significant effects were found only with duloxetine, which is an SNRI. We cannot talk about back pain without mentioning the use of opioids, since as we saw earlier in the presentation, that opioid was the most common medication prescribed in 2013 and 2014 for back pain. So Denmark and USA have general guidelines for opioids. Meanwhile, other countries have specific separation between acute and chronic low back pain. Let's start by Denmark. They only offer opioid for patients with recent onset of back pain. The US, for them, clearly, opioids should be the last treatment to be considered for back pain, and only we should consider it when other therapies have failed. Concerning acute back pain, all guidelines stressed on the use of opioid only if non-opioid analgesics are contraindicated or found ineffective. This is the case for Belgium, Canada, Germany, Netherlands, and UK. Concerning the chronic low back pain, Canada states that we can use opioid, but following unsuccessful trial of non-opioid analgesics. For Germany, we can consider opioid for long-term in case of relevant improvement with minor side effects. For Netherlands, if we want to use opioid, we should use it for a short period, not more than 2 weeks, and when patient is really experiencing severe disability. UK does not offer this option for treatment. The use of opioids should take into account the risk of misuse and drug dependence. So this is a systematic review published in 2017. They found that the risk of misuse due to opioid is estimated around 25%, and the development of drug dependence is estimated between 8 to 12% for patients with chronic non-cancer pain, such as low back pain. What the literature say about the use of opioids? So this is also another systematic review and meta-analysis published in JAMA in 2016. They state that opioids provide modest short-term pain relief. There is no evidence on long-term efficiency, and there is unknown efficacy in acute low back pain. So finally, my take-home message for today. First, there are a lot of differences that exist between guidelines in terms of the first-line analgesic in acute low back pain. Second, paracetamol and anticonvulsants, which have not been shown to be effective in RCTs, are unfortunately still recommended in a number of guidelines, 4 out of 8, which is a lot. In case of neuropathic pain, it is recommended to use the anticonvulsants treatment, but we should be careful for patients who have a profile of substance misuse disorder. Based on the available evidence, NSAIDs and muscle relaxant may be the best possible drug choices in case pharmacotherapy is needed. Only limited evidence exists for the efficacy of antidepressants and anticonvulsants in chronic low back pain, and the best available evidence does suggest a small but significant effect of duloxetine for chronic low back pain. Opioids should only be prescribed as a last resort in chronic back pain. And the American guidelines state that non-pharmacological treatment should be first selected for the treatment of acute low back pain, as most patients will improve regardless of treatment. And misconceptions about back pain and focus on a pathophysiological model rather than the real reason of back pain have been a barrier to successful implementation of these guidelines. As most low back pain guidelines are updated approximately every 10 years, so we don't expect really any major changes in policy or clinical practice or guidelines in the coming years. But if we need to move forward, if we need to do anything in Lebanon, first, I think we should have our own guidelines, taking into consideration patient profile, the availability of drugs in the market, and the lifestyle of our Lebanese population. Second, we should encourage and fund research to evaluate the effectiveness of different treatments in chronic back pain and acute back pain, and steer physicians and patients towards non-pharmacological treatment as the intervention of first choice for low back pain with improved quality of life. For example, we should stress on media campaigns, information websites, patient education, etc. And we should focus more on function rather than pain, and on non-pharmacological treatment rather than pharmacotherapy as a first-line treatment for low back pain. Thank you.
So next will be Dr. Ghassan Kanaza, who will talk about when to refer to pain physician, pain specialist. Dr. Kanaza is a professor in anesthesiology at the department in AUBMC. He's the founder of pain division at AUBMC, strong advocate of evidence-based pain management, and he's now the head of this division. Welcome, Dr. Kanaza.
Thank you. Thank you. It's a pleasure to be here and pleasure to have you all. You know, while I was preparing this conference, I came to this idea of, when to refer to a pain specialist. And I thought that would be a great topic to discuss in this conference. Little did I know that it was one of the hardest topics that I had to prepare because the material is very scarce, and I couldn't find a lot of well-researched information that is up to date. So, but basically, I'm gonna go through this, and tell you a little bit about the history of pain clinic. So basically, John Bonica was the first to come up with the idea of pain clinics. He was basically an army officer and was treating soldiers who had, war injuries. And there was a prevalence of, at that time, what was called causalgia, which now is called complex regional pain syndrome. And, there they were doing just simple, injections to these patients or soldiers, lumbar sympathectomy, and they were doing just fine. However, he noticed a subpopulation of some of these soldiers that required more than just like an injection and sending them home. There were other issues that he needed to refer to specialists, of different medical specialties, perhaps consulting with, physical therapists to look at, improving their function of their legs. And what he realized is that, if he needs to do this was a very time-consuming process. And sometimes like frustrating to get everybody to kind of like work well together. So this is where he came with that idea of a multidisciplinary pain clinic. And the idea here was simply to like get these disciplines together and try to meet, discuss the case, try to like come up with a diagnosis and agree on a treatment. Sounds great, but at the same time, that came with its own limitations to get everybody to come together. So the question was to come up with a one place, everybody is there, one-stop shop, patient comes in and sees everyone. There are more than one type of pain clinic that we are, currently a practice. Basically, there are three types. The first is what we refer to as the single modality pain clinic, and this is what is the most common currently used type of practice, where it is procedure oriented. The surgeon refers the patient for a procedure. I need to have an epidural injection. This is done, and the patient is sent back to the surgeon or to the primary care physician, and they're followed by that. You have little information or interaction sometimes with the patient as far as efficacy of your injection, or sometimes as far as manipulation of medications. It's nice setup, but it really doesn't address the patient as a whole. Issues like physical activity, psychological status, quality of life, none of this are being addressed. Another type of pain clinics that also you will see is what we call the syndrome-oriented or specific, clinics. Now you have this concept of, we have a spine center. So this is just, patients with spine pain will come to the spine center, and they will do, they will have their evaluation for their back, or the headaches clinic is another thing. These clinics, currently are becoming more available. For example, headache clinics are mainly staffed by neurologists. PM&R, physical medicine and rehabilitation are the ones that work primarily with spine centers. And the main treatments that is offered is basically pharmacological treatment, nerve treatments, and physical therapy. They don't address a lot the psychological aspect of pain. This is I think, is the core, of pain clinics. Where this patient has to be addressed on a different level. The multidisciplinary pain clinics, that deals with these chronic pain patients, chronic complex pain syndromes, for example, fibromyalgia, and it involves multiple clinical services, whether it's medical disciplines, psychologist or psychiatrist, a physical therapist, perhaps chiropractors. And patients are assessed at a multi-dimensional level, where we look at pain, trying to relieve pain or the intensity of pain, as much as the psychological status of the patient, physical, and the quality of life. And the treatments is a wide range of treatments that could be, as you could see, sometimes by the time patients come to these clinics, they have been exhausted with injections and sometimes medical treatments. So, the things to stress here is that these are clinics sometimes that deal with patients, to help them adapt with their pain, learn to live with their pain. So, work with, stressing more modification, behavioral modifications, and as a matter of fact, there's a lot of these centers that are involved in, research, clinical trials, and teaching. So basically, as a physician, whether primary care physician or a surgeon trying to refer a patient to a pain clinic, what do you expect? What are their expectations from the pain those pain clinics? Well, a pain clinic should be able to provide a comprehensive assessment of the patient condition. It's just you have to look at the patient as a whole. You can't just say, okay, fine, I'm treating this patient with neck pain and that's it. You have to look for other causes, or what sometimes we refer as red flags, and make sure that none has been missed. Evaluation of the treatment. A lot of times, you could see now the way things are evolving. the pendulum is swinging. You know, before everybody who had back pain just get a gabapentin and you keep escalating the dose. Now we're realizing that pregabalin and gabapentin are something that we have to be careful about because of some of the side effects, and especially, you know, the issue of like addiction. So management with opioids, you know, opioids where you're like, you know, given a dime a dozen, you know, and you can give as much opioids and the sky is the ceiling. Well, I mean, as you have been all aware that, you know, there is problems with, you know, opioids and the opioid crisis, and the CDC guidelines, you know, are all indications that, you know, these are not simple medications that, you know, you can use. A pain physician should be able to handle this and should be able to control and tailor and follow closely with the patient as far as these, you know, medications and adjustments of medications. And as far as interventions, you know, these are things that, you know, not only being done for therapeutically. I mean, yes, you know, we do an epidural steroid injection for, you know, radicular pain. That's fine. But sometimes, you know, we can provide a diagnosis with that, and there's, you know, a lot that will be said on this, where we can identify what could be the pain source or the generator, okay, for that, for the pain. In addition, you know, should not undermine the status, okay, of patients with chronic pain and what this can resolve into. So basically, you know, it is important sometimes to have, you know, self-report questionnaires to assess the patient status, psychological status, and look at their expectations. Are they realistic or unrealistic expectations that we can achieve? And is there a way that we can tell them there's, you know, there's no solution, you need to learn how to cope and put them on some kind of, you know, programs, whether it's, you know, pain management programs or group therapy programs. You know, we are all realizing that there's, you know, the physical condition of the patient and getting them rehabilitated as far as their physical status is one of the most important aspects in treatment of these patients. You know, sitting and waiting for the pain to go will make the pain worse. So this is something that is important to stress on these patients, improving their flexibility, improving, you know, decreasing their limitation. So historically, because somebody like Bonica was, you know, the godfather of pain, you know, or pain clinics, you know, anesthesiologists were kind of like the most, or actually the primary physicians, you know, staffing such clinics. And it made sense because, you know, anesthesiologists are, you know, doing, you know, nerve blocks. And at that time, you know, and that's part of their training, whether it's peripheral nerve blocks or epidural nerve blocks. And, you know, the common practice for, you know, treatment, one of the conditions, or most common conditions, is back pain. So epidurals, you know, yes, anesthesiologists can do the epidurals and go ahead and, you know. So this was the trend, you know, for most pain clinics. However, this thing changed with time, you know. As a matter of fact, I remember when I was at the University of Rochester in New York, you know, we had a fellowship, and I was the first, you know, to have an application or accept an applicant from physical medicine and rehabilitation. And that my chair at that time called me. He was like, "What are you doing?" And I said, "I think, you know, we really need to widen our scope." And this is actually what happened with time. As a matter of fact, now family medicine, you know, PM&R, neurology. There's a lot of, like, this specialty has becoming, you know, is of interest, or this subspecialty is of interest to a lot, you know, of different disciplines. And I think this is good. It's not bad, because everybody will shed, and I'll show you some examples, will shed different ideas on how to deal with pain patients. And moreover, it's now we're realizing that, you know, that we really need to provide evidence-based treatments for pain patients. And this is very important because the field of pain, you know, is sometimes could be lucrative to have anything. And patients, the way they respond, you know, whether it's a placebo response or a true response, you know, and you think like, you know, you're doing the right thing. But it's very important to stress the concept of, and this is going to be the main core of my talk, of evidence-based treatments. I'll give you a couple of examples, okay? Interlaminar, okay, epidural steroid injections. Any patient, comes to a physician, whether, surgeon, primary care physician, with back pain, okay, they're sent immediately for, an epidural injection. And the most common, okay, practice unguided epidural injection, just the way we do it for labor analgesia. Patient is sitting, and we place an epidural, and instead of giving putting a catheter and giving local anesthesia, we give steroids. And you have no idea whether this is a true placement of your needle or where that medication, the steroids, have gone. Well, I mean, there's some literature here that would show you there's two papers, one by White and the other is by Bartinsky. Okay, inaccurate placement, all right, occurs in 25 to 30%, and this is in experienced anesthesiologists. Placing epidurals, 25 to 30%, the needle was not in the right place, okay? Unguided loss of resistance technique, okay, 26%, okay, this is the paper by Bartinsky, 26% of unguided loss of resistance technique were not in the epidural space. Another interesting point to raise is in randomized control, unguided midline interlaminar caudal epidurals, okay, and this is for all types of back pain, okay, all sorts, we're not talking about specific, okay. Number needed to treat is N greater than 90. I mean, this is very, I mean, if you're familiar, one is like, the gospel, this is the way you should go. I mean, 90 is almost close to like placebo. So. And as far as the thing I mentioned earlier, pain physicians, yes, they can provide some diagnosis. Many times, we have, because of the familiarity of doing nerve blocks, we can go ahead and specifically target a nerve, whether now it's, especially now with ultrasound guidance, you can be assured. And many times, you can sometimes help. Okay, radiculopathy, that we thought this is the cause of the pain, and the surgeon is not convinced, so we went in and did a selective nerve root injection, and based on our results, we told the surgeon we don't think this is the cause of the pain, so we spared the patient from L5, okay, disc decompression, and the surgeon was happy with that, and I think the patient realized that this would be a surgery. Another situation we'll be talking about this later, and I'm going to on this, is like, facet joint injections and the ability to diagnose, okay, axial pain due to facet-mediated pain through diagnostic injections, okay? This is an important concept. This is actually the reason I put this slide is just not to discuss the study, but this is a study by Kaufman in 2013, where there was more than 2,000 patients received single injections, okay, for radicular back pain, L5, L4, L5, and S1, okay, injections. And what they looked at is, okay, the percent responders, okay, after those injections. I want you to keep attention, pay attention to the time here, okay? So the first group was, they received an injection within 3 months. The second group, 4 to 6 months. Third group was 7 to 12, and so on, all right? This here is your percent responders. Patients receiving their injection within the first 3 months had the best response rate, 60%, okay, of these patients had good response rate, versus, close to like 30% or 40%, okay, if it's, it's way down. So very important that once you identify, okay, a patient that you feel that they are not responding, okay, in this patient for their back pain, is to refer them before you start having dealing with the chronicity of this pain. This is also like from Marvel, where they looked at patients that received brief the brief cognitive behavior management program, a short program of cognitive behavioral therapy, and patients with acute pain, okay? And what they found is that those that were in that program, where their pain duration is less than 8 months, they're significantly better than those, okay, that had, okay, more than 8 months. So the duration will affect your outcome. So and that's something to keep in mind. Another interesting, this is a meta-analysis by Fluoro, and what they looked at, they compared the treatments provided by different clinics, and what they found that there was significant advantage for multidisciplinary and multimodal, okay, treatment packages offering unidisciplinary and unimodal treatment. So you have to have, you know, not just like, you know, take through this pharmacological medication or injection. You have to combine them together along with physical therapy and perhaps psychological therapy. This is also talking about the evidence, you know, being familiar with the evidence, you know, behind what you're doing and working on evidence base. This is a study by Price in 2005, and what they looked at is patients with chronic back pain, okay, randomized study, and they randomized them into two groups. One received unguided interlaminar injections, and the other received placebo. They went in, okay, and they injected only saline in the interspinous ligament, okay. This is what's important here. You know, there was no benefit over placebo in functional assessment, return to work, or need for surgery. So basically, whether you do an unguided epidural or a placebo, you know, there was no difference between these two groups. More importantly, okay, this thing that we would like always think about, you need to have 3 injections, okay, before you can decide whether your thing is going to get better or not. Benefit, they found that there is no benefit in 1 or 3, okay? And the other thing is that the quality adjustment, okay, last year's threshold, which looks at basically the effectiveness of treatment as far as, you know, getting the clinically functionality. This is the money spent will give you, you know, adequate outcome or good. Another thing, you know, just like we had it in Lebanon, you know, back in the early 90s, everybody that does this, okay, will get a bypass, okay? So everybody that does this ended up with an epidural. And the idea here was, and this is just to show you the numbers, okay? This is 1994. Okay? So basically, this was 550,000 epidurals in 1994. And this is basically 2001, okay? They went to about like 2 million epidurals done. It's not uncommon, okay, to have, fine, I jump on a treatment if this treatment is fine. But you see, you have to make sure that this treatment is first justified and you're getting the government spent in 1994 24 million, okay, on epidurals. Before you, this is Medicare. Medicare means like نحن كيف نقول وزارة عنا تقريبا. Okay, this is the idea here. It went to 175 million. Okay. You can imagine that, you know, the money wasted if this is just as we were doing, just unguided epidurals and so on and so forth. Another example, okay, facet joint injections. Well, facet joint injections became like, you know, a great fashion to do. This is basically from the year 2000. Excuse me, I couldn't get the slide. From the year 2000, look at this sharp rise until 2006. Until somebody came down, which basically was the legislative body, and said, listen, we're spending too much money on this. We need to put some guidelines. And as you can see, this is where they said, okay, it's a joint injection. You have to be done in a certain way. It has to be, we'll talk more about this later in our talk. And these are controlled blocks. If this works, then, you know, then we can proceed based on the outcome to treatments. And then see what happens. We taper, so it's no more shrinking out. Very important. This is where the importance of pain physicians can help in the improving the cost effectiveness. McQuaid extrapolating data, okay, on Canadian data from on chronic pain patients, concluded that the use of pain clinics, okay, resulted in a direct health service savings equal to twice their cost. So there is some cost benefit. Treatment of patients of neuropathic pain, this is studied by Crombie, showed that patients referred to pain clinic with neuropathic pain resulted in lower visits to their GP and more effective treatments. Third, in 2002, compared patients with chronic back pain referred to either surgery, whether they had spinal cord stimulation or intrathecal program with delivery pumps, to multidisciplinary program centers. And the results showed that, yes, surgery, spinal cord stimulation, and implantable drug delivery systems do have some benefit, but these come at an extremely high cost. Compared to the multidisciplinary pain clinic, they were significantly more cost-effective than the rest. So there is some cost effectiveness or some cost benefit with multidisciplinary pain centers. So in closing, the guidelines, referral guidelines I'd like to share with you to pain specialists. First of all, you have to realize who are you referring to. Not all pain clinics are the same, as we talked earlier. Modality or procedure-oriented versus multidisciplinary. Not all so that's something to think about before you refer to your pain clinic. Early referral is an important concept to keep in mind that will have reducing the cycle of pain and increasing the incidence of chronicity of your pain and helping with deconditioning. Sometimes, establishing the diagnosis, okay, if you can shed some light as pain physicians to establish diagnosis and help with the management, okay, maybe through a procedure for treatment, and many times, as primary care physicians or surgeons, they feel like, they are like overwhelmed with these patients. The term we use here, sometimes it's not very nice, but get this patient off my shoulder, I need some help for this patient, this is where I think, pain patients and pain clinics will be of help and provide advice. Dealing with patients with intractable pain, yes, this is where you can go that extra mile with invasive procedures. Managing their pain, and learning how to live with their pain through, cognitive behavioral therapy, group therapy. And thank you. This will conclude our first session, and I would like to open the floor for for questions. And each microphone.
This is an excellent morning to hear all these things. واللكتشر تبعتك الحقيقه كثير حلوه لانه فرجتنا انه مش كل واحد بيقدر بيعمل بين مانجمنت. والشيء اللي عم بيصير انه الكرونيك بين مانجمنت عم بتصير من الفيلر تبعت الاكيوت. نحن لما عملنا الجمعيه تبعت معالجه الالم بنقابه الاطباء كان في كرايتيريا انه واحد لازم يكون عمل بالقليل سنه يقدم اوراقه لوزاره الصحه ولنقابه الاطباء لحتى يقولوا انه هذا بيعمل بين مانجمنت، يعني مش كل واحد بيعملها. لسوء الحظ كتار اللي بيعملوها والحق على السنتر اللي هو فيه. يعني البيج سنترز بضل في عنده نقوانين، بس السمول سنترز ما عنده نقوانين ليقولوا هذا بيعمل بين مانجمنت وهذا ما بيعمل. هذا شيء واحد اللي لازم نحن نرجع له، لازم نرجع نشدد. شيء ثاني المصاري اللي عم يقبضوها كثيره. وعم بيعملوا مرتين وثلاثه لحتى يضل في عندهم مرضى ويضل في عندهم. والشيء اللي ابشع من الكل مثل ما انت قلت تفضلت انه في حكمه كثير ما عم بيعملوا ريفيرال للبين كلينيك يعني لهالمحل سبيشالتي لانه this is private medicine. فيمكن نحن علينا حق البيج سنترز انه نعمل ريجوليشنز سبيسيفيك ريجوليشنز لحتى نمنع هالابيوز هذا. ثانك يو.
say about the, you said once or 3 times it's the same to do an epidural infiltration. They are same. Me, if it's an acute pain, actually, and the patient is not on gabapentin or something, it's first time experiencing that pain. If you got located, most locations are problems, and they have many anticonvulsants and referral. I don't see one injection is enough. So I go for 2 or 3. Only in the case we got an acute first attack, I go for 1 is okay. This is my experience. That question was talking about the myofascial principle. Do you use ultrasound on localizing the points?
Recent advances in medical imaging, yes, show promise in this regard. So basically, we have studies showing that ultrasound and magnetic resonance elastography can identify specific features of trigger points. But you know, the cost and availability of these modalities prohibit their use as, you know, the practical use.
Exactly.
So basically,
Nowadays,
they are being used only for so far for research purpose.
We are using ultrasounds. So you localize the points. We should localize the points. You should hit it. And I think, according to my experience as well, the dry needling has no effect at all. Whenever you use first what I do actually, I do use the lidocaine first time, second time lidocaine. And if you had more pain, I use Botox. This is what I do actually.
Okay, so
I use the dry needling. There's no effect at all. Because when you got the patient in your clinic and you use the lidocaine, he's okay. He will say it's okay immediately. So
yes,
can you tell us the difference between the dry needling and the lidocaine?
Yes, basically studies show that they are equally effective on the long term for the management of the myofascial pain complaints. But basically, maybe lidocaine injections are better in terms of reducing the post-injection soreness that's usually more severe with dry needling. So that's, I think, the main advantage of lidocaine injections over dry needling.
What do you use?
And studies showed this.
What do you use?
I personally use dry needling, and I find good effects so far. And I shared with you a lot of studies that showed similar effects on the short and long term. But I can tell you that, yes, post-injection soreness is worse with dry needling and less with lidocaine injections.
Okay, thank you very much.
Thank you.
Thank you for the very nice lectures. I have one additional comment to what Dr. Jalbout said. Basically, I think that in the waiting for really more structure and guidelines, I mean, legislation in Lebanon where it can address this issue of whoever wants to do pain is now doing pain, we have a major role, and I think one of the answers to this big problem is what we're doing today, is to educate physicians and to share evidence-based practices, which can also address some of the concerns that you've mentioned. So basically, many would come and say that they are doing this and that, but we have a role of educating physicians to go by evidence-based practice, as in any other specialty. Maybe the pain medicine is a little bit lagging behind, but we should emphasize our role of educators in this field, and this will address some of the concerns. If you know to whom you should refer, part of the problem will be solved. This is what I think. And really, we should stick to evidence and try to tailor our practices according to evidence. So, and another question for Dr. Fadila Naji. What about acupuncture? Where is the evidence in non-specific low back pain? I know that you have interest in this, and you didn't mention at all during your lecture
yes,
if there is any evidence behind it.
Yes, thank you for giving me the opportunity to talk a little about acupuncture. I had a limited time, basically. So let me make it a little bit simple. or share with you the findings of an interesting study published in 1977 that was conducted at McGill University. It compared the locations of common locations of trigger points and common acupoint locations, and actually the researchers could establish 70% correspondence between common trigger point locations and common acupoint locations. And this maybe suggests that even if dry needling and acupuncture were discovered independently and labeled differently, they may at least share some similarities. Now today, dry needling is considered one of the aspects of Western medical acupuncture, which is an adaptation of Chinese acupuncture using current knowledge of anatomy, physiology, and the principles of evidence-based medicine. So dry needling today, for example, I do what's called dry needling, acupuncture dry needling. So basically, I use acupuncture needles to needle the trigger points. So if you want to make it simple, it's today one of the aspects of the WMA or Western medical acupuncture. Yes, we have the same Cochrane review I shared with you also showed that we have a very good level of evidence on acupuncture effectiveness, mainly on the short term for chronic lower back pain, but also we have some studies showing good effects up to 6 months. So that's it basically. So again, some similarities, maybe different nomenclature. So dry needling and acupuncture may share some similarities, and the evidence so far, yes, is similar.
Thank you.
Thank you.
I just want to have a small comment before your question. Yeah, I think that the problem that going back to the same issue is that when we are providing certain treatments in pain medicine, okay, we have to make sure, okay, that we are following the outcome and documenting these outcomes and making sure that, you know, this is based, okay, on proper documentation, and to look at that, you know, whether we're doing the right thing, helping or not, you know. And, you know, I'd like to tell you, you know, in the famous words of Deming, in God we trust, for everybody else, show me your data. Show us data that shows, you know, that this procedure is helping, and I think that will be the way to go. Otherwise, you know, the future is coming where insurance companies are going to tell you, you know, you have a good outcome, you get paid for your procedure. You have a bad outcome, I will not pay you for this procedure. So it's very important for us as physicians, as whether pain or other, you know, to make sure that we are outcome-oriented and making sure that we are documenting, okay, this, you know, in a scientific way. Yes, we have a question.
Yeah. Again, thank you for the nice lectures. And I have a few comments for Dr. Neji and for Dr. Yammout. First, Dr. Neji, concerning the missing, it was not only the muscular exam, it was neurologic exam that was missing, that can show sometimes if there is any radiculopathy.
Neurologic exam? Yes, yeah. I mentioned that it was unremarkable in the beginning. So okay. In our patient, in this clinical scenario, the neurologic exam was unremarkable. Yes, definitely, it is very important. It's part of the physical exam, yes.
And about the joint and the bone exam also?
Yes, definitely. So it just
because it can show facet joint disease that can be one of the most common cause of lower back pain.
Exactly, definitely, yes, I agree with you. And that's why I mentioned that her physical exam was unremarkable. So you don't, I had just 20 minutes to present the whole thing. Okay. So the summary of this was that her physical examination, including the neuro exam, the joints exam, was unremarkable. Yeah, good. Definitely.
Concerning the antidepressant agents,
yes.
If we review the literature, usually they are not efficient for non-specific lower back pain unless there is a depressive component. If the patient presents depression with the non-specific lower back pain, they become indicated.
Yes, that's why I stressed on the concept of central sensitization, because yes, that goes in line with what you are saying. Yes, definitely. So maybe they are more helpful, as Dr. Yammout also said, in similar cases. I agree. Yeah.
Right.
Not all antidepressants actually, through studies and RCTs, stress out mainly on about the effectiveness of SNRI, specifically duloxetine, in back pain, and it can enhance or affects better the pain component rather than the depression. That depression will not be affected, but it can improve the pain. I would like to stress out on another important thing that we didn't mention yet here also, is about the impact of management, whether it is interventional or non-interventional, to the quality of life of the patients. Because I think this should matter first for us as a physician and for the patient to stress about quality of life other than what treatment to give to our patient. So this is what was also lacking in our assessment.
Right, right. And concerning, Dr. Yamout, concerning the listing of Belgium, Australia, and other countries, I would like if you see what is your guidelines at AUB in the management of pharmacologic treatment?
Actually, since on AUB level, we don't still have clear guidelines. Every physician do whatever he sees he's comfortable to do that. But unfortunately, I think if we need to move things forward, we need to work on the national level and we need to have a clear Lebanese guidelines regarding this. But for now, we don't have any clear recommendation. Each physician will do upon his way to do. Thank you.
All right, we're going to have a coffee break and we reconvene at 11. All right? Thank
Sorry.
I'll hold that. It's a three-handed thing.
That'll be hard.
Chase down there. Chase it down.
Done. Okay. You check.
Test, test. Yep, yep, yep. Yep. I'm going to show a lot of images in my talks. Is it possible to dim the lights in the front of the room? Perfect. Thank you. Remind me, I need to give you the... More than once I've walked off stage with it.
It's time saving if you have yours and the others are rotating.
Okay, welcome for the second session, and I'm glad everybody is still, perky and ready to go. Good. How are you, Yusuf? I would like to start the second session by introducing a person that has been with us for the last week, and tell you that it's been a pleasure knowing him, and I have to say that it's been, 6 years? This is through the efforts of Dr. Al-Yahshushi that I got to meet this great man. And he's been with us, working with our residents, with workshops, and agreed to be a speaker in this conference. And in appreciation of all his efforts and dedication, Dr. Maroon, myself, and Dr. Yahshushi would like to present you with this small appreciation.
Thank you so much. Thank you so much. I appreciate it greatly.
And now, if you want to, I'll just introduce you. Dr. Timothy Moss is a professor of radiology from the Mayo Clinic, and he's also has developed in the last probably 15 years or so an interest in pain, and specifically like spine pain. So, and he's worked on, he has a number of publications, and he's also the president of the Spine International Society, a society that was established back in the late 80s, and they basically concentrate on interventions for spine and specifically evidence-based interventions. Dr. Moss will start with the first lecture, which is now a little bit changed from what you have on your program. The first lecture is going to be on the rational use of imaging in a spine patient. And the second lecture is about planning for transforaminal injections and the use of MRIs will be the third lecture. So just note that. Tim?
Well, thank you very much. It's a pleasure to be here. My enduring thanks to Dr. Al-Yahshushi, Dr. Kanazi, and Dr. Maroon from the Department of Anesthesiology. I'm now here as a representative of the Spine Intervention Society. We have an active collaboration with the AUB Anesthesia Department as an educational venture to provide training for for their anesthesia residents. And I think it's been a very positive endeavor, and I look forward to doing it over the next several years. So we're going to talk first here about rational use of imaging in the spine pain patients. There we go. So first, let's think about why do we image the back pain patient? It's important to remember the primary role of imaging is the detection of underlying systemic disease, tumor, infection, spondyloarthropathy, fracture. Do we know how common that is as a cause of back pain? Well, we do have pretty good data on that. In a patient who presents to a primary care facility with back or leg pain, about 0.7% of those will have metastatic cancer. Only 1 in 10,000 will have a spine infection. Osteoporotic compression fractures are pretty common, about 4%, and about 0.3% will have a spondyloarthropathy. And how good are we at detecting that systemic disease? Well, we're really good, particularly with MRI. And we have likelihood ratios up close to 30, and our negative likelihood ratios are also very good. We're very good at ruling those conditions out. The challenge we have, though, is that the low prevalence of systemic disease as a cause of back pain implies that most of the findings we'll see on imaging will be so-called degenerative changes. And that's going to lead us to specificity issues, which we can see in terms of degenerative findings, in quotes, in asymptomatic subjects, degenerative findings in populations greatly in excess of back or limb pain, and the proportion of degenerative findings in painful populations versus controls. We'll also have a sensitivity issue with imaging in terms of dynamic lesions. And finally, usefulness or validity. Can imaging predict the clinical course of back or limb pain? And can it predict the response to therapy? So let's look at some of those questions. First, specificity. I'm going to show you now a table of all the major studies over the last 20 years examining the prevalence of so-called degenerative imaging findings in asymptomatic subjects. And there have been a lot of studies going all the way back to simple radiographs back in the 50s to many studies using MRI. And if we look at disc degeneration, meaning loss of disc space height or loss of T2 signal on an MRI, it's ubiquitous in an asymptomatic population. And where it's stratified by age, it becomes more and more prevalent as an asymptomatic finding with age. Disc herniations as well. They're ubiquitous, they're extremely common in asymptomatic individuals. I would suspect that 50 to 60% of the people sitting in this room have disc herniations, and everyone in this room has a dark disc on a lumbar spine MRI, and hopefully very few of you have back pain. So the prevalence of disc degenerative change in young populations, there's some population studies. These are done in Scandinavia. At age 13, 20% of children will have so-called disc degeneration, loss of T2 signal on an MRI. When you get to age 15, it's 30%. When you get to age 18, it's 40%. When you get to the young adulthood, it's just about 50%, and nearly 20% will have multi-level change. So we can't call this disease. It's not a disease process. It's a normal process of maturation and aging. If we look at other imaging findings, if we look at cervical discs, there is only a correlation with symptomatology at the C5-6 level, not at any other cervical level. Cervical facets, asymptomatic versus symptomatic populations in terms of the prevalence of facet arthritis, no difference. If we look at lumbar facets, even stratifying it by age group, when we see so-called degenerative change or arthritis, there's no difference in populations with or without back pain. If we even take it a step further and really categorize that osteoarthritic change with CT, and then we anesthetize those facets with placebo-controlled blocks, there's no difference in the CT grade of arthropathy between painful and non-painful joints. So these imaging findings simply don't correlate with pain. And finally, we get to the level of systematic reviews. This was done in 1997, so this data has been out there for a long time, looking at all the data from high-quality studies, and there's no clinically significant association between back pain and simple so-called degenerative changes. And we should probably stop using the word degenerative. Rather just call them age-related changes because that's what they are. Now, how about these? If we talk about specificity here, we can kind of summarize this, that imaging findings of cervical or lumbar disc so-called degeneration have no correlation with back pain. Imaging findings of cervical or lumbar facet arthritis have no correlation with back pain. The only correlation with age, so we'll call them age-related changes. Disc extrusions, severe central canal stenosis, and direct evidence of neural compression are more likely to be symptomatic. But there has to be a concordance, a correlation of that pain syndrome and what you expect an imaging finding to manifest for you to even suggest causation. There's an important caveat from that, that if this need for concordance suggests that concordance between the imaging observation and the pain syndrome to suggest causation has a consequence that me as the imager, if I'm the one looking at this MRI study, I have to know the nature of that pain syndrome if I'm going to put a rational interpretation on it. So how is that information going to be communicated? There has to be either a robust electronic medical record with good documentation about what that patient's pain syndrome is, or an intake document at the imaging center with a pain diagram, or heaven forbid, the radiologist actually talks to the patient. And that's what I advocate to my trainees. You know, talk to the patient. They'll tell you where the problem is, and then interpret the MRI. Now, we also have a challenge on the sensitivity side. You think if we have we have a big challenge on the specificity side, maybe we're really good in terms of sensitivity. But we do have a challenge in that we know that neuroclaudicatory pain is exacerbated by extension positioning, which we all have to assume as we stand upright, and also axial load. We know from anatomic studies that the cross-sectional area of the lumbar spinal canal, the lateral recess, and the neural foramina diminish when we go into extension and axial load, and the same thing holds in the cervical spine. And here's a little bit different in the cervical spine, and the cervical spinal canal is maximal in dimension in the neutral position, and then we go into flexion, it'll diminish, and we go into extension, it diminishes even more. So it's a very dynamic phenomenon. So in both cervical and the lumbar segments, recumbent imaging, which is how we do most advanced imaging, the patient is comfortably lying on a CT or an MRI couch, might be insensitive to dynamic lesions that only show themselves when that patient assumes axial load and a physiologic posture of lumbar extension or cervical extension. Here's an example. This patient had neuroclaudicatory symptoms. Here's the CT myelogram, and I would submit it's pretty hard to say there's much trouble with this CT myelogram. A little bit of ligamentum flavum thickening here, I think we can see right there at the L4 level, but that central canal looks wide open. What happens? 5 minutes later, we stand that patient up, and then we swing a C-arm and generate a data set when they're upright, and then reconstruct that. Now we have severe central canal stenosis. So that's 5 minutes later, highly dynamic phenomena, and this is repeated again and again. When we're looking at imaging, we have to think about this as any medical test, and there always has to be a risk-benefit analysis before you order a medical test. And what are some of those obvious benefits? Well, sure, we can identify systemic disease. We can demonstrate neurocompressive disease that might require intervention. Certainly, there's value in demonstrating the absence of sinister pathology if we provide reassurance and stop any other workup. And we may identify the structural basis of a chronic pain syndrome. And then we can define a specific, when we have a specific diagnosis, then we can impart a specific therapy, because we know non-specific therapies tend not to be beneficial. We also have to think about some of the risks or harms that are part of imaging. One of the things to be aware of is, what is that patient going to see when they read their MRI report? And our patients all read their own reports now. They're going to find out they have degenerative spine disease because that radiologist is going to use the word degenerative. And there's nothing good about a degenerative phenomena. It's a downward arrow. I mean, you don't recover from degenerative processes. So now they're not just someone who got an MRI. They're a patient with a degenerative spine disease in their mind, unless we explain to them that those findings are not necessarily germane. Certainly for X-ray-based imaging, there's radiation exposure, cost to the patient and society. And one thing we might not think about is provocation of intervention. Those images are really powerful. They affect our decision-making, whether the evidence says they should or not. There's evidence in the literature that early MRI imaging tends to lead to more surgical interventions despite equivalent pain and disability profiles when compared with non-imaged patients. If you look at the rates of CT and MRI utilization across the United States, that variation correlates exactly with surgical rates of decompression for central canal stenosis. When we image something, we think we have to fix it and we intervene. So in a highly imperfect medical marketplace, and I'm talking about the US, imaging tends to provoke interventions that may have little evidence basis. So this has already been invoked in this conference, and this is the mantra I use all the time. Treat the patient, don't treat the images. So how about the validity, the utility of imaging? So what's the utility in the acute presentation of the patient with back or limb pain? Well, we do have evidence. Roger Chow in The Lancet in 2009 did a meta-analysis of all the ARC CTs, comparing immediate imaging with radiographs, CT or MRI versus purely clinically directed care. And there was no difference in pain or function in imaged versus non-imaged patients in either the short or long term. And they concluded that imaging in the acute low back pain patient really isn't valuable. Mike Modick did a very nice study in 2005. He tried to correlate the relationship between disc herniations and patient presentation and outcome. And there's no relationship at all between the extent of a disc herniation and the presenting signs or symptoms. The type, size, or location of a disc herniation at presentation or change over time did not correlate with clinical outcomes. Small discs can be symptomatic, large discs can be completely asymptomatic. And they emphasize that surgery is a clinical decision. MRI might help you in planning that surgery, but it should not be the defining feature in deciding whether surgery is necessary. That should be defined by the patient's situation. And psychosocial parameters much more strongly predict functional disability than anything on imaging. So here, as a radiologist, I'm telling you to ignore some of what I do, but we have to recognize that in the back pain scenario, it's often just not that valuable. Don't overutilize it. Repeat imaging. It's extraordinarily common. As I look at our medical record, we see MRI, MRI, MRI on the same patient. Very commonly performed. In one recent study, more than 50% of low back pain patients had had previous advanced imaging within the year. In prospective studies, however, new findings are extremely uncommon. They tend to be relatively static. So you can only justify repeat imaging if there has been a clear change in that patient's clinical scenario. There has to be a new symptom or a major exacerbation of a symptom or finding to justify an additional imaging study. So what are the imaging recommendations from the American College of Radiology? No imaging in acute low back pain except when there are red flag features, which obviously seek to identify those patients who do have systemic disease. From the American College of Physicians and the American Pain Society, imaging should not be obtained in nonspecific low back pain patients. It should be performed when there's severe or progressive neurologic deficits, or you suspect that they have red flags suspecting systemic disease, or in patients who have neurogenic claudication or an active radiculopathy, and who can undergo an intervention, whether it be minimally invasive or surgical. If you can't do anything about it, then is it valuable to do the imaging test? And here is a little more robust recommendations from the American College of Physicians. Immediate imaging with radiographs occur when the patient presents with risk factors for cancer. With MRI, if there are risk factors for infection or signs or symptoms of Cauda-Equina syndrome. Otherwise, a month of conservative care, and then radiographs if their pain persists and they have risk factors for an inflammatory spondyloarthropathy or compression fracture. An MRI if they have radiculopathy or evidence of neurogenic intermittent claudication, and if their pain resolves, no imaging. Or if they have prior imaging and there's no change in their clinical status. So this is a plea to use imaging in a more rational and evidence-based sense. So you should ask as a clinician, as a provider, am I putting my patient at risk by avoiding imaging in these settings? And is there evidence? Well, there's good evidence both in retrospective trials and in prospective trials, and now in systematic reviews that when you follow these guidelines, you do not place your patients at risk of missing a major systemic disease. So do we capture patients with serious underlying conditions using these guidelines? Yes. So in summary, the primary role of imaging is the identification of undiagnosed systemic disease. It has a significant specificity fault. There's a high prevalence of asymptomatic age-related degenerative findings. The significance depends on concordance. There's got to be a fit between that imaging finding and what that patient presents with. And to make that imaging interpretation valuable, the imager has to know that, that syndrome. Spine imaging can be insensitive to dynamic lesions. No imaging is indicated in the acute presentation of back or limb pain unless there are those red flag features. You have to make a calculated risk-benefit decision when you're going to order that imaging test. We do know it correlates poorly with clinical presentation and course. It tends to be overutilized, and as spine professionals, it's our responsibility to try and change that overutilization. So thank you very much. As a member of the Spine Intervention Society, I'd certainly invite you to come to our European Congress. It'll be in the end of May in Munich. We'll look forward to hopefully some of your presence there. Thank you very much.
Our next presenter is Dr. Christine Yashoushi, graduated from Department of Anesthesia at AUB, followed by fellowship in the Interventional Pain Management at UH Western University in Cleveland. Active as international pain societies, served as an educational board of Spine Intervention Society, and recently appointed as instructor in this society.
Thank you, Dr. Shamandi. Thank you, Dr. Timothy Moos, and for the Spine Intervention Society for providing evidence-based medicine. So I'm going to talk today about the epidural steroid injection, the efficacy and safety in common practice. So we don't have any evidence to support epidural steroid injection to treat localized axial pain, but we do have abundant clinical and experimental evidence that radicular pain requires both neural compression and inflammatory reaction, and therefore the emergence of epidural steroid injection to treat patients with radicular symptoms, since it has an inflammatory reactions. We have clinical evidence of inflammatory component where not doing anything. So we do have clinical evidence of inflammatory component in patients with radicular pain, where usually the large disc herniation may be asymptomatic, and you all know that surgical relief of a neural compression is sometimes not clinically successful, as well as conservative therapy is often effective. We do also have experimental evidence that of an inflammatory component, where the natural history of disc herniation is resorption, and the introduction of nucleus pulposus into the epidural space will induce nerve dysfunction, even without any traction. So to access that epidural space, we do have a lot of way to access the epidural space. The traditional approach is the interlaminar approach, where we access the epidural space between the lamina. And doing this, we're putting the medication or the therapies in the posterior epidural space, dorsal, where the actual needle is, and this is not where the pathology is. Historically, it used to be unguided, where we do it in a similar way as we do it for OB anesthesia. However, we don't have any evidence that unguided interlaminar injection are putting the medication in the right spot. And actually, as Dr. Kanaza mentioned in a previous slide, 26% of the unguided loss of resistance are not in the actual epidural space. And therefore, we don't have any evidence to support the effectiveness of unguided interlaminar epidural injection beyond 3 to 6 weeks. We do have evidence for short-term term benefit, and the evidence are conflicting and of low quality. However, if we see here when we're doing a guided interlaminar approach, the spread from a dorsal to a ventral epidural space is usually in 36 to 51%. لا عندي على اللابتوب طبيعي. جربي غير السلايد شو بركي يتصل. بركي حطي سلايد شو بركي لأنه من ماك على خلص كيف هيك اتركيها هيك بلا بون ما لا اتركيها خليني ارجع اجربها خلص اتركيها. So just to summarize what we were talking about, so we do have evidence that radicular pain has a component of inflammatory disease. Therefore, the emergence of epidural steroid injection to treat patients with radicular symptoms. No evidence at all to treat patients with localized low back pain where there is no reason for an inflammatory process. And to access that epidural space, we have different way. We can do it through the traditional way, which is an interlaminar approach, similar to what we all do in anesthesia, which is accessing the epidural space between the lamina, putting the medication posteriorly. And in the past, we used to do those procedures also for patients with back pain. We used to do a non-unguided procedure. Nowadays, we don't have evidence for an unguided procedure in the practice of pain medicine. And a matter of fact, we can see that the spread from the dorsal epidural space to the ventral epidural space occurs only in 36 to 51%. And we cannot rely on this number when doing procedure to relieve patients with pain. However, we do have some evidence when we're doing an interlaminar and we go a little bit using the lateral parasagittal approach, not the midline approach, that sometimes we can get to the ventral epidural space, especially if we're doing it at L5, where the fat will facilitate the movement of the drug from the posterior to the ventral epidural space. And in this small study, we did see that when comparing the parasagittal approach to the midline approach, we do have spread from from dorsal to ventral spread in 89% using the parasagittal approach in comparison to 32% when using the regular midline approach. So, but what we still have indication for the regular interlaminar injection. I'm talking about guided interlaminar injection whenever we need to access a foramen, but the foramen is really stenotic or is full of bone graft, or the access is impeded by instrumentation, or we have any anatomical changes that will forbid the access. And it's preferable to use a lateral parasagittal approach instead of the midline for the reason to put the medication ventrally, not posteriorly, as I showed in the previous picture. So a more like specific way to deliver the medication to the epidural space was developed, and it is the transforaminal approach, where we're putting the medication through the foramen and directing it to where the pathology is at the interface between the disc and the nerve root. And we can do this using the subpedicular or supraneural approach, placing the needle directly above the nerve, or using the infraneural approach and putting the needle below the nerve at the level of the disc. And this depends on what we have on MRI, which approach is better, and which approach is allowed by the anatomy of the patient and the nerve root. And when we're using the supraneural approach, the traditional subpedicular approach, usually we will get like a cephalad flow. However, when we're using the infraneural approach, especially at L5 level, the flow will be caudal and will cover also the S1 level. So it really depends on what we have on the images and on the symptoms of the patient to decide which way to go. So what are the indications did not respond to more conservative therapy, as Dr. Yamout and Dr. Naji before mentioned, or patients who are not a surgical candidate or they want to delay or postpone the surgery. This slide was previously discussed by Dr. Moss. We need images to plan the injection or to rule out any like serious underlying disease, but we don't go and do images for all the patients with back pain. What about the efficacy and effectiveness of transforaminal epidural steroid injection? In a review by Bogdach in 2013, including 12 observational trials, 5 pragmatic and 6 explanatory trials, he really showed that with patients with radicular symptoms due to disc herniations, transforaminal are not placebo's injection. They do work up to 70%, achieving more than 50% relief of the pain. They spare healthcare consumption, and they are a cost-effective procedure when they are done using appropriate guidelines. So looking at those patients, 55 patients who were scheduled for surgery, so they have, the surgery was planned and they failed all conservative therapy. Those patients were randomized either to receive marcaine or bupivacaine plus steroids before going to the surgery using a transforaminal epidural injection. And they noted that following those patients a year after this, a patient who received steroid, not only local anesthetic, only 29% of them actually went to surgery. So the other 70% were spared from surgery. However, a patient who only received local anesthetic, 66 or 70% of the patient actually went to surgery. So showing the subsequent studies to Bogdach review, Dr. Kennedy at Stanford University randomized patient with only single-level herniated nucleus pulposus and radicular symptoms, and he did see at 6-month follow-up that 70% of this patient really responded to the injection, and 65% of those patients had better functional recovery. In a similar way, Dr. Moss and his team at the Mayo Clinic included all the patients, not only patients with single-level herniated disc, included patients with disc herniation or bony lateral recess, fixed lateral lesions, or foraminal stenosis. And looking at the response here, it's a little bit less, since not only single-level disc herniation was included, and 46% of the patient had less pain 6 months after, and 41% had better functional recovery 6 months after. And this, as Dr. Kanaza mentioned before, if you capture patient before in the acute or subacute period, they will do better when undergoing an injection. So what are the determinants of efficacy of our injections? So the degree of neural compression is an important criteria. Getting patient early before they have central sensitization is also an important factor. And the most important thing is the delivery of the medication to the correct spot. So if we're doing the right injection or not, and getting the medication to where the pathology is in the right level. So when is reasonable? We're talking about repeating the injection or doing like 3 or more injections. When is reasonable to assess the patient and see if he needs another injection? Should we do the injection and follow up on the patient the next day and decide if he needs to go to surgery or not? So we looked at the data at the Mayo Clinic, including 3,645 patients undergoing lumbar transforaminal injection. And we did see that the immediate response directly after the procedure with patient having sensory block or motor block directly after the procedure is a poor indicator of what the patient will be 2 months from the injection. What really correlated with the 2-month response was the 2 weeks response. So it is important to follow up on the patient at 2 weeks after the injection because at 2 weeks, the response of the patient will correlate with the longer-term relief. So in summary, for the efficacy and effectiveness of epidural steroid injection, we don't have good evidence of unguided interlaminar injection to be practiced nowadays. Image-guided still have some place, especially if the transforaminal axis is blocked. And when you're using an image-guided interlaminar, it's preferable to be lateral, to do a lateral parasagittal interlaminar rather than a midline interlaminar. The robust support is for transforaminal epidural steroid injections for patients with radicular symptoms. And the strongest evidence is for disc herniations. And we have a greater effectiveness for patients with subacute, acute pain rather than chronic patient. We can assess the patient and decide if they need another injection or if they need to go to a more invasive procedure at 2 weeks from the procedure. So what about those injections? Are they safe? Is it safe to perform a transforaminal injection? Some of the practitioners will decide to go to do an interlaminar because it's a safer procedure. So we looked at the safety of these transforaminal epidural steroid injection because in the state we did have 16 reported cases of paraplegia following transforaminal injection, where we postulated an embolic etiology, meaning that we're putting the drugs in a radicular artery, occluding the vascular supply of the spinal cord. So we looked at what can potentially cause these cases, and we did a non-inferiority study using the Mayo Clinic data, including 3,645 patients undergoing transforaminal epidural steroid injection, mainly at the lumbosacral junction, L4, L5, L5S1, or even S1, for patients with radicular symptoms with or without radiculopathy, comparing patients receiving non-particulate steroids such as Decadron or particulate steroids such as triamcinolone or betamethasone. It was a non-inferiority study that concluded that the non-particulate steroid dexamethasone was non-inferior to other particulate steroids. It was a non-inferiority study. However, at the same time, the Stanford University, Dr. Kennedy was conducting a randomized controlled trial that showed similar result, that the non-particulate steroid were of equal efficacy and safety than the particulate steroid. After those studies, the guidelines were to use non-particulate steroids such as Decadron in the cervical area specifically, and to use it at the first therapy. And if the first injection failed, the practitioners were allowed to use a depomedrol or particulate steroid after the second injection. I'll skip those slides. Okay, so following those case reports of catastrophic complication, we can't really rely on case report to assess the safety of an injection. What is more needed is doing large series of consecutive prospectively collected data to document all the adverse events. So we're still looking, are these injections safe or not safe to perform? And we again looked at the data at the Mayo Clinic, including 16,000 this time, 638 transforaminal injection and interlaminar injection performed at three institutions, the Mayo Clinic, University of Chicago, and University of Pennsylvania. And we looked at the immediate adverse event reported by the patient and the delayed event reported at 2 weeks or later. And we did see here that including all these injections, we didn't have any major complication, such as neurological deficit or intraspinal hemorrhage. We did have some minor complication, such as vasovagal reaction, which was the most common reported complication. As well as for the delayed event, we didn't have also any major complication. We did have also some minor complications, such as vasovagal reaction or central steroid effect. So looking at around the 20,000 injection done, we didn't have any major complication. Only minor adverse event for approximately 2.4%. so we concluded that those injections are safe, and there is no valid reason to prefer interlaminar access rather than transforaminal access. So is our data supported by the literature? That we did have other studies comparing, like looking at the safety of those injections. One study done at Europe included 52,000 injections. 22,000 of those injections was using the lumbar, was a lumbar transforaminal, the other 10,000 was interlaminar. And they looked also at the immediate and the delayed complication, and only looking at those 52,000, only we did have 0.02% of procedure-related complication. The other were drugs-related complication, and none of these complications were major. So for the procedure-related complication, we can see that we did have more complication when using the interlaminar approach, like CSF leak and 6 lumbar, 1 cervical. We did have the major complication with 2 interspinal or epidural hemorrhage, and also you can see here it was with the interlaminar approach and the caudal approach rather than the transforaminal approach. We did have infections with 2 caudal and 2 lumbar interlaminar approach. None of these were reported in the transforaminal approach. So in conclusion, like looking at the safety and efficacy, we can conclude that transforaminal epidural steroid injection, they are more effective, and that when they are performed by evidence-based medicine, they are also safe. We looked at more than 15,000 consecutive injections, didn't have any major complication. And when there is no difference in the safety and major difference in the efficacy, I don't think any suspicion why to prefer the interlaminar approach rather than the transforaminal approach when treating patients with radicular pain.
Dr. Maus will be presenting the necessary role of advanced imaging in planning transforaminal epidural steroid injection. Thank you, Dr. Maus.
I'll just hold it.
Done. What?
So we've talked about imaging in the back pain patient and realized that there's significant caveats to using imaging, and we should use it sparingly and with careful thought. But when patients fail conservative therapy, then we're going to think about doing an epidural injection, as Christine has just been talking about. MRI needed. So now so the question at hand is, if we're going to do an intervention, an epidural steroid injection, do we really need to have an imaging before that? Is it worthwhile to do an MRI on every patient that we're going to do a transforaminal injection on? So let's kind of look at what the evidence shows regarding that. So this is an issue of diagnosis preceding therapy. Epidural injections, as Christine has mentioned, do have demonstrable efficacy and effectiveness in treating radicular pain. Radicular pain is a symptom. A pathoanatomic diagnosis causal of that symptom is desirable prior to instituting an interventional therapy. Why? Because, as we've talked about, some of these are going to be due to systemic disease, and we want to know about that, and we want to ensure the safety of our therapy, and we want to ensure the efficacy of our therapy. So systemic disease, we mentioned that. It's a relatively uncommon cause of patients who present with back or limb pain. But once they've failed conservative care, the American Pain Society, the American College of Physicians, and the American College of Radiology think it's appropriate to do an advanced imaging study prior to an epidural intervention. And these are just examples of patients who presented with back or limb pain with no systemic features, and they had metastatic cancer, leukemia with complete loss of all the fat signal in the marrow, or here dural ectasia in a patient with ankylosing spondylitis, or pyogenic discitis, again, who had no systemic or constitutional findings. In terms of safety of therapy, fluoroscopy images cortical bone. We're using fluoroscopy as our guidance tool most of the time for epidural injections. And because it images only cortical bone, it can assess the critical epidural, the target epidural space. Is it critically stenotic? If we're doing a transforaminal, is that foramen critically stenotic? Is it a good idea to put a needle in that? And we also have to think about the vulnerable structures in the way between the skin and the target zone that we might put our needle through. In the cervical region, the vertebral artery, the cervical plexus, the brachial plexus, the exiting nerve. And in the lumbar spine, the exiting nerve, the thecal sac, potential meningeal cysts. So advanced imaging allows the operator to plan a safe and efficacious approach to the epidural space. Otherwise, you're simply flying blind. Here's such an example. A referring physician here requests a C6-7 intralaminar epidural steroid injection. Say this is all you had. You just look in the medical record, all you've got is this lateral radiograph. Should you go ahead and just do an epidural at that C6-7 level? Well, let's just compare it to another patient's lateral view. And if you look carefully, you realize here at the back of that articular pillar here on your index patient, there's no lamina back there. The spinous process is sitting right on the articular pillar. In the normal state, you have a nice long length of lamina. So this is a patient with a congenitally narrow canal. If you didn't recognize that, something really bad is going to happen, because this is that patient's MRI. There's no room to do a C6-7 intralaminar at that level. It would be dangerous. So you need to have that advanced imaging to make sure you don't do something that'd be extremely unpleasant for all. As a matter of fact, the FDA Safe Use Initiative demands that for cervical epidurals that the operator examine advanced imaging prior to any epidural procedure, and simply should not be undertaken without that examination to make sure there's room for that needle placement. Another example, a patient with intractable left shoulder pain. EMG shows a left C5 radiculopathy. The radiologist reading this didn't really say much. So you're going to walk in this procedure room and put a needle in that C4-5 foramen. Well, maybe you should look at that MRI really carefully and see that there is a tortuous vertebral artery in that foramen. That's probably the cause of their radicular pain, not a disc. And putting a needle in there is likely to give you a vertebral angiogram, potentially embolization to the neuroaxis, a bad thing. So you need to be looking at that advanced imaging. Because we don't, in the lumbar spine, we don't want to be putting a supraneural needle when there's a nerve right in the way, as we see here, or we don't want to be putting an intralaminar needle in a very tight central canal. Something bad is going to happen. Now, how about efficacy and effectiveness of therapy? We have to be segment specific. Dr. Elyashoushi has talked about the need to deliver the medication to the target zone. And we know that clinical identification of what segment is causing the pain is not very good. Even the correlation between surgical findings and the patient's symptomatology is not good. EMG is not very good, N+1 or N-1 in terms of the segment. So what you have preoperative or pre-procedure without imaging is just not very specific. We also know there's a challenge with vertebral enumeration. We like to think we live in a world where everybody has 7 cervical, 12 thoracic, and 5 lumbar vertebral bodies. But on the odds, about 10 or 15 of you sitting in this room don't have that number of spinal segments. And if you don't know that going in, you're not going to know where to put that needle. There's a significant variability in the number and distribution of thoracolumbar vertebral bodies. And we also know that when you have transitional anatomy at the lumbosacral junction, that's going to change the segmental innervation of myotomes, and that's going to change the pattern that your patient presents with. So you need to understand these things to know where to put the needle. Transforaminal efficacy depends on putting the anti-inflammatory agent on the target, the interface of the compressive lesion and the neural element. And Dr. Elyashoushi showed these papers as well, and they tell us that we've got to put the medication in the right space if we're going to be effective. In the absence of imaging, the operator really can't know what segment to target. The rational use of transforaminals requires knowledge of the segment involved, the nature of the compressive lesion. If it's a synovial cyst causing this, we might want to rupture that cyst, not just do a transforaminal. We need to know the degree of compression so we can talk to the patient rationally about the prognosis of this intervention and consider safety considerations, and the ease of access to that target nerve. So this is really an individualized medicine phenomenon. And this is what makes it fun. This is why I enjoy doing epidurals, because every case is different. I tailor every intervention based on what that anatomy allows me to do. Just as an example, say this patient has an L4 disc and an L5 radicular pain syndrome, and we're going to do a transforaminal. We've got a lot of choices where to put that needle. We could put it infraneurally at the level above. We could put it at the level of the target nerve, above the nerve, supraneural. We could put it behind the nerve in a retroneural position. We could put it below the nerve in an infraneural position. We could potentially put it at the level below at S1, or we could do that lateral parasagittal interlaminar. So we've got a lot of choices to deal with, and we have to make rational decisions about which tool we're going to pick up. So, and each of those tools is going to have a little bit different flow pattern. Christine touched on this. The supraneural tends to have dominant cephalad flow. The infraneural tends to have more caudal flow. Retroneural is a variable, probably most likely representing supraneural. So the needle above tends to be flow upward. And we actually have that quantitated. It takes about 3 cc's to 95% of the time reach the superior aspect of the disc above. Retroneural, we don't have much data, as we said. Infraneural, we have more data, tends to go caudally above a bit above L5, and then at L5 it really tends to go caudally, and sometimes won't even cover that L5 nerve. It'll only cover the S1 nerve. Kim et al. Here, we're using 1 cc at the L4 level, using an infraneural L4. 90% of the time it'll cover the L4 nerve, and 10% L4 and L5. Doing it at the L5 level tends to go down, and you may only cover that S1 nerve. So here's that infraneural pattern at L5. And then we have our S1 injection, flowing cephalad to cover that S1 nerve. So we've got a lot of tools at our disposal with different flow patterns. Now we've got to pick the right tool for the right anatomy. And again, this has been quantitated by Dr. Furman and colleagues. About 2 cc's of injectate 100% of the time is going to reach the medial aspect of the pedicle, and 3 cc's is usually going to reach the disc above. So these are all the tools. Now you got to plan how to use them. And then you have to make intraprocedural decisions when you see that flow pattern and decide, is it working? Is it not? Maybe you got to pick up another needle, go to plan B, sometimes plan C. So always walk into the room with plan A, plan B, and plan C by looking at that imaging. I think the key anatomic feature is what's that lateral recess. That's the conduit of medicine from the foramen down into the ventral epidural space. And if we kind of focus on that, looking at some imaging, that'll help us make reasonable decisions. If the lateral recess is patent at the level of a herniated disc, then I'll do an infraneural at the level of the disc pathology. And I'm going to show you lots of pictures. If the lateral recess is occluded at the level of the disc pathology, then I might do supraneural at the level below. If that foramen below is not in such a good state, then it gets a little more complex, but that's where the fun comes. So a couple examples. Here's this patient has a right L5 distribution pain. We can see that L4 disc herniation here coming down. But we look at this lateral recess, and it's pretty wide open. That kind of begs us to do an infraneural at that level. And if we do that, here the epidural gods smile on us. We do an infraneural, and that comes nicely down, covers the lateral recess beautifully right there. That's where the contact zone between that L4 disc and the L5 nerve is going to be. We've covered the target. Life is good. They're likely to do well. And the contrast all stays ventral. In contradistinction to that, this patient also has left leg pain in the posterior thigh and calf, an S1 distribution. But here we have a disc osteophyte complex. And the idea that we're going to put a needle right there and hope it's going to flow through there into the central canal seems a little far-fetched, not likely to happen. So we're not going to use an infraneural at the level of the pathology. We're going to do a conventional S1, bring it up from below, and we do indeed do that, and we reach the target zone with our flow pattern and hence our medication delivery. Another example here, a left L5 radicular pain pattern. The lateral recess here is not really ideal. It's really filled with disc material, as you can see right there. So that's probably not a great approach. So we'll use a supraneural below. It comes up, and we cover the target zone quite nicely right there. So we're making rational decisions based on that lateral recess. Foraminal disc disease, here we've got a disc herniation back into the foramen. We can see it's pushing the dorsal right ganglia up right there. It's jammed up under the pedicle. So maybe doing a supraneural approach there is a bad idea. But there's a little bit of fat right behind that nerve, as we see with the yellow or gold arrow. Can we target that? Sure we can. And we're going to do that in infraneural approach. And there we get a very nice distribution. And you can actually see outlined here, there's the dorsal right ganglia as a negative defect in the contrast pool. So we know we've covered the target quite nicely. And it's all ventral. That's where the pathology is. Is there evidence? We mentioned the evidence earlier about reaching the target zone. How about evidence for having or not having an MRI? It's curious, Dr. Cohen here, we've had several debates on this issue, some published, others in live presentations like this. And he actually published a paper saying you don't need an MRI, but he buried the lead in his paper. He has the data saying in his paper that you do need an MRI. He just chose not to emphasize it. If you have the data you don't like, you put it in table 4 and put it down at the bottom. But these were patients who all had MRIs, and then they were randomized to either the operator gets to look at it or not. It simply has to make a choice based on symptomatology. And if you look at those patients who had an anatomically correct needle placement, the categorical responder rate was 41%. If you look at those who were anatomically incorrect, the response rate was only 23%. I would suggest his study is simply underpowered because it wasn't significant, but his response was, oh, it doesn't matter. I think it's just an underpowered study, and he's got the data here suggesting that you really do need to put it in the right place. So in summary, advanced imaging is necessary prior to epidural injections to assure the exclusion of systemic disease, safe avoidance of vulnerable structures, and target-specific delivery of an anti-inflammatory agent to the preganglionic nerve in the ventral epidural space. Essentially, it's a question of whether you wish to rely on luck and the fates, or you wish to make a rational plan to do a procedure to maximize its safety and efficacy. If you choose no, realize that in the United States, that places you in opposition to the American Pain Society, the ACR, and the ACP. If you have an adverse event in that situation, it's really not defensible. Thank you for your attention. And I'm going to continue with the next talk.
Yes. CT. Yes, CT. 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 Okay. It's CT versus fluoroscopy and spine injection. Pros and cons session.
So this was to be a pro and con with one of my radiology colleagues from AUB. Unfortunately, he had a health issue and was not able to be here, so I am both pro and con. So I'll put on one hat and then the other hat. So I'm going to start out with my fluoro hat. And realize, as a radiologist, I have access to both fluoro and CT, so I try to make a rational choice as to which is the desirable modality. But I'll try and present you with the case for either fluoroscopy as a guidance tool or CT as a guidance tool. So what's the case for fluoroscopy as the preferred guidance tool? The advantages of fluoro are pretty evident. It's inexpensive, it's accessible, it provides effective guidance for the vast majority of procedures. In terms of safety, there's less radiation, it's less radiation intensive than CT. It does provide real-time guidance, allows you to detect vascular flow, and it's very flexible. You can get very complex angles, and using a down-the-beam approach, following a needle parallel to the X-ray beam, you can work out very complex trajectories out of the axial plane that you're restricted to with CT. Accessibility and cost, there's about a 10-to-1 differential in capital costs for fluoro versus CT, so it's much more cost effective. Maintenance costs are certainly far less with fluoro than with CT. And fluoroscopy is ubiquitous. You go to your ORs, there are fluoroscopes sitting, C-arms sitting everywhere. They're generally present. They're part of training programs for multiple specialties. There's a general awareness of how to use a C-arm. And that's less common with CT that tend to be restricted and walled off in radiology departments and sometimes jealously guarded in radiology departments. In terms of effectiveness as a guidance tool, I work in a radiology department at the Mayo Clinic. I can access either one I want, and I can make that choice. As an example of a published study that we did looking at lumbar transfemoral epidurals, we use Fluoro guidance in nearly 99%. We had the choice to use CT, but we didn't need it in the vast majority of circumstances. When did we use CT? When there are anatomic barriers, bone graft, instrumentation, deformity, body mass. All the supporting literature is really based on Fluoro-guided interventions, so there really isn't a literature base for CT-guided interventions. The CT literature really falls short. In terms of efficacy and effective guidance, one of the advantages of Fluoro is it gives you real-time ability to assess the spread of an injectate in the longitudinal axis as it spreads cephalad and caudal. As we said, that's critical to understand, does your medication reach the target zone? If you've got a CT up and down a little bit, that's going to take more time and it's going to take more radiation dose. As an example here, this patient has an L4 disc herniation. It's affecting the target nerve, so we're going to do an L5 supraneural approach here. If we do that under CT guidance, we're not going to be at the level where we want to see where we want to see that the injectate reaches. We have to do additional scanning, and that's going to take some additional dose. Whereas with Fluoro, a planar imaging modality where we can look in a significant cephalocaudal dimension, we can accomplish that all. And we can understand its three-dimensional distribution by taking images in both frontal and lateral planes and realize it reached the target. CT is more radiation intensive. That's certainly an argument in favor of Fluoro. We did a study at the Mayo Clinic using a model phantom setup and said that the assumption was we're going to exclude vascular filling. That's one of the critical features of imaging. And we're going to say we're going to use like a 5-second Fluoro run to exclude vascular filling, or a 5 seconds of digital subtraction imaging, or 2 CT fluoroscopy acquisitions. And we'll talk about using CT to exclude vascular uptake in a few minutes. We looked at the differential in dose between those 3 mechanisms of excluding vascular filling. In the lumbar spine, if you went from just fluoroscopic observation to DSA, depending on the manufacturer, it increased the dose 2.5 to 4 times. If you went to CT Fluoro, it increased the dose 8 to 14 times. In the cervical spine, similarly, when you went to CT Fluoro, it increased the dose 19 to 34 times. Now I'm making the case for Fluoro here, and I'll show you the other side of that story when I put on my CT hat. The magnitude of that dose is about 160 to 280 microsieverts. That's the actual magnitude of increased dose that you incur when you choose to use CT versus Fluoro. Safety, Fluoro does provide real-time guidance in terms of detection of vascular flow. Sorry, a little funky there. CT guidance tends to be overrepresented in systematic reviews of catastrophic embolic cord injuries, and that's probably really a failure of radiologists to really pay attention to excluding vascular filling. You have to use very specific CT techniques to do that. Vascular uptake is relatively common in epidurals. It occurs about 13% in the lumbar region, much more common in the cervical region. With Fluoro, it occurs about 20% of the time. With DSA, almost over 30%. That has specific spatial and temporal characteristics, and you can identify that very clearly with Fluoro. That vascular uptake might be out of plane if you're using CT, and you might not detect it. Here's just an example of what we can see with Fluoro and how exquisite it is. If we look at this very carefully on this injection, if you look over here, you're going to see some venous filling late in this injection, which would otherwise be a nice injection, but there's venous filling going up there, which renders it less than ideal. Another example here during a cervical transforaminal. Again, we have the ability to look at this real time and then review it, and we can see that looks pretty nice, but then as we continue on, we're going to see venous filling out here very shortly. So that'd be a less than ideal injection. This flexible down the beam targeting with fluoro allows us to get complex trajectories that might be unobtainable with CT. And we'll show you some examples of that. Here's a good example. This patient has an L4 disc herniation. We can see the little herniated disc right there, a little caudal migration of that disc material. And this lateral recess is stenotic. We can see that on the MRI. We can see that on the CT. So the challenge here is we want to target the L5 nerve. And this is at a transitional segment. And here's the CT on that patient in straight axial images. How in the heck am I going to get at that L5 nerve in a straight axial plane? It's up there. It's pretty darn well protected by bone in a straight axial plane. Unless I have a drill, I'm not going to get there in a straight axial plane under CT guidance. But this becomes a relatively simple case with fluoro where we can construct a complex angle going from cranial to caudal and get right next to that nerve, as we do every day in the fluoro suite. Here's another example, a C1-2 lateral articulation. I target these fairly frequently in patients who have pain with head rotation. And on CT, the joint is this little lucency there, and under in the direct axial plane, there's really not a way to get there under CT guidance. But with fluoro, it looks quite nice. We can get there very easily using, even in this complex circumstance with all this hardware, and we can get to here and see filling of that C1-2 lateral articulation. So fluoro can be a very powerful tool when utilized carefully. So the summary for the fluoro case, it's accessible, it's cost-effective image guidance for the vast majority of interventional pain procedures. CT might have a role in challenging anatomy, but the operator has to be aware of its shortcomings in detection of vascular uptake, characterization of spread patterns along the z-axis, and lack of flexibility for available trajectories. So that's the fluoro case. Now I'm going to put on my CT hat. So fluoro's good, it's bad. Now we're going to say CT is good. So what really makes the case for CT as a guidance tool? And again, I use that on a regular basis, but I try and use it selectively when I need it because it is more expensive. And it's just a tool. It shouldn't be glorified because it's a fancy device. It's just a tool. It's just another hammer. We got to decide where's the right nail to utilize it. It shouldn't be applauded or condemned for being a fancy technology or being accessible or inaccessible. We just got to figure out when do we use it correctly. And really, its successful use demands a knowledge of its strengths and weaknesses, and it's the decision-making of the operator, not the tool, that's also ultimately going to define success or failure. So what are the advantages of multi-slice pulse CT fluoroscopy? And realize this is a very specialized form of CT where the tube is constantly spinning. I hit a foot pedal and I get multiple images in a half a second displayed on a monitor in the procedure room. So it's very much like fluoro in that the acquisition of the image is just as fast as it is with fluoro. It's not real time, but it's quasi-real time. Multi-slice CT fluoro has superior contrast resolution. The target and all the vulnerable structures, including those which are soft tissue, can be visualized with CT. So if there's something in the way from skin to target, I'm going to see it. Whereas with fluoro, all I see is bones. Contrast material is far easier to visualize. We're looking at axial plane guidance. It's not a planar modality, so we're going to see all those things between skin and target. And it does indeed give us 3 dimensions of guidance. Fluoro gives us 2. We have to swing to a different view to get that 3rd dimension, whereas CT gives us 3 dimensions with 1 acquisition. And here's how that happens. When we get multiple acquisitions with one tap of the foot pedal, we can now track this needle across multiple slices, and that allows us to track it in the cephalocaudal axis, and we have direct visualization of its dorsal ventral and right-left orientation. So with just one quick glance at multiple slices, I know exactly where that needle is in 3-dimensional space. And this is how we're standing in a CT fluoro suite. I have the monitor there, the foot pedal is there to acquire the images, and I can handle all the CT-based controls under a sterile cover, so I can essentially act just like a fluoroscopy-based for the physician. I don't need input from anyone else. I can handle it all right there. Vascular pacification, we talked about this a few moments ago as an advantage for fluoro. Well, there is a way to identify it with CT, but you have to be careful about this. realize that vascular opacification, how do you recognize it in any imaging device? Well, it's got a spatial appearance and it's got a temporal behavior. On fluoroscopy, that spatial appearance is it's going to look like a branching tree. It looks like a vascular bed. But that also has a temporal behavior. It washes out over time. So we can use those two characteristics, apply them to the CT environment, and we can detect vascularity as well. So on a CT slice, it's going to be any dot or a line that you can trace over multiple images that's present while you're injecting contrast and that goes away as soon as you stop. And if you see it, you know you've got vascular filling and you need to change the needle position. How do you do this? You acquire a multi-slice acquisition while you're injecting contrast. You stop, then you hit the pedal again and acquire immediate, 1 to 2 seconds later, when there's no contrast injection, anything that was there and gone is vascular. You got to fix your needle position. Here's just a kind of a artist rendition. Say if I'm in the lumbar spine and I were so unfortunate as to inject the radiculomedullary artery, in a planar image, I would see the characteristic hook-shaped radiculomedullary artery, and we would see CT images that we could then understand what we're seeing, and then a second or two later, it would fade away. So we just have to bring that information into a cross-sectional imaging environment, and we can understand what we should see. And indeed, we talked about the rate of vascular detection with fluoro as being fairly significant. But if you do this acquisition using CT, we can detect vascular uptake just as well as you can with fluoro. And here's an example doing a cervical transforaminal. This is the pre-contrast injection. Then during the contrast injection, there are all these tiny little arterial structures light up. And that means I'm going to have to change that needle position. I change the needle position and now inject contrast, and we have beautiful flow into the foramen. And when I wash that in with lidocaine, now we can see distribution into the ventral epidural space quite nicely. We talked about radiation dose a few minutes ago as a big advantage for fluoro. Well, yes, indeed, there's more exposure with CT. But we have to be if we're thoughtful about how we use CT, we can minimize that exposure. The vast majority of the radiation exposure occurs in an initial acquisition for you to do your planning. And if you really restrict that planning just to the target zone, you can significantly restrict the dose, because when you're using multi-slice pulse CT fluoro, that dose is very minimal, either for guiding the needle to the skin, from skin to the target, or to excluding vascular uptake. And again, we did this radiation dose study, and I just told you a few minutes ago as the fluoro advocate that, boy, there's all this additional radiation with CT, but you have to say, what does that mean? And sure, yeah, there's an additional 140 microsieverts, but that's 2.5 to 4 orders of magnitude below any known biologic effect. Yes, there's more radiation. Does it have any biologic effect? Not that we can measure by any stretch of the imagination. It's orders of magnitude below any known effect. In terms of efficacy and effectiveness, CT gives us really great anatomic target specificity. I can know with certainty my needle tip is exactly where I want it, but the literature documenting that that's useful is really pretty sparse and of low quality, and it pales in comparison to the fluoro-guided literature. There's only been one really good pragmatic trial on cervical transforaminals with fluoro versus CT fluoro guidance, and there was a greater response rate with the CT fluoro guidance, but it stands in isolation. There are no other really good comparative effectiveness trials of fluoro versus CT fluoro. In terms of safety, as I mentioned, CT is overrepresented in case reports of bad things happening. However, there are no significant complications that have been reported in pragmatic trials or case series. And as Christine mentioned a little bit ago, we did, in that large series of transforaminal injections, all of our cervical transforaminal injections were done with CT guidance, no major adverse events. So when would we use CT guidance? Again, this is kind of much, you're going to get the same story as I said at the end of the fluoro version of this. In lumbar epidurals, we're going to use fluoro for the vast majority of the times, but we're going to revert to CT when we've got instrumentation problems, bone graft, anatomic anomaly, body habitus. A couple of examples. Here we've got this big intertransverse bone graft out there, trying to get a needle under fluoro guidance around that barrier is going to be a bit of a challenge. If we look at the CT, we can see that there's a lateral recess compromise the arrow is pointing to. How can we potentially get to that target? Well, if we can make a needle do that, the yellow arrow there points to the dorsal ganglia of the target nerve. So can I make a needle do that? Sure I can. There it is. And there's the needle tip right next to the target. There's the target nerve right there. We inject contrast, and we see contrast flowing around the target nerve. Another example, these are really just two pictures. This is all subcutaneous fat. This patient could not go on my fluoro table because they weighed over 400 pounds. They would have broken the carbon fiber table. But I can put them on a CT scanner safely and get a very, very long needle and target this L4 disc herniation. We use all of a 7-inch needle there. But when we inject contrast, we can see it nicely outline the target nerve and go into the central canal we see here and treat that patient effectively. No way to do that with fluoro. So other reasons where we would use CT, when the target tissue is uniquely demonstrated in the axial plane. Extraspinal nerve blocks have blocked the cranial nerves using CT guidance. PARS defects, we can do that with CT guidance. Synovial or meningeal cysts, sometimes we can decompress with CT guidance. And in patients with CSF hypotension where we want a targeted installation of fibrin glue in the central spinal canal, CT is a great tool for that. Pudendal neuropathy, another example where CT guidance can be extremely helpful, and we can very precisely place the needle and then fill Alcock's canal right along the obturator internus muscle. CT is also valuable when we have vulnerable structures that are only demonstrated on cross-sectional imaging. When we look at this patient and you're asked to put a needle in, in that tight foramen, you better be asking yourself, where's the vertebral artery? Well, there's the vertebral artery, and I would not even think about going into that foramen under fluoro guidance because I need to know that my needle is not at that vertebral artery. Even intralaminar injections can be well done under CT guidance because here we can directly see the ligamentum flavum. We can see that there's a little bit of fat deep to it, and we can construct a vector that doesn't point at the cord. So if I overshoot here, I'm not touching the cord. And as we did there, we can see nice distribution into the epidural space. So in summary, multi-slice pulse CT fluoro gives us 3-dimensional guidance, whereas only 2 with planar fluoro. Allows detection and exclusion of vascular uptake if you do it the right way. You have to be meticulous about it. It allows visualization and avoidance of critical structures, the vertebral artery, the spinal cord, the spinal nerve. It allows guidance with radiation doses that are not that much different than planar fluoroscopy, and the difference probably isn't biologically important. The literature support, there is literature support for efficacy and safety, but it's very minimal, and it's not in the same league as what we have with fluoro. And its utility, we're going to use it when there's difficult anatomy, rendering fluoro not really operative. When there are vulnerable structures that are unseen by fluoroscopy that are going to be in our trajectory, we want to avoid them. And we thank you for your attention. So make your choice. I think there's a role for both, and I choose both at varying points in time based on the anatomy. What's the right thing to do for the patient? It's a tie. It's whatever's most appropriate.
Thank you, Dr. Maus.
Happy to answer any questions.
عندك question انت؟
يمكن نبدأ هون
لا لا questions بعد.
هذا تبعك. هو تبعك انا. هذا تبعك انت؟ لا هذا تبعك.
Okay, thank you. First, I want to say thank you very much for a very comprehensive symposium. I'm here because I'm a patient. What about ozone injection? I did it 3 months ago and I'm better. Ozone. Because I was scared from the steroid side effect like osteoporosis. Because it is very close to the bones. The steroids you are injecting is very close to the bones.
endocrine side effects from epidural steroids are a concern. For single doses or limited doses of corticosteroids, the systemic effects that potentially could exacerbate osteoporosis are probably minimal. I think the challenge occurs when there's repeated utilization, and that's as we as practitioners and we see these patients and realize that corticosteroids are utilized by multiple specialties, and if you're going to think about cumulative steroid doses, then you better look to the interventional pain aspect of the medical record. You better look at orthopedics. You better look at family care, family practice, because they all might be doing steroid injections, and that cumulative steroid dose then can be significant. But if we keep the dose, if we are thoughtful about the utilization of the dose, I think the risk is modest at best. I'll talk a little bit about ozone this afternoon when we talk about disc disease, and I'm glad you're better. That's a wonderful thing. But in terms of is there evidence that ozone is effective? Not very strong. But I'm glad it's better for you.
4 years. I have 1,800 patients. I have 300 patients. I did article about ozone versus cortisone transforaminal. And if you review international literature, ozone effective more than cortisone transforaminal. If we treat the patient, our goal to give him maximum help. Yes, if you go transforaminal, our goal to reduce inflammation. But we forgot about the ganglion. When I go there, at the same time, I'm doing ozone or cortisone, and I do ablation of the ganglion. This maximum effect for patient. If you tell me only transforaminal, I don't believe, because it is maybe it gives help, but not maximum help.
So you're talking about ablating the ganglion
ablation
with
of the
what?
nerve roots, ablation of the nerve roots, and transforaminal ozone or cortisone.
What are you ablating it with?
Frequency ablation.
With pulse RF or with
yeah, pulse.
Okay,
Pulse
I've reviewed all the pulse. I would not put stock in it, frankly. I apologize for saying that, but I reviewed all the literature. There is no high-quality literature supporting pulse RF.
Yeah, there is many articles about it.
There are many articles. But
if you want to resolve the patient problem, you should decide and put a diagnosis. If there is this, you should put if degenerated, ozone. If not degenerated, we can give
I respect your opinion, but I don't have the literature to support that.
Okay, thank you.
So I have a question. If the compression is due to malignancy for cancer patients, so is there any additional place for CT better than fluoroscopy to use if you want to do injection for this kind of patients, category of patients?
Sometimes I do that fairly frequently in cancer patients because there's often neoplasm in the way. There's been previous interventions in the way. The anatomic layout is more complex. So not just because it's a cancer patient, but because the anatomy is more complicated. The challenge, obviously, is we don't have something that has a positive natural history, and corticosteroids will be at best of limited durability. But that's where one of the exciting things is that corticosteroids have had about a 40, 50-year run with interventional pain, but I think their day is done or will be done soon. But there are many new highly targeted agents that are in the developmental pipeline, some of which my lab has been working on, and I think you're going to see neuroablating agents using highly targeted biologics that will take the place of corticosteroids within the next decade.
For the translaminar steroid overall, I mean, in your practice?
So my practice is very limited to Dr. Moss' practice, but sometimes whenever I feel like I cannot access the foramen, like it's a last resort, I do a guided interlaminar lateral sagittal. So if you want like an accurate percentage from a big database, Dr. Moss will be more helpful.
In our practice, it was in the one study, it was about 1% for lumbars. It's realized that it's more rational to do an interlaminar in the cervical region. The challenge in the lumbar region, you've got this big dorsal fat pad, and the medication may never leave that. It may not get to the ventral epidural space, whereas in the cervical spine, the epidural space is so small that delivering it dorsally is much more likely to travel ventrally, and it's a more rational application in the cervical region. The other reason it's more rational in the cervical region is what are we dealing with causing cervical radicular pain? 80% of cervical radicular pain is foraminal stenosis, not disc herniations. And that means it's harder to deliver something on the outside than going through a stenotic foramen. So in the mix of epidurals in the cervical spine, we use interlaminars. The majority of transfemoral is a higher proportion of interlaminars in the cervical region.
So, what type of steroid do you use? What's your
For steroids, you use dexamethasone. You don't use except dexamethasone. What is the dose? Which dose?
10 milligrams.
10 milligrams. In the cervical and the lumbar? In cervical and lumbar regions?
You must remember that sometimes the pathologies can happen at different levels, sometimes bilateral. This is one indication to perform translaminar. To decrease procedure time and avoid the patient multiple breaks, we can do translaminar injection with one single break to treat multiple levels and sometimes bilaterality.
We're doing a lumbar transforaminal. I'll do a test injection with 2% lidocaine, 10 milligrams of dexamethasone, and then clear the needle, make sure it's distributed. And that's all. I don't use any additional normal saline. I'm doing an interlaminar. Then I'm going to use some normal saline to try and distribute it. The negative advantage as well.
We don't have here the 10 milligram, we do the 8 milligram.
يلا have a seat please. خلينا نبلش السيشن بعد الظهر. Welcome back. I hope you are not drowsy now. Our speaker is again Dr. Ghassan Kanazi. He's been introduced before. It's enough to say that he is the founder of pain medicine at AUB. And let me remind you that he is an American board certified in anesthesiology, pain medicine, and critical care. Dr. Kanazi will be speaking about lumbar facet joint pain, diagnosis and treatment.
Thank you.
Ghassan, the floor is yours, Habibi.
Thank you. Thank you, Nadeem. And I hope everybody is ready for another session or this afternoon. هذه كيف تركب يا شباب؟ Okay. All right, set. Okay. The topic is going to be about lumbar facet. So basically, what the idea was, in the morning we talked about radicular pain as our back pain with radicular component, and now the session is going to be more about axial pain and the different pathologies that could be that cause axial pain. So the zygapophyseal joint, or what we refer to as the Z joint, okay, is a potential source of mid and low back pain. And interventions have been known to decrease, okay, this facet pain. As a matter of fact, facet joint injections are the second after epidural injections for pain procedures that are performed in the US. The history of the Z joint as being a back pain, I just went back to the 1900s where somebody by the name of Goldthwaite, was the first to say that this could be a potential cause of back pain. Actually, Gormley in 1933 was the first to coin the term facet syndrome, and in 1963, Hirsch was the one to show that if you provoke that joint by injecting hypertonic saline, you can produce back pain, low or axial back pain. In 1971, Rees was the first to look at denervating the Z joint and as another way to relieve the back pain. And it wasn't until 1979, until Nicholas Bogduk described anatomically, was able to dissect and describe anatomically the innervation of that joint and established, the current practice that we have for treatment of the Z joints by medial branch blocks. So it's very important when, when you're thinking about the facet is to, we should think about it as an independent factor, but as a matter of fact, the facet and the disc, okay, work together. So basically, if you get degeneration in the disc, okay, this can affect your facet joints and vice versa. So, and the pathology or arthropathy of these joints can also affect the disc. And so basically, it's not uncommon to see that the L5, L4-5, and L5-S1 are the most commonly affected, okay, facets, because if you think about it, the most common place for disc disease or disc herniation occurs in the lower spine, 4 and 5, and this is also the common place where you get facet joint disease. More importantly, facet joints can occur with lumbar fusion, or actually it's accelerated through lumbar fusion, okay? And less common causes of facetogenic pain is inflammatory, like inflammatory arthritis and pseudocysts. As far as the prevalence, okay, of facet-mediated pain, okay, it's really, it's widely varies in the literature, and the source, okay, and the source of controversy. The reason is that it varies with age. So if you're looking at a younger age group, the prevalence is low, and and the older age group, the prevalence will be high. And this will, I'll elaborate this on more. However, the range, okay, is about, between 10 to 30%. I'd like to quote these 4 studies actually done by Manchikanti and Schwarzer from 94, okay, all right, all the way for 2004. And you can see these are prevalent studies, and the range is quite significant, between 95 to like around the lowest is like 31. So that's a very wide range. And the reason here is because I'd like to point to your attention is this false positive rate that you get. So that's why you see this wide range. And you could see, you know, the false positive ranges between like 30 to even like 40, you know, 27 to 40%. So this is why prevalence is a little bit controversial and hard to say. Clinically, patients with facet pain, okay, usually are older patients, usually at the range of like 60 years and above, okay. They usually present as axial pain, okay. It should be not radiating. Sometimes it may be radiating, but in the majority it should not be radiating. Pain should be relieved in the recumbent position. So if they lay flat, the pain should be relieved, all right, and should not increase with coughing, forward flexion, rising from a sitting position. This is basically Bogdan looked at the symptoms and signs and showed that if there's more than 5 or more of these criteria, you get about 75% chance of getting a positive response to a facet injection. In other words, a diagnostic facet injection. So that's something to keep in mind. As far as physical exam also there's no specific signs by physical exam that can point to, that can give you the diagnosis of facet pain. However, some things are suggestive. Most importantly is to realize that you should have a negative neurologic exam. So there's no motor or sensory changes, the reflexes are normal. There are some, there's no provocative maneuvers that will point to the diagnosis. However, you know, some indicators, for example, like palpation at the paraspinal muscle region may sometimes give you an idea where which facet that's mediating the pain. Okay, flexion, extension and rotation. Okay, is another maneuver that you can do. However, there's this study by Cohen in 2007 that's the idea was if you don't have that, okay, it correlates more. So the absence of extension and rotation correlates more or has heavier weight than a positive response. So if you don't have that sign, okay, the chances of having having facet pain is less. Referral pattern of lumbar facets, it depends on which facets are involved. So if you have like a lower back, okay, flank, okay, pain, this is usually secondary to referral. This is referred from the facets, you know, upper facets, like, you know, L1, L2. Lower joints, okay, L4, 5, okay, will give you more like a referred pain in the posterior thigh and sometimes in the lateral thigh, and that, you know, rarely in the calf, but it can happen. So based on the site, okay, or the pathology or the location, okay, of the facet, this is the referral pattern can differ. Upper facets will refer it to the lower back, okay, and the flank area. Lower facets is buttock, thighs, and sometimes the calf. Radiologic examinations, MRI and CT studies have limited utility in the diagnosis of facet-mediated pain, okay? If you take across a population, prevalence of facet pathology is anything between 40 to 85%. You will see it increases with age, and there's also a poor correlation between, okay, the radiologic findings and pain. So you can look at a CT scan or an MRI, and you see facet pathology, and when you ask the patient, there's no correspondence to the site or the location of that facet and the area that the patient is complaining of the pain. So MRI response also were poor predictors for facet blocks. So if you look at the facet by MRI or CT and you find that facet to be, could be the culprit and you inject it, that doesn't mean that they will do better. So the inability of lack of a good history, lack of a examination, radiologic examination, and a kind of like not very predictive physical exam put us in a situation of how should we diagnose facet-mediated pain. The best thing to do that was to do something what's called diagnostic blocks, where you can go into that facet and inject some local anesthesia and see how that patient responds. Well, there are two things that you can do here. You can either do an intra-articular facet block or you can do a medial branch block. So in a cadaveric study where dye was injected into the facet joint, okay, and they looked at the spread of the contrast after injecting, okay, into the joint, the facet joint. They found that the dye was not localized to the joint. Spread was noted in the ligamentum flavum and as well as the dura. And this is basically what we're looking at here. So this is the blue thing is the dye, and basically this is the ligamentum flavum right here. Thank you. Ligamentum flavum, okay, and right here is the dura, and you could see the contrast, the blue thing going all the way back here. That's ligamentum flavum, and then goes a little bit more the dura. When you see something like this, that you realize there's significant spread, this means that this is not localized to the joint, and it cannot be a good diagnostic tool to use. The better way or better process to use is basically doing a medial branch block, and there is actually what we call anatomic and physiologic validity. The anatomic validity, okay, was done through cadaveric dissection, okay, and through volunteer injections. So what they did was, they did the dissection, and they looked also, they injected patients with, with saline, and what they found that 84%, okay, of medial branch, okay, was localized in that joint. So basically, here we're trying to find a target. So basically the dissection, the cadaveric dissection, okay, showed that the medial branch could be a target, and on injecting that with local anesthetic, they were able to find that they can reach to that point in 84% of the time. Physiologic validity was through provocative testing. So what they did, they got also a bunch of volunteers, and they placed a needle into facet joint, okay, and injected, okay, hyper-injected with that joint and provoked the pain. When they went in, okay, and did that with prior to injection, they injected lidocaine, okay, the pain was gone. 89%, okay, of these patients had relief of pain with injection. So that proves that the medial branch, okay, is a good target, okay, it's an anatomical target, it could be accessed, all right, and if you block that branch, okay, you can get a relief. So that's why now we use medial branches for diagnostic blocks. Problem with doing a medial branch, okay, you have to realize that there's a false positive and false negative that can occur. There is an 8% chance of venous uptake, okay, and the issue here is that you have to think of whether should you do like one injection versus a placebo-controlled injection or a comparative injections, comparative blocks, and we'll we'll discuss this a little bit later. The volume here also is very important. So because you have to prevent spread to neighboring targets like medial and lateral branches, and the smaller the volume, the better it is. Okay, let's talk a little bit about the false negative results. Okay. It's been shown that with single uncontrolled blocks, if you do only one injection, okay, the rate of false positive, okay, is between 25 to 40%. Placebo-controlled is a good way to go, where you start with a placebo and then you go back and do your activity. You inject the local anesthetic. However, there are ethical and practical issues, that you have to deal with. It's very hard to convince a patient that, I'm going to do an injection and you're giving them saline, and there's a problem with that. Plus, I think the only use for this has been mainly in research projects. The common process that we do, or the clinical application that we're using, is basically using controlled comparative local anesthetic blocks. And this consists of using a short-term and a long-term anesthetic. And then we look at the amount of pain relief, or the duration of pain relief, okay, that the patient has after these injections. So for example, when you start with lidocaine, you expect good relief for about 1 to 2 hours. And with bupivacaine, it should be longer than that. So, and with these, we have good specificity and sensitivity. Studies has been shown that this helps. As far as false negative blocks, okay, you have to, sometimes this is also, you have to be able to realize that maybe I've used a lot of local anesthesia to inject, and then the anesthetics have spread around. You have to remember that there's always an 8% chance of getting a vascular uptake. As a matter of fact, doing these injections should be done under fluoroscopy and the use of contrast, and this is this will tell you whether you have intravascular spread or not. Patients that are sedated will also increase the likelihood of post-operative, false negative. It's that lunch that's getting to me now, I don't know why. The false negative results, all right? So it's very important, okay, once you do that, is to have a proper post-procedural assessment, okay? So the person that's doing the block should be ideally independent from the one that's assessing the patient post-block, and should be done like about 30 to 60 minutes after the block, and it should employ positions that will reproduce the pain. So basically, after the injection, we have to, if the patient has extension and rotation that causes the pain, after the block, we should make that patient stand and do these maneuvers to see whether this pain is relieved or not. And it's been an acceptable practice, in the pain literature where patients will have if they get 50% relief of the pain, that's an acceptable, result. Well, sometimes in this situation, you can, some people go for 80% and others go for 100%. And the reason for that is, the next step or the treatment that we'll be discussing later for facet mediated pain is radiofrequency. So if you accept your lower limit, which is 50% pain relief, okay, and you send these patients for radiofrequency ablation, you have a higher incidence of failure compared to the 80 or the 100% relief. So I'm going to really briefly go over the technique. This is basically an AP view, and what you see here, okay, this is the superior articular process, this is the transverse process, and here is the mammato-axillary ligament, and the yellow thing here is this, your medial branch block. So basically what we do when we do this injection is that this is the oblique view that will give us the target points. So this is the L3 and the L4, and that's the L5. So this is my target point for doing a medial branch block at L3. And as you can see, the needle here is placed in that oblique view, all right, at L3 and L4. This is what we call sometimes the Scotty dog. If you think this is the ears of the dog and that's the head of the dog, this is the eye. So the eye of the Scotty dog. And basically, what I was saying is you have to inject contrast to see, whether you get vascular spread, and to see the spread of the contrast to be localized to that. So you could see this is a perfect flow of the contrast going, to cover the medial branch. So once we do that, okay, then we should decide on a pharmacology or the treatment of pain. This could be done pharmacologically, and we're all familiar with the use of non-steroidals and and acetaminophen. So there's always strong evidence for use. The numbers needed to treat is anything between 1.8 to 2.4, so that's pretty good. Antidepressants, usually don't have a very effective role, but could be used in chronic pain patients as neuromodulators. Muscle relaxants, okay, the evidence is strong for acute pain rather than chronic pain in such situation. Non-interventional modalities simply, it's a gamut of exercise program, relaxation, yoga, spinal manipulation, acupuncture. I would like to stress the interventional modalities here. basically the use of two things that can help in treatment of facet-mediated pain: intra-articular corticosteroid injections and radiofrequency denervation. Well, as far as intra-articular corticosteroid injections, two studies, Barnsley and Carrot, showed that no sustained benefit from intra-articular steroid injections for facet-mediated pain. However, radiofrequency has been, the kind of like the commonly used treatment. What does this involve? It involves the use of an RF radiofrequency needle positioned at the junction, as we have showed, of the superior lateral neck and superior articular process, and should be parallel to that nerve, not just going pointing to it, so that you get the maximum area. And we do for those, we do sensory and motor stimulation because we are very close, you may be close to the foramen, so you really don't want to do an RF for the foramen. And basically, this is a safety measure. First, the sensory is important to say that we get good stimulation, and motor is to prevent any lesioning of the nerve. The analgesia following RF can varies, but it could be anything between 6 months and 1 year. And denervation, repeated denervation appears to be helpful. Outcome is very important, but it all depends on the type of diagnostic block that you have done. With single diagnostic blocks, you get 47%, greater than 50% relief, and with double comparative blocks, you get 77%. So basically, we advocate doing controlled comparative double blocks, because as you could see there, you get 77% compared to 47% relief. Complications from RF, basically you get like post-denervation neuritis, and this is most common complication. 10% of the cases may complain of pain. This could be ameliorated with corticosteroids. Infection is pretty rare. Neurologic damage could occur. However, proper and correct needle placement will decrease that. And the incidence decreases significantly with motor stimulation, and transient numbers may occur. Conclusion, basically the prevalence of Z joint mediated low back pain is between 15 to 40%. Medial branch blocks is the only modality to confirm the diagnosis. Single blocks has a high false positive rate of 25 to 40%. So that's why we recommend the controlled double, comparative block. Controlled comparative blocks provide better outcome. Therapeutic effect of intra-articular steroid injection is questionable. And thank you.
Thank you. Thank you, Ghassan.
Touched mine a little bit. Huh? There you are.
Thank you, Ghassan, for this interesting topic. We are glad to welcome again Dr. Timothy Moss. He had been introduced this morning. Dr. Moss is an eminent radiologist. He will give us a talk about an interesting subject, which is sacroiliac joint pain.
So Ghassan talked about the history of facet-mediated pain. Well, the sacroiliac joint can do that one better. If you go with the sacroiliac joint pain, as it being described as a potential pain generator, goes all the way back to Hippocrates. So this potentially goes back a long ways. But if you look at the intervening 2,000 years, it's cycled between where it can't be a pain generator. Yes, it causes pain. No, it doesn't. Yes, it does. Yes, it moves. No, it doesn't. Yes, it does. No, it doesn't. And the current generation of literature, which I think is now fairly strong, is that yes, it can cause pain. Yes, it moves, but very little. So we're going to talk about the sacroiliac joint, diagnostic and therapeutic interventions for both intra-articular and also sacroiliac joint complex pain. I do wish to acknowledge Dr. Frank Willard. He's a professor of anatomy at the University of New England, who has contributed to this talk. Nick Bogduck as well, one of the founders of Spine Intervention Society, and DJ Kennedy, one of our board members. Our agenda here is to talk about intra-articular pain, its diagnosis by intra-articular blocks, It's therapy by intraarticular steroid injections, and then sacroiliac joint complex pain, diagnosis by lateral sacral blocks, and therapy by radiofrequency neurotomy of those lateral sacral branches. So first about the anatomy. What does the sacroiliac joint do? Well, its function is a stress-relieving joint. It uses a dynamic force closure construct as a joint. It's not held in place by its configuration. It's rather held in place by a tension band. And we'll talk about that tension band in a minute. It's a very small capacity joint, only 1 to 2 cc's, even though it has a large surface area. It only moves about 2 degrees in any plane. It has strong dorsal supporting ligaments and this encircling tension band that holds it in place, holds it in its position and holds the sacrum between the iliac bones. The abdominal wall musculature anteriorly makes the anterior aspect of this tension band, and the multifidus muscles and the thoracolumbar fascia posteriorly. If we kind of look at this as a circle here we've got the sacroiliac joint. We want to balance load bearing across the articular portions of that joint. And we have posteriorly the thoracolumbar fascia and the multifidus. And then anteriorly, we have the anterior abdominal musculature. And it helps emphasize to us that when we're treating or thinking about the sacroiliac joint, we can't think of it as just a structural joint. We have to think about it in terms of the musculature that holds it in place and supports it. So you have to think about the muscles. In terms of its innervation, surprisingly, it's not completely understood. And there was very little information prior to the 19th century. The innervation of the joint itself is primarily dorsal from the L5 and S1 through S3 lateral sacral branches. Here's just a diagrammatic representation of that. If this is the midline, I'll bring my cursor over here. This is the midline of the sacrum right there. And here is the S1, S2, S3, and S4 dorsal foramina. We're going to have a little network of small lateral sacral branches which will go laterally to both the dorsal ligaments and to the sacroiliac joint itself. There's lesser but real ventral contribution to the joint, primarily just for the intraarticular component. In terms of imaging in patients with spondyloarthropathies, ankylosing spondylitis, psoriatic arthritis, their MRI findings of inflammation about the joint correlate very highly with disease activity, but not at all in just osteoarthritic patients, which are the vast majority of the patients we see. So just like in the spine, osteoarthritis imaging does not help us. Inflammatory spondyloarthropathies, yes. Osteoarthritis, no. So let's look at the clinical evidence regarding sacroiliac joint pain. Now we're talking about intraarticular pain. Prevalence data, the relative prevalence as a cause of chronic pain ranges around 20% in multiple papers. If we look at this over time, over the course of life, these are nice studies done by Michael DePalma when he was at Virginia Commonwealth. We look at the disc, we're going to see that's a disease of young people whose prevalence falls as you go through life. If we look at the facet joint, as Ghassan had said, it's rare in young adults. In children, it becomes more prevalent up to about age 70, then starts to fall off. Very similar to the sacroiliac joint, maximum prevalence around age 70. Axial pain from all other causes become more prevalent after 70. Many of those are malignant or sinister in character. And a caveat to that prevalence data is the post-fusion patient. And you can think of this as an adjacent segment issue. Once you fuse the lumbar spine in the first mobile segment, caudal to that is the sacroiliac joint, which doesn't really want to move very much. It's more likely to become a pain generator. And the existing data would suggest that in the post-lumbar fusion patient who has axial pain, now we're talking about a prevalence as a cause of axial pain up above 30%. In terms of clinical evaluation, it's generally, here it does particularly associate with pain arising from sitting in contradistinction to the facet joint. It's usually localized below the L5 spinous process. If it localizes there and is unilateral, just those two features alone give it an odds ratio of over 3 that it's the SI joint. There are multiple sacroiliac joint provocative maneuvers. Each one in itself is not predictive at all. And here are some of the typically used sacroiliac joint provocative maneuvers. So any one is not well predictive. But if you have 3 or more positive provocative maneuvers, then the odds ratio jumps up to 27. If you have unilateral pain below L5, 3 positive tests, now you got nearly a 75% probability. This is SI joint pain as verified by dual intra-articular blocks. Another study which also did rely on dual intra-articular blocks, again looking at that sacral provocative maneuvers, 3 or more, here sensitivity was 85%, specificity 79%. So 2 pretty well done studies saying that if you use multiple provocative maneuvers and it localizes below the lumbosacral junction, pretty good likelihood this is the SI joint. Now in terms of how are we going to make a diagnosis, there's a systematic review done by the Spine Intervention Society Standards Committee. We looked at 39 studies of diagnostic SIJ injections, 15 studies of therapeutic SIJ injections, and 7 systematic reviews. The caveats here, the injections have to be target specific. If you're injecting in the joint, it has to be in the joint. It has to be documented to be in the joint with an arthrogram. Real-time fluoroscopy is essential to verify that it's truly delivered into the joint. Ultrasound is insufficient to do an intra-articular injection in a small joint like the SI joint or the facet joint. A large synovial joint, shoulder, hip, knee, yes. Facet joint, SI joint, can't do it, never been documented to be successful. You have to also look at those studies and see, is there a limited volume used? The average capacity of a SI joint is 1 to 2 cc's. If you look back at some of the early studies on SI joint injections, you're looking at 6 cc's, 8 cc's. I don't know where that was, but it wasn't in the SI joint, or it wasn't exclusively in the SI joint. So how about sacroiliac joint diagnostic blocks? What does the literature tell us? The challenge we have here is we don't have a pathoanatomic reference standard. We do know something about the prevalence based on dual blocks, 20 to 30%, more with age, more with in the post-lumbar fusion population. We have no real data in a general population. We do know that intra-articular sacroiliac joint blocks, like any block, have a false positive rate, probably around 20%. We know that there's failure of access to the joint. This is one of those things that looks easy and isn't. Most people would say that at least 20% of SI joint injections fail to actually deliver the medication to the intra-articular space. And if one looks at using grade analysis of intra-articular injection, diagnostic injection literature, we really can't provide an assessment of the quality of the literature because we don't have that pathoanatomic standard. In terms of sacroiliac joint therapeutic injections, there are 2 RCTs in spondyloarthropathy patients. That's where our evidence is strongest. They're not perfect trials. They have some issues associated with them. There are also a number of observational studies, but they're not strong enough to bring the grading up higher. And it's going to result in a moderate quality grade of evidence for intra-articular therapeutic injections. The technique of intra-articular injections, it looks easy, it isn't. The SI joint is very sinuous with tremendous individual variability. If you have the ability, if you're doing this, look back in your medical records, see if there's a CT for any purpose that shows you the orientation of that joint. If you're looking at this in a prone patient, the posterior aspect of the joint, that's what's available to your needle, is going to be the medial expression of the joint. And sometimes there are spurs that cover the back of the joint and you just can't get there. And as we said, the synovial space is exquisitely small, maybe less than 1 millimeter. Here are some just random examples of SI joints, and look at the variability from person to person and within a subject in terms of the orientation of those joints. So in the middle one, you'd be taking a medial to lateral approach, so a straight AP approach there. Here you'd be taking a more extreme medial to lateral approach. Here you'd be taking a lateral to medial approach. And in some of these, there's going to be osteophytes covering the back of the joint, and you simply have no chance of getting in there sans a drill. If you look at this under fluoro on a prone patient, this is going to be the posterior aspect of the joint. This is going to be the anterior aspect of the joint. When we put a needle in, we'll see the inferior recess, and then we'll see this very thin synovial space. That's a 25 gauge needle. So that synovial space is less wide than a 25 gauge needle, and that's absolutely typical. A few other examples, again, that very thin synovial space. Notice it will track all the way up to the top of the joint. The synovial space does go all the way to the top of the joint. Again, we see that inferior recess and then the very small synovial space, 1 to 2 cc's total capacity. This is where things get tricky, where looking at a CT or any other cross-sectional imaging helps you understand how you're going to get into this joint. We all know the major axis of the SI joint is from posteromedial to anterolateral. That's the major axis we see here, but what's available to your needle here, it's 90 degrees from that. Look at that lateral to medial approach. That's the only way you're going to get in that joint. Whereas its friend on the other side, you'd take a straight AP approach. So it's variable within a person. And here, this is indeed that patient. So we had to go very ipsilateral oblique to get into that joint. And here's the proof of the putting the arthrogram. And you can see the arthrogram seen on FOSS here. A very small capacity joint, less than 2 cc's. A couple other examples. Here we start to see a little extracapsular leakage. And here's just a capsular tear. And here on a lateral view, there's that contained capsular tear. Here's the anterior ventral margin of the joint coming up like that. This patient, if we looked at the most inferior aspect of the joint, where we typically go, we have no chance of getting there. If we go a little bit more cephalad, then we have the ability to get into this joint way up there. And so we take that information into account, place the needle a little higher, and get into the joint. And there's the anterior and ventral expression of the joint on a lateral view. So we've talked about the intra-articular joint as a cause of pain. Well, we also have to think about sacroiliac joint complex pain. And that's pain coming from those dorsal supporting ligaments. That's a relatively recent concept of the last 20 years or so. But we know that pain can come from those dorsal ligaments. What are those ligaments? They are going to be the interosseous ligaments here and the short and long dorsal sacroiliac ligaments. And then subsequent peripheral to that will be the multifidus muscle and then the thoracolumbar fascia. The lateral branch blocks, where we block those small sacral branches that come out of those, the sacral foramina, were developed to intercept the nociceptive pathways from L5 and S1 through S3 as they course both to the SI joint and to those dorsal supporting ligaments. Paul Dreyfus did a nice study showing that if you consistently bring needles just down to the periosteum, even if you cover 180 degrees of the lateral aspects of those sacral foramina, you're not going to block that innervation effectively, only a third of patients. That's because some of those lateral sacral branches are not consistently down on the periosteum. They're interwoven within the ligamentous structures off the periosteum. So he developed multi-site, multi-depth lateral sacral blocks, where you're simply putting a needle down to the periosteum at 3 or 4 sites around half the circumference of the sacral foramen, and drop a little local anesthetic at the periosteum, bring it back a millimeter or two, drop some more lidocaine or bupivacaine. And so it's kind of time intensive, multiple spots around each of those dorsal foramina. And in an anatomic study, that intercepted those sacral branches in greater than 90% of the time in a cadaveric study. And then in normal volunteers, read medical students and residents, where you block those lateral sacral branches and then try and stimulate the dorsal ligaments, they're insensate to needle stimulation of those dorsal ligaments in about 70%. A fascinating result from that paper was you take those people who were completely insensate to stimulating those dorsal ligaments after a successful block, and you put a needle in their joint. Only 20% of those were protected from feeling intra-articular pain. So that tells us that some of the innervation to that joint itself is ventral, because you're not effectively blocking the joint by just blocking the lateral sacral branches. It's got to have ventral innervation as well. So this kind of tells us, it's a little bit simplistic, but intra-articular blocks identify joint pain, lateral sacral blocks identify ligament pain. So how about what does the literature tell us regarding diagnosis for multi-site, multi-depth lateral branch blocks? Moderate quality. In terms of treatment, treating those lateral sacral branches with radiofrequency neurotomy. There have been 2 explanatory studies, 13 supportive observational trials, and again, moderate quality by the grade analysis. This was probably the best randomized control trial using lateral sacral radiofrequency neurotomy. This was using cooled RF, and we can see at 3 months, 6 months, and 9 months. At 9 months, we're up to about a 60% patient responder rate of patients who had 50% pain relief. The sham group, in which the RF simply was not turned on, only a 12% responder rate. Those sham patients were then allowed to cross over, and they had a significant response rate after crossover. Here are all the observational trials. They're somewhat supportive, but one of the look at kind of the challenging paradigm here is that many of these observational trials are picking their patients with intra-articular blocks. They really should be selecting those patients with lateral sacral blocks. So to summarize, the good old SI joint, 2,000-year history of being described as a potential pain generator. The prevalence as a cause of axial pain, about 20%. It increases with age, increases in the presence of lumbar fusion. We're going to make the diagnosis on physical exam with multiple positive provocative tests, pain which is predominantly below the lumbosacral junction. Imaging is not helpful in osteoarthritis. For intra-articular pain, we make the diagnosis with an intra-articular block, realizing again there's a 20% false positive rate for a single block. We're going to therapeutically use an intra-articular corticosteroid injection. For posterior complex pain, multi-site, multi-depth blocks, and then radiofrequency neurotomy. One of the huge holes in the literature is we don't have prevalence studies for posterior ligamentous complex pain, and we don't have studies showing what's the Venn diagram of intra-articular pain and posterior complex pain. Does it overlap? Is there only a substantial overlap or no overlap? Not been done. So for young colleagues out there, a great study to do. It would be a great contribution to the literature. Thank you very much for your attention.
We are glad to welcome Dr. Claude Maroon. Dr. Claude Maroon is the Director of Physical Therapy Department at AUBMC. She is the former President of the Order of Physiotherapists in Lebanon from 2010 to 2013. She is a lecturer for doctoral and BSc programs in many universities. She's interested in spine-related problems. Also, she's interested in quality of care and evidence-based practice implementation, and she had several publications in these areas. Welcome, Dr. Maroon, and the floor is yours.
Thank you, Dr. Kanaza, for inviting me to present and to share with you the role of physical therapy in the treatment of low back pain, and specifically in the treatment of non-specific low back pain, with the introduction of the mechanical technique modality of treatment as a means for treatment in non-specific low back pain. The Netherlands Association, the Association of Physical Therapists in the Netherlands, has published its evidence-based clinical guidelines related to non-specific low back pain that is based on the biopsychosocial model. And this guidelines us to start whenever we receive a patient to check first of all for any red flag. If there is a suspicion of any red flag, there is a need to immediately refer the patient to the physician. And if there is no suspicion of any red flag, we continue our exams and taking the history. In Lebanon, we don't have so far direct access to physical therapy, so patients are referred by the physicians, and they are usually diagnosed for specific or non-specific low back pain. So what we do, we start assessing the patient. We take a thorough history for identifying red flags and mainly for identifying yellow flags. We try to check what are the complaints, the present complaints, and mainly we try to trace or to identify the course of these complaints, whether it is a normal or abnormal course. And of course, we check the patient's coping strategy, and it is very important to check the yellow flags or the biopsychosocial model, because these patients who have yellow flag, they involuntarily and unconsciously maintain their symptoms. So we use objective measurements to check on the pain and the disability of the patient. And after getting all the information, we check whether these factors, psychosocial factors, or the factors that can impede the recovery of the patient, that could be back-related, for example, widespread pain, or personal factors related to age or to the health status of the patient. The psychosocial factors, whether patients are catastrophizing or they have elements of depression. And of course, we need to identify the occupational factors, because they are the most impeding factors in addition to the psychosocial factors in impeding the recovery of the patient. When we analyze, we get all these information, the patients are categorized under 3 profiles. The first one is the normal course. The second, abnormal course with no evidence or no dominance of psychosocial factors. And the third one is the abnormal course with the importance of presence of psychosocial factors. For the normal course, what we do usually, it is just 1 to 3 sessions most. We reassure patient, we explain the condition to the patient, and we encourage patient to keep active with whatever the pain it is within her limitation. And then we try to explain that having back pain will not be will not impact negatively on his status. And usually it is, as I said, 1 session. For the second profile, abnormal course without dominance of psychosocial factors, first of all, we have to encourage patients to stay active within their limitation. And we use a time contingent plan to ask them to move around and to stay active, because we want to help them focus on the functioning and not on the pain. So it is very important to encourage them to move, and we start with them with a graded exercise program based on their capacity. And of course, we need to consider whether they are under sick leave or not. It is very important to check with them what is their work station or the work condition, in order to provide them with ergonomic instruction related to their daily activities needs and to their work needs. For the third profile, abnormal course with the dominance of psychosocial factors, patients here catastrophize, and they really need to be supported psychologically and physically. Although the evidence recommends to restrict the number of sessions in physical therapy for non-specific low back pain, for patients who have yellow flags, the recommendations of the NICE guidelines is to provide 10 sessions of physical therapy distributed over 3 months, because these patients need to be really supported all the time, and to understand that having back pain will not make harm to their spine. They will not end up on a wheelchair, because this is the most important factor or idea that comes to their mind. So we encourage them to stay active. We provide them with a graded program of exercises based on their capacity, and we go up with them based also on their capacity. And of course, we need to check their work condition and to provide them with instructions related to their work condition, and to give them the modifications and the adjustment required. As you can see, the evidence encourage providing exercises to patients, but so far there is no evidence that support what type of exercise to be provided. This is why in our department we are using the McKenzie method in diagnosing and treating non-specific low back pain. It is also based on a biopsychosocial model that focuses on patient empowerment and self-treatment. Our aim in the MDT method is to get our patient independent from physical therapy and to be their own treater, or they provide their own treatment to themselves, because this kind of ailments and diagnosis, it is it is with the patient on a long term, and it requires long-term treatment. So McKenzie method applies to acute, subacute, and chronic conditions related to the spine and also to the extremity. Just a brief introduction about McKenzie method in order to understand how patients can immediately relieve their pain. McKenzie classifies the mechanical symptoms under 3 main categories that are the derangement, and it constitutes 80% of all conditions. And the important issue in derangement that you have immediate pain relief. Dysfunction, the second category is the dysfunction, and what we call failed back syndrome falls under dysfunction in the McKenzie vocabulary. And we have the dysfunction is related mainly to the soft tissues that are impaired around the joint, whereas the derangement, it is something that is not smooth within the joint, and it is causing the pain. The postural category is related to bad posture and the affection of the joints and the muscles around the joint. Under others, the fourth category, McKenzie includes all specific pathologies that could be the sacroiliac joint, the hip pain, or any other specific pain pathology. McKenzie introduced the notion of centralization of pain, and the centralization, it is the fact that we are taking the pain from, sorry. It is taking, can you help? So it is taking the pain from the periphery, from distal, from the foot, till the center of the back. And this is being done by what is called directional preference. It means that there is a specific movement that we do and that leads to this centralization. For example, if I have an anterior derangement of the lumbar spine, it is the flexion that will abolish my pain and reduce my pain, and the flexion is my directional preference. Whereas the peripheralization, it is taking the pain from the central to the periphery, and of course this is what we don't want, it is what is called the back pain. Whenever we have centralization, we have 2 types of responses. There are symptomatic responses where the pain will decrease and the symptoms will decrease, and the mechanical response where the range of movement will be increasing. I will be giving 3 examples of patients that have been treated with the McKenzie technique, and the assessment form is divided into, first, we try to identify what are the mechanical stresses that can impact the symptoms, negatively the symptoms. Of course, we check for the disability and the pain intensity. Then we try to check what is the course of the symptoms, whether is this a normal course or abnormal course. We check for the treatment that was provided, and then we try to check whether there is any cause for specific low back pain, and then of course, we check the posture of the patient, and we start with the test movement that constitute at the same time the treatment of the patient. So this lady of 31 years old is a nurse. She spent lots of time, 8 hours, almost 8 hours per day, standing and bending, and she spends 1 hour driving. Her functional assessment, the Quebec Back Pain Disability Scale scored 80 over 100, meaning that there is high disability. Her pain was graded 10 over 10, irradiating from the low back till the foot. She has, the pain started 3 months ago, and the pain is unchanging since it started with no apparent reason. And these two elements are hints for us that guide us to think that could be a mechanical pain. She has, the triggering factors are mainly bending, sitting and rising, and as you can see, it is, the pain is related to movement, so it guides us also towards thinking that it is a mechanical pain. The worse it is when she is still, and she feels better when she is on the move. There is no specific pattern for her pain, and she received anti-inflammatory painkillers, muscle relaxant. It did not have any effect for her, and the last month she spent it with, complete bed rest. She presented limping to the department, and the triggering factors are mainly cough and sneeze. On the MRI, there was bulge disc L4, L5, and 5S1. And based on the assessment, there is no cause for specific low back pain, for malignancy. When assessing her posture, she feels better when we corrected the posture, and this is also guide us toward the directional preference of this patient. When, because she was limping, I went through a neurological assessment assessing the motor and sensory deficit. Her muscles, abdominal and low back and lower extremity muscles were graded 3 over 5, and she had no sensory deficit. She had major limitation in all back movement, except for the flexion, where she felt pain when doing the movement. When asking her to start, when I asked her to lie prone, just while decreasing prone, she abolished her pain in the leg, and the pain was reduced in the low back. And with the repetitive exercises in extension, she abolished her pain and she left the department better. She was diagnosed for a posterior derangement, and of course she received education. It is very important to educate patients in the Mackenzie method. She received also a lumbar roll in order to correct her posture and to prevent the triggering of the pain while sitting. And she was asked to do 10 repetitions in extension every 2 hours. The second case is a 59-year-old man who is a guard. He stands for almost 6 hours per day. He presented with a pain graded 8 over 10 at the level of the hip, low back, the hip, and below the knee. The pain started 1.5 months ago. It was unchanging since it started with no apparent reason. He feels better while bending, while walking, and when he is on the move, but he feels worse when he is sitting and rising from the chair, and while lying on the back or on the right side. He has disturbed sleep, and he received 2 infiltration at the level of L3, L4, and L4, L5, and he did not feel any better. The MRI showed a bulge disc at the level of L3, L4, L4, L5, and L5S1. While correcting the posture, he felt better. He had reduced lordosis, and he had moderate loss of movement in all back movement. In standing position, extension movement did not have any effect, but while asking him to repeat the extension, he started centralizing. And when he lied prone, just lying prone did not have any effect, but with the repeated extension, extension in lying, he abolished in the leg and centralized in the back, and he left the session with the pain graded 3/10. Of course, he was diagnosed for a posterior derangement, and he received, we suggested a roll, lumbar roll to correct the posture, and he was asked to repeat his exercises every 2 hours. The third case is a lady who has of 28 years old, who undergone at the age of 17 a correction of her thoracolumbar scoliosis with a Harrington rod. And as you can notice, the only moving element in her back is at the level of L5-S1. She presented with a pain graded 10/10 at the level of the low back radiating above the knee. She is an office worker. She sits a lot, and during her leisure activities, she takes care of her children. Her pain is unchanging since it started 6 months ago, and with no apparent reason. And usually when it is no apparent reason, you can think automatically about mechanical because the pain starts adding up with no apparent reason. She felt worse at sitting and rising and better on the move. She received medication, anti-inflammatory painkillers, muscle relaxant, and she received many sessions, of physical therapy with heat pens and stretching exercises with no effect. Her gait was abnormal. She was walking with a slight flexion, bending forward, and you have seen already her X-ray. Of course, she has a reduced lordosis and major limitation of all loss of all movement due to the Harrington rod. She has minimal flexion because she flexes only by her hips. And when I asked her to lay down prone, she immediately centralized, and with the repetition of exercise, she abolished her pain. She was asked to repeat her exercises every 2 hours. And we did not provide her with a roll because her back was just straight and she was not able to correct it. So what is important in Mackenzie is this immediate relief of pain if we can choose the correct directional preference in order to allow the patient to centralize and abolish his pain. But what the evidence states about the Mackenzie method, as a matter of fact, the evidence is mounting about Mackenzie. 43 additional articles were added in the systematic review that was checking about whether centralization and directional preference could be considered as prognostic factors in patients with low back pain. So the review confirmed that there are key prognostic factors in patients with low back pain with limited evidence related to the cervical spine. In another systematic review, only exercises were found effective in 7 out of 8 trials, which included extension exercises and an education session based on Treat Your Own Back, that is the educational material distributed by Mackenzie Institute. Stress management through inserts, back supports, ergonomic advice, and reduced lifting programs were found to be not effective. And another systematic review, including 4 high-quality studies, showed that directional preference exercises were an effective intervention in 3 out of 4 studies, showing significant differences compared to a range of controls, regardless of duration of symptoms. I included this study, the last one, because when we explain to the patient in Mackenzie why their pain is immediately reduced, we tell them that in the derangement, the disc is not, the nucleus pulposus is not at its place, and this is why there is this derangement. And with the repetitive exercises, we are pushing this nucleus pulposus at its place, and this is how your pain is reduced. But we did not have any evidence, and it was just a mechanical and logical explanation. So it is the only study that studied, that took MRI for the nucleus pulposus before and after Mackenzie treatment. And the initial MRI before the treatment showed a portion of the nucleus pulposus displaced right.
3 minutes, please.
Yes. and posterior towards the side of brain, and overall NP position in the coronal plane shifted to the left. After 1 month treatment with the Mackenzie technique, the MRI showed the displaced portion of the NP was no longer present, and the left shifted NP was centrally located, which coincided with the centralization and abolition of symptoms. Of course, this only study does not constitute evidence, but it makes us think about studying this movement of the nucleus pulposus. I will conclude this presentation by stating that, unfortunately, evidence is supporting the use of physical therapy modalities is still scarce. The evidence supports only the use of exercises, but so far we don't know what type of exercise. The evidence is very contradictory yet. And we need to know that a thorough assessment to set accurate physical therapy diagnosis and categorization can lead to an effective treatment outcome. The biopsychosocial model is very comprehensive and can lead to effective outcome. For Mackenzie method, it is the assessment enables the physical therapist to triage patient and to provide them with the appropriate exercises specific to them, individualized with their individual with their individual needs, and the process promotes patient empowerment, and it is very cost effective because the number of sessions are between 3 to 5 sessions, and we don't use high-tech equipment, just the treatment table and the chair and the patient and our clinical reasoning. Patient education is very important, and thank you very much for your attention.
Thank you, Dr. Maroon, for this comprehensive lecture. And the story doesn't end without the involvement of a psychiatrist. Let me introduce this beautiful lady, Olivia Shab. She's a clinical psychologist. She completed her education and training at Harvard University, Stanford, and NYU, and has worked in a variety of settings before joining AUBMC Psychiatry Department. Welcome, Dr. Shab. The lecture is Mental Health Contribution to the Treatment of Back Pain.
Hello, can you hear me? Okay. Thank you for the kind introduction. If you're a psychiatrist to end the session will never end because I'm a psychologist. Do I need to do something here? Okay. So thank you again for the kind introduction. And I wanted to talk a little bit about what psychotherapy can do for the treatment of pain. Dr. Maroon, I really appreciated your emphasis on the biopsychosocial model. And I think that we can help take care of that piece as well, the psychosocial aspect of that piece. I believe that one of the main motivations behind this symposium today was to promote an interdisciplinary approach to treating pain. And I think it's really a wonderful and necessary idea. One, to provide a better understanding and more effective treatment of the problem, because instead of going at it from one very specific hyper-specialized approach, maybe together we can build a three-dimensional model of who this person is, and we can collaborate on working on it a little bit more assertively from our various perspectives, which I think can translate into less time spent in treatment, greater patient satisfaction because they feel like they're being treated like a whole person rather than a medical case, and can translate into a long-term relationship between the patient and the institution, where there's a mutual accountability and mutual fidelity, I guess, between the patient and the institution's commitment to community care. Finally, and this is more of an intra-institutional point, I guess, that I think such initiatives can really promote a smoother functioning and collaboration between departments, which can also spur ideas for research so that we can hopefully continue to raise the bar in terms of standards of care and quality of care and continue to treat our patients more holistically. So I wanted to introduce the basic idea between the mind-body connection and specifically how this translates into the connection between mental health and pain. So if you forget the sensory neuron for a moment, we have the basic CBT or cognitive behavioral therapy triangle, which is At the very top are cognitions and attitudes. At the bottom are emotions and affect. And it takes bravery to approach the laser pointer. I think I'm going to stay away from the laser pointer. And thank you, though. And the third piece of the triangle is the behaviors. So this triangle is one of the main ways in which we think about our patients who come in for mental health treatment. And the idea is that the way that we think about things affects the way that we feel about things, affects how we approach things or how we avoid things. And obviously, all of this feeds into our biological system because that's where our emotions live. And there's a reciprocal relationship between them. So how I think about pain, how I feel about pain, and what I do or don't do because of pain is very much influenced by what my body feels, and what my body feels is very much influenced by this triangle. So, for example, I had a patient who came quite recently actually with medically unexplained pain, and she didn't respond to any interventions except for an anxiolytic, which I thought was quite interesting. And she sort of asked, well, is it possible that mental phenomena actually affect physical manifestations and level of pain? And it's not a stretch to understand why, because emotions live in the body. So assuming if we understand anxiety, for example, as something that really tenses your body up, then if you have any vulnerabilities in your body, then of course emotional distress is going to contribute to an intensification of pain. So that's the basic mental health triangle, and we work a lot with it in terms of how it fits into pain patients. So I want to take a look at specifically what works and why. So what are the kinds of things that if you were to refer a pain patient to a mental health clinic, what kinds of things would we be working on with that patient? The first thing that we try to do is to heed and manage alarm bells. And we can actually do that very effectively without a very direct collaboration with a medical provider so that we don't push a patient beyond their limits and so that we don't also contribute to their own sense of helplessness about things. So the idea behind managing alarm bells is developing a mindfulness of body signals that is actually proportional to what the body signals are. So patients often, I think as you said, Dr. Maroon, catastrophize their symptoms, which means that they overestimate what it means in terms of what they can or can't do. Or they minimize the symptoms, which means that they don't want to have this problem, so they pretend that it doesn't exist and they go about their life in a very normal way, which then exacerbates their symptoms. So our job is to help them to constructively and compassionately connect with their body. So to try not to be angry with their body and to reject what their nerves are trying to tell them. So no fighting and no denying, just having sort of an honest relationship about what are your pain symptoms, how can we pay attention to them. So for patients who tend to disregard their body signals and who minimize, they can overexert, which makes the situation worse. And for those who fall into this pattern of learned helplessness, that I can't really do anything because I have pain, we try to challenge their overly cautious view of the world and try to break their underexertions. And one thing that I wanted to mention too is that studies have shown that back patients that are depressed tend to report higher pain scores than back pain patients who aren't depressed. So learned helplessness is one of these very clear pathways into depression, and so our job is to help prevent that if we can. So one thing that we do also in order to intervene effectively is to think of what is the impact of pain in various ways. So the first one is, how does having pain actually change your landscape? Social changes, occupational changes, physiological changes, obviously. Some of these things are good, and some of these things are not so good. So you have patients, for example, who are very emotionally reserved, who don't communicate well with friends, with family, and then they come to a place where they find themselves at the most vulnerable point ever, and then have to talk about themselves a little bit differently, and in some way act as an impetus to break a barrier and create more honest conversations with people, which actually makes them feel closer to other people. And so paradoxically, sometimes people's relational quality of life can improve after such incidents. But there are also lots of losses, and some of those changes are losses. So I had a patient come in one day, and her chief complaint was that she had sprained her ankle. And I thought that was a very strange chief complaint for the psychologist's office. And she she followed up by saying, and it made me realize I actually have no friends. Because what it really showed her is that when push came to shove and she was in a situation where she needed somebody to help her get her groceries or take care of her a little bit better and not just be with it for the fun times, she found that she had no one. So that was something that we had to work on. There are obviously lots of losses that you're familiar with when pain happens. We look at the coping style of the patient. Is there denial? Is there resignation? Is there some kind of rebellion against the pain? This is what I was talking about in terms of people rejecting their condition as opposed to working with it. And what we're trying to do is we're trying to get people to work with their body and with their systems and with their emotions constructively and compassionately rather than fighting their condition. Do they numb? Do they overly intellectualize? So instead of sitting with the changes and processing what it means for them, do they just sort of sit in this very cold brain space and push people away instead of talking about what's happening with them? What reinforces attention to pain and neglect to pain? So interestingly, sometimes people, well, I guess it's not that surprising, but there are some secondary outcomes that people can get from having pain. Maybe somebody is in a relationship that is on the brink of dissolution, but this is a pain condition that keeps their partner from leaving. Or maybe this is somebody that's not used to getting a lot of attention, and then suddenly having a pain condition is a way of asking for emotional attention that they don't actually know how to ask for in other ways. So when taking care of these pieces, you can sort of take these complicating layers away so that we actually know how much of it is pain that needs to be treated and how much of it is a different kind of pain or relational landscape that needs to be addressed. Role transitions. So sometimes a person will be the breadwinner for the family, and then something changes that they can't do the kinds of things that they needed to do before. And so those are some pretty complicated role transitions. Or sometimes, let's say, somebody who's a mother will have a pain that will preclude her from any of her children. And that is also something that is very damaging to the role that she sees for herself. And so these are actually forms of losses that you have to work with as well. And one of the main things that we do with pain and with any sort of condition action is that we have to help patients coach people around them to be the kind of support that they need. Because people don't often know how to communicate effectively about what they need, how to ask for things, and so we help them build a support system that actually feels like support. I wanted to mention John Kabat-Zinn, who wrote a wonderful book about living with pain, and it's called Full Catastrophe Living, Using the Wisdom of Your Body and Mind to Face Stress, Pain, and Illness. I have a copy if anybody wants to look at it, and it's quite wonderful. The idea of mindfulness training in general is to take advantage of attentional limitations. What does that mean? So for better or worse, our attentional capacity is very limited, which means that if we focus on pain, then all we're going to see is pain. But we actually have an ability to train our minds to sort of like flash the spotlight on what it is that we actually put into our attentional capacity. And so that's what mindfulness actually does. So instead of being overcome by whatever is most likely to come into your mind, either by habit or by circumstance, you train yourself to be in the moment and to actually choose what comes into your attentional capacity. And because our attentional capacity is limited, if you effectively learn to shine your flashlight on one thing, that means there's not much space for something else to come and take over your attentional capacity. And one of the reasons why this is, to make it less theoretical and more applicable to pain, really helpful with pain patients, is that one of the things that pain patients tend to do, particularly chronic pain patients, is that they're not just living with the pain of this moment, they're living with all the past pain that came before it, and they're catastrophizing all the pain that is to come, and which really puts a lot more intensity into the pain of the moment. And so what you're trying to do is to just pick this moment out of the past, out of the rumination of the past, to also separate it from the anxiety of the future, and to just breathe through, glide through, ride through the pain of this moment, which may not be easy, but it's much easier than also shouldering all of the pain of the past and all of the pain of the future. Another form of therapy that I really like to apply with pain patients is acceptance and commitment therapy. Why? Because with pain patients, patients, I think acceptance is a really key concept, because there are lots of things that you can't change about your life, and a pain condition is something that you can work on, but it's not going to just go away, and a lot of times it doesn't go away. So the idea is, how do you recalibrate your relationship towards things that won't change, instead of putting all of your energy into trying to change them? So we try to shift patients' perspectives from being attached to their pain, and attachment is not a positive concept. It's not like I love my pain. I can hate my pain, but that's still a form of attachment. So we're trying to move from attachment to pain to attention to pain. So just heeding what we need to heed to manage our alarm bells, but also dissociate one's identity from pain. So the idea behind ACT, which is acceptance equipment therapy, is that whether it's pain or anything else, our life is always going to be a plate that's full of things that we like and things that we don't like. And we have a tendency to focus on fighting the things that we don't like, which fills up all of our attention, and it's harder to see the other things that are on the plate. And the idea with ACT is that, can I accept that there are these things that I don't like on my plate, and can I invest in those other things that I like, identify my values, and actually grow? And when I put my attentional capacity into growing, it leaves less space to actually focus on the things that are bothering me, including pain. And so it's a value-based and it's a growth-based perspective, which a lot of people find very validating, because it moves your perspective from trying to deny something or fight something to who can I be despite this thing? What do I want to be? What do I want to do despite this thing? Which is very empowering. So must and can I accept pain as a reality in my life? What defines me outside of the experience of pain? So a lot of work is going to identify values. And what can I build on despite the experience of pain? And so people start to feel like people again, rather than just a pain feeler. And then there are quite a few practical skills that one can use to tolerate pain that the ACT program also teaches. I realize this is a slightly ambitious photo, so we can not attach to it too closely. But another thing that we can do is that, going back to that three-dimensional model of how a patient works and having the medical aspect, having the therapy aspect, we can really help with adherence to treatment to those things as well. So we can explore and help resolve ambivalence around adherence to treatment. There can be a lot of issues with hope, particularly with chronic pain patients. Finances can be an issue, mobility can be issues. So we can help resolve that ambivalence, and a lot of it can go back to sort of values and moderating expectations as well. Physiotherapy can be painful, requires a lot of discipline, as you surely know. And so we can help explore and resolve the ambivalence around that as well. And the pharmacological and medical approaches to pain treatment are not ones that everybody's very comfortable with. So that's something that we can help talk about in treatment as well. And the fear of addiction, and there's been such a thing around the opioid epidemics, and so people have really a very legitimate fear of medications. And so in collaboration with the medical community, that's something that we can take a look at as well and have advice on. All right, that's it. Thank you.
Thank you, Dr. Shah, for this interesting presentation. We have time for some questions. Are there any questions?
Question please to Dr. Timothy. When you do a diagnostic block for the sacroiliac with lidocaine or whatever, what's the type of treatment that you put in? Steroids, neurolytics, what do you?
The only evidence supports using corticosteroids at this point. That's the only thing we have strong evidence for. And there's no evidence to differentiate one corticosteroid from another. It's perfectly rational to use any particular steroid in this setting. So most the literature would suggest a 2-to-1 or 3-to-1 ratio of a local anesthetic to prednisolone or triamcinolone. There's no differentiate. There's not good data to differentiate one from another.
And you repeat it once again in a week or two or something? Or you wait until the pain comes back or what?
It kind of goes back to this concept that's been described
in other settings, in the epidural setting, of a series of injections. And there's absolutely no scientific evidence that supports any predetermined series of injections. So a subsequent injection is based on response to the prior, and I would treat it very much like we do with epidurals. If the patient's had a significant but incomplete response, it's rational to do an early additional injection. If they have a sustained benefit, I'm not going to inject them again until their benefit wanes and they're again being impacted by their pain.
They do a lot of exercises back in the States, so would you advise the patient to go directly to his normal exercise, or should he wait for a bit before resuming normal life?
Return to normal activities as soon as they're able, and as we talked about, looking at the anatomy of the SI joint, it's a joint bound together by a tension band, and you absolutely have to involve the physical therapy colleagues in conditioning the anteroabdominal muscles and the posterior multifidi to support and hold that sacroiliac joint in proper position. And again, obviously I'm speaking largely about interventions, but most of my colleagues as well on the stage are speaking about more the holistic aspect of the patient, and certainly that's something I absolutely advocate. Injections are a mechanism of providing relief to allow a patient to participate in a vigorous program of holistic care. So this is just one aspect of a much broader spectrum of care.
Thank you.
I will use the microphone. So concerning the McKenzie technique, you mentioned the immediate relief of pain. What about, do we have any data concerning the short-term or long-term of pain relief?
Yes, on long-term status, it is usually whenever the patient is compliant with the exercises, the long-term effect of the treatment is present. But for short term, it is always an immediate relief of pain. There is no evidence studying this issue in relation to short term and long term gain of benefit. I mean, of the method.
Thank you.
This is for Dr. Shab. I just wanted to ask you, are you aware of any comparison as far as success with treatment of patients with chronic back pain, comparing like group therapy versus pain programs versus CBT? I mean, is it like, is there anything that as you may be familiar with that looked at these things and showed a better response or
of groups versus individual, or
yes, groups versus individual.
I'm not sure that I've seen such comparative studies. I know that groups generally offer benefits that individual therapy does not, just in terms of community and validating, but I don't know specifically, no.
Because that had been a common thing where pain programs have been like, it was, very common at certain time in the US, and then suddenly it kind of like vanished, and now it's coming back. So the question is that, are they doing the same thing where they're, getting like a group of people, chronic pain, and they will go ahead and take them through a course, physical therapy, cognitive behavioral therapy, and like release them after a week or so? Is there any benefit of like revisiting these issues here in Lebanon, or what do you think?
I think it could be, yes. I mean, the programs that I've been a part of have been mostly group-based, and I think the literature reports mostly on group-based programs rather than individual programs. But it's something that we can do together, maybe.
Excellent. Looking forward. Thank you. If you guys would like, we can cut our break to like 15 minutes and start at 3:15 instead of 3:30. Okay, sounds good. So we will meet in 15 minutes, all right? And we do the last session. Thank you.
Welcome to the last session of this symposium. Dr. Moss, who was introduced several times earlier, will talk now about the treatment of discogenic pain. Thank you.
Thank you very much. Before I launch into this, I just want to again thank my hosts here, Dr. Maroon, Dr. Kanazi, and Dr. Shushi for all the great experiences, spending some time with their residents. Look forward to coming back at future dates and continue the educational process and the educational collaboration between AUB and SIS. So I'm tasked now about talking about treatment of posterior end-plate pain. Is there any reality to the many, many things that have been tried over the last 20 to 30 years? So this will be a little bit of a historical review and see going forward, what does science have to offer us? And the fact that we're going to talk about 15 different things tells you that, and they're no longer around, tells you that 15 different things didn't work very well. I do wish to thank or to acknowledge that a portion of this talk is built off a review article by Wei Yin and Dr. on interdiscal therapies for low back pain in Marvel's last edition. So the lumbar discovertebral complex is one in which the key is maintaining homeostasis within that tissue environment. The chondrocytes within the disc control synthesis and degradation of the nuclear matrix, proteoglycans and collagen, and the ability to bind water and provide a cushioning effect. It is, however, a hostile biochemical environment. When we're children, we have a direct arterial supply to the disc. We lose that direct arterial supply as we go through adolescence. So those poor chondrocytes have to live on diffusion from the adjacent end plate, and they're really in a challenged environment. So all the diffusion has to occur across the vertebral end plate and the cartilaginous end plate of the disc. As I said, there's a low blood supply, low oxygen tension, and it's essentially anabolic metabolism. A variety of insults then can upset this relatively delicate homeostatic balance, and they can be metabolic disease like diabetes, overnosis, genetic factors, traumatic end plate injuries, which we focus on as kind of the basic model of disc degeneration, nutritional challenges, smoking, vascular disease, and potentially low virulence and infectious agents. The disc injury model as the genesis of discogenic back pain goes as thus. That is, thought there's an end plate injury, maybe an axial loading injury that's subclinical in expression. There's not a frank fracture. This results in injury to the disc by injury to that ability to transmit nutrients across that end plate. So essentially there's an injury to those chondrocytes. We have loss of homeostasis. The nuclear matrix is degraded. It can no longer maintain pressure in that disc. With that depressurization, then comes axial load being assumed by predominantly the posterior annulus. If the posterior annulus maintains its integrity, then you're going to see increased load dispersed over that annulus. You'll see osteophyte formation, but that annulus may be failed by fissure formation, and then we get the radial fissures typical of the internal disc derangement. About 70% of painful discs will have radial fissures, and about 7% of discs with radial fissures will be painful. So there's a clear association. And that pain generation then may occur by mechanical stimulation of the normal posterior annular innervation, by chemical stimulation or sensitization of that normal annular innervation, and by amplification of that innervation by acquired innervation, which occurs by ingrowth of neural tissue and associates with angiogenesis in those radial fissures. When those fissures breach the outer annulus and reach the very richly vascular epidural space, you'll see ingrowth of vascularity and neogenesis, development of new neural tissue. The challenge we have in making the diagnosis of internal disc disruption or discogenic pain is the only tool we have is provocation discography or disc stimulation, but we have a reference standard dilemma. We really, there's no clear-cut pathoanatomic reference standard. We can't look at a piece of excised disc and say, aha, that was painful. Can't be done. So we don't have a positive reference standard. And in that sense, we don't have cells A and C of our typical 2x2 matrix. We only have a negative standard when we apply this test to a patient who is asymptomatic.
but we can maintain some validity if the false positive rate B here is very small, and the reference standard then is asymptomatic subjects. But we know it's a compromised test. There's been a lot of dispute over the years whether there is indeed a high false positive rate from disc stimulation or lumbar discography. A very nice systematic review by Wolfer and Derby and colleagues looked at 11 studies using SIS. I apologize, SIS used to be known as ISIS, the International Spine Intervention Society. We had to change our name. So if anybody wants to know where the National NSA, the National Security Agency, well, it's probably in my Mac, because I've been sending emails for years saying I'm the president of ISIS. So it goes. Anyway, very nice. Using SIS and the International Association for the Study of Pain criteria, meaning that to be a positive disc stimulation, there has to be 7 out of 10 concordant pain, a grade 3 tear at pressures less than 50 psi above opening pressure, an adjacent normal control disc, and using 15 psi as a low pressure positive. Looking at all the data and applying those criteria rigidly and carefully, the false positives are about 9% per patient, 6% per disc. Using all that pooled data with no confounding factors, the false positives were 3% per patient, 2% per disc. In chronic pain patients where we expect more false positives, there's still only about 6% per patient and 4% per disc. So it's probably a rational and reasonable test, and it's really the only good test we have. Disc stimulation, should we then employ it? Yes, even though it has its detractors, I think it does have value. As a negative predictive value, because when it's a negative, we prevent unnecessary surgery and we prevent other unproven interventions applied to the disc. It has diagnostic utility. When it's positive, it results in closure. Even though we don't have a great treatment for disc-related pain, we prevent overtreatment. We prevent other unnecessary investigations or other unnecessary interventions. It's always good to have a diagnosis and not continue cycling in an injection pathway that doesn't address the true pain generator. Through the efforts of many and over a period of decades, disc stimulation has attained this validity in the diagnosis of disc disruption. How do we then treat internal disc disruption, so-called discogenic? And there's where the rub comes in, that we have a very poor armamentarium in treating discogenic pain. Look at what we've used over the last 20 years. All potential intradiscal therapies. Denervation therapies directed towards the gray Rami communicans, intranuclear RF, RF directed towards the sinovertebral nerve, intradiscal electrothermal nucleoplasty, myoplasty, base vertebral nerve denervation, chemical therapies including intradiscal steroids, etanercept, methylene blue, ozone, proliferants, reparative therapies using fibrin sealants in annular fissures, and most recently regenerative therapies, including growth factors, gene transfer, and cell augmentation. So let's talk a little bit about some of those, and is there any evidence to support any of those? So in terms of denervation therapies, we can target the great Rami, kind of, the sinovertebral nerve, kind of, the ingrowth of neural elements into the annular fissures. Targeting the gray Rami, there's a single controlled RF study. Target specificity is questionable because targeting exactly where that nerve is a little dubious. Modest benefit, it was continuous data only, not categorical data, and confounded by the simultaneous administration of steroid. Intranuclear RF, there's no possibility of coagulation temperatures in the outer annulus, so in the control trial, it was no better than a sham procedure. Trying to target the sinovertebral nerve, it's a plexiform nerve, it's not really clear that you can truly target it as a unique structure, and there are no controlled or prospective studies on efficacy. In terms of denervation using IDET, intradiscal electrothermal therapy, this was a big thing back in the early part of this century. I did it for several years. Postulated mechanism here is you're putting a thermal wire essentially in the outer annulus, and you're going to generate enough heat that you're going to coagulate those nociceptors in the outer annulus and potentially remodel collagen. There's questionable validation of the in vitro studies. The 8 observational studies, the mean pain reduction was 30 out of 100 on studies, only about 20% had complete pain relief. The reality, and there are 2 randomized control trials. Again, they're not terrible. 40% achieved greater than 50% pain relief. In the second study, there was no effect either with active treatment or sham. But essentially, it's fallen out of practice completely in the United States. Paradoxically, about the time it got its own CPT code, it died from lack of enthusiasm. So here are the randomized control trials and the observational trials. Nucleoplasty. This is using a plasma field to vaporize disc tissue on the theory that you're going to reduce the intradiscal pressure by simply vaporizing part of that disc. Novel. There's really no anatomical rationale for the treatment of using this in the treatment of discogenic pain. The challenge is nuclear pressures are already low. It's already a depressurized nucleus, and we're going to take away some of that nucleus. I don't understand how that might conceivably conceived to work. And observational trials showed only a modest improvement in pain and function, and again, it's fallen out of favor, essentially not done in the U.S. anymore. Biacuplasty is another RF study, or another RF therapy. Observational trials showed benefit. This is now putting an RF needle in the posterolateral corners of the disc and creating a field, a bipolar field between those two RF needles. The idea being that you're going to create a more robust field and generate a very large thermal lesion that you're going to a greater extent than I did, coagulate those posterior annular nociceptors. Of course, many of these things, there were some initial observational trials funded by the startup company showing some benefit. A single randomized sham control trial, the treatment effect was greater than sham. The categorical outcomes, here they define success as the MCID of only 2 out of 10, only 30% had success. I've never figured out what 2 out of 10 means, because in my patients, they can't tell whether 4 out of 10 or 6 out of 10 from one end to another. So even though the literature tells you 2 out of 10 is a valid MCID, it makes little sense to me as a game changer in terms of most people's lives. So it's not a sham procedure, but its clinical effectiveness is of uncertain value, and it's not really caught on effectively in the United States. So why do so many devices get into the marketplace, and why do so many fail? This is a little bit of an aside here. Devices reach the marketplace in the U.S. anyway without significant evidence of efficacy. Cardiovascular devices, for example, from 2000 to 2007, that were cleared by the U.S. FDA by the 510K approval process, most were based on 1 study. Less than a third had any randomized studies. Less than a half had any primary outcomes compared to a control group. So a lot of these devices make it onto the marketplace without really good science. And as I said, the preferred clearance path in the U.S. is the 510K approval process, where a proponent, a company, merely has to show equivalence in function to a pre-existing device. They don't have to show efficacy. And this fundamentally does not safeguard the public. And it's acknowledged to be a flawed process by the Institute of Medicine study in the U.S. Now 9 years ago, but it hasn't been fixed yet. So continually, there's a paradigm referred to as the QRS complex of medical devices. There's this enormous enthusiasm, generally by a study funded by the device company, gets into medical practice, it fails miserably, and sometimes it comes back to a small niche application. So denervation really hasn't been effective when we're targeting the denervation of the disc. But maybe we're looking in the wrong direction. We're talking the disc. How about some other things that are innervated? How about the end plates? Well, there has been some study in the last 3 or 4 years showing that the quantitation of innervation in the end plate is actually of a higher level than in the disc itself. And that there's more innervation in those end plates associated, particularly where we see motic changes on MRI. And that's led to the suggestion that maybe we should be targeting innervation of the end plate, not the disc. And these end plate abnormalities are, as I said, are more frequently innervated and to a greater neural density than disc abnormalities. And they're served by the basovertebral nerve, where this network of neural tissue coming from the end plate aggregates in association with the basovertebral vein in the central aspect of the vertebral body, and then egresses in an afferent pathway through the base positioning in that in those afferents take out nociception to the end plate, and that's the theory behind basivertebral nerve ablation. There's one RCT treatment versus sham, 6 months of chronic low back pain with modic changes. The change in ODI somewhat better than sham, change in VAS slightly better than sham, not dramatically. And this is touted as a positive study, but I don't look at graphs and go, really? It's slightly positive, but not dramatically positive. But it remains a source of some thought that maybe if we can effectively denervate that basivertebral vein via some mechanism, it may have some value. How about intradiscal therapies? Well, we've thrown everything but the kitchen sink into the disc over the last couple of decades. Intradiscal steroids, there's some potential thought process that has validity. We inhibit phospholipase A2, prevent the production of prostaglandins and leukotrienes. There are multiple poorly selected observational series that supported some benefit. One RCT really showed an overall improvement to 21% of those who got methylprednisolone, 9% of those who had just bupivacaine, but not dramatic results. Intradiscal steroids, again, an RCT, no discernible improvements in VAS or ODI in either the active or control group. These are all back in the 80s. So the 2 RCTs without benefit. There's no clear role for the benefit for the treatment of discogenic pain. But recently there has been another study suggesting that there may be some benefit utilizing modic changes as the mechanism. So there's still some uncertainty at play here. Etanercept, TNF-alpha antagonist, that makes some intellectual sense that might have a role. Steve Cohen did one RCT, a dose-ranging study. There's no benefit in pain or disability at 1-month follow-up, and that really hasn't been pursued any further. Methylene blue, a couple years ago, study out of China. This was all the rage. It was an unbelievably positive RCT. How could something that's so benign potentially be so therapeutic? Well, no one's been able to reproduce the RCT. If you believe what it said, the NRS went from 72 out of 100 to 20 out of 100, and the ODI went from 48 to 13. I mean, that would be wonderful if that were indeed true. The challenge is that you have to replicate it, and there's been no substantial replication to date, so it's certainly not become something that's utilized in the United States. Antibiotics, again in Europe, this is still out there, and this is a concept that's been around for 20 years. That potentially single-level advanced disc quote-unquote degeneration, particularly in young people, maybe a low virulence infection, particularly P. acnes. There's always the thought that this is going to be the helicobacter of the spine. The Albert study, an RCT in patients with discogenic pain, they got 100 days of amoxicillin, and they did indeed show benefit with a trend towards a dose-response relationship. Begs replication. It's a long time of constant antibiotics, but there are proponents out there saying this is that this is the way to go, and I know there are some other studies ongoing to try and replicate that. Reparative strategies have been tried. Weighed in, one of our SIS members utilized fibrin sealants to try and direct this towards an annular fissure, and then also deliver other agents to the disc to try and seal that annular fissure. That would be a regenerative or a reparative strategy. He did a small pilot study. I did have one case of discitis. There was some evidence of efficacy, however, that prompted a larger RCT. And it essentially failed. But to his credit, they reported the failed study, and that's again fallen out of practice. And so we're left with potential regenerative medicine. And this, in the United States, this is the way everybody is all enthused about delivering stem cells to the disc in the hopes that they will differentiate into nucleus pulposus cells and increase the production of extracellular matrix, produce more trophic factors, again stimulating disc cell production, increase cytokines that will diminish inflammation. There's been a large meta-analysis of all animal trials suggesting that stem cells within disc can indeed arrest degeneration, to change MRI signaling characteristics, and promote regeneration. Of course, all those animal trials are quadrupeds, not bipeds. And now there's been a systematic review of human trials. There are 6 qualifying completed trials. There are no adverse events. All reported significant improvements in pain and function, improved water content in the treated discs measured by MRI. There are now 5 additional ongoing trials, and SIS, in collaboration with the American Board of Regenerative Medicine, is updating a systematic review of human trials. So there's some positive early data that this might be valuable, but I think it remains unclear whether this is indeed the answer. So it's a long saga of 20 years of challenges and failed therapies. So an extensive literature over a 50-year period validating disc stimulation. It's a reasonable diagnostic tool. A tortuous and as yet not completely successful journey seeking a safe and effective method for minimally invasively treating discogenic pain. A lot of the early attempts focused on destructive techniques or denervation techniques, and many were failures due to their focus on devices without any sound underlying science. There's still some intriguing results, more recently with steroids and antibiotics, but they beg replication. And then the regenerative medicine phenomena remains very interesting. We'll see how that pans out. Our society only advocates for interventional therapies when they are clearly soundly based on irrefutable evidence. We're not to that point yet, but we're going to watch very carefully. And if it's something that does indeed reach that level, then we will enthusiastically support it. Thank you very much for your attention. And again, thank you for hosting me here. I really appreciate the opportunity to speak here.
Thank you, Dr. Moss, for this interesting presentation about treatment of discogenic pain. Now, Professor Rahim Omes, who is the professor in the Division of Neurosurgery at AUB Medical Center, will give a lecture about low back pain without radiculopathy, evidence-based approach to surgical management. Dr. Omes.
Thank you for inviting me to this conference. I was asked to talk about it's not bad. Chronic low back pain without radiculopathy. What's the perspective on surgical management to that? So I'll talk about evidence-based to surgical management of back pain, or specifically chronic non-specific low back pain, and how can we manage this surgically? Or there's a role for us in this. So I'll start with a case example. This is a 33-year-old female who is a pharmacist who had chronic low back pain, really tried everything from medication to epidural steroid injection, Facet injections, physical therapy, chiropractic, still no relief, and she started taking a lot of sick leaves. Her ODI was a little bit high, not happy with her pain. Basically, she stands on her feet all day long in the pharmacy, and she needed something done to her. If you look at her MRI, really, she didn't have any ridiculous symptoms except back pain, and it's worse when she stands. If you look at the lower of this picture here, you see there's a degenerative disc there, not compressing the nerves. And if you get some x-rays there, you see, again, there's degeneration there. You see there's maybe a little bit of hyperlordosis. When you do flexion extension, there's not much that can move with this. And you can see, so the extension is on my right and the flexion is on the left side. And then you do this long scoliotic x-ray, and you see like she has good lordosis compared to her pelvic parameters, and she has a good sagittal vertical axis. Now, what's causing her pain? And when she comes to me as a surgeon, I mean, there's a few questions that I need to ask. It's like, what else can we offer her? Can we consider surgery? And if yes, what can we offer her? What kind of surgery can we do to her? Well, what should we tell the patient regarding clinical outcome? Okay, you're going to take this patient, undergo surgery, she's going to take post-operative care for a few months to heal, and then she's going to ask you, am I going to be better? Am I going to go back to my life? I'm married, I have kids. But we have to take also into consideration the risk associated with this kind of surgery that you offer this patient. So all these things, you have to put them together when you talk to somebody about non-specific low back pain or any surgery that you offer. So talking to her, you know, for many, many times, and actually I offered her, you said, you know what, I'm going to do surgery to you, I'm going to do it from the front, a small incision, not to disrupt the muscles, and we do what we call an A-lift, just to stand alone. And that's what we did. She did very well, actually, and she healed very well. Her ODI went down, her VAS went down, and she went back to work, and she was happy. But it was it's a gut feeling, to be frank with you, and you'll be surprised why I say that, is to offer somebody surgery, a big surgery, and then try to, you know, make sure that they go through the surgery smooth, and then they do well after surgery. Maybe at the end of this, I'll give my reasoning why I offered her surgery. So the outlines of this talk is really to talk about low back pain, the prevalence, issues with chronic non-specific low back pains, refer to surgery, how do we measure outcome, confounding factors with the non-specific low back pains, and what does the literature say about surgical treatment of this kind of disease, and then to summarize at the end. So it's a major public health problem, the leading cause of disability for people less than 45. It's the second leading cause of physician's visit. You know, every other patient comes to the doctor, the family practitioner, is a back pain problem. And I start seeing it here in Lebanon when I moved here. You just people who had just back pain for one day, they come to you and they say, what can we do? You just prescribe them some NSAID or even Tylenol, and it'll work fine. It's a lifetime prevalence is almost 80%. So it's not something that we take it easy. You can see this is if you look at the different types of pain in the body, musculoskeletal, you see low back pain is one of the highest. And if you look at the number of patients in the US, they're having back pain, and even the visit, actually I can't see it here, the visit that's going through the years is going more and more frequent. You're going to the doctor just to go for back pain. So, in other words, it's a benign neglect. Most studies suggest that it's a self-limited disease. Dramatic improvement happens in 1 to several weeks. You just stay cool. Improvement is part of a natural history. 80% in 2 weeks will just get better on their own. Okay? So this is a study from the Netherlands where it's a natural history to look at people who have back pain over a 1-year period, 15 general practice in Amsterdam, 269 patients, completed the survey. People want to start having less pain, they start answering to the survey, basically. And 7 weeks was the median time to recover from this episode. At 12 weeks, 35% have still back pain. At 52 weeks, only 10% had low back pain. 75% had 1 or more relapses during the study. So in 1 year, if you had 1 episode of back pain, about 70% of these patients may have another relapse of back pain. Pain and disability were less during the relapses. So the second time you get an episode of back pain, it's less. And time to relapse is about 7 weeks. So you get better for about 6-7 weeks, and you have another one. And the duration is almost 6 weeks. So as you can see, it's not something easy, but it's an annoying problem that goes on and on and on. Now, you have to look at these low back pain. What kind of pain do we have? So you have to stratify pain, the mechanical, and the rheumatological, infectious, neoplastic, endocrinological, referred pain, hematologic, neurological, psychiatric, and miscellaneous. So first, you have to really know what kind of pain we're talking about. And the problem with this non-specific low back pain is unable to diagnose it. So it's up to 85% of patients cannot be given a definitive diagnosis because of a weak association among symptoms, pathological changes, and imaging results. You know, somebody comes to you, they have back pain, and basically, you look at their MRI, X-rays, you do everything, you do a nuclear scan, and really nothing shows. And then, so what do you do with these things? But here's a good study. It's a little bit old, but the New England Journal of Medicine, 2001, where it tells you like asymptomatic adults walking on the street, they have no back pain, they just invite them to do an MRI, and look what they have. Almost 90% if you're over 60, you have a degenerative disc. If you're less than 60 or younger than 60, 50% they have degenerative disc in addition to other problems. If you're younger, in your 30s, you have 70% degenerative disc. So you have at least 1 degenerative disc. So putting this into your equation, how you're going to treat patients with low back pain when you just automatically prescribe them, order them an MRI or an X-ray, You're going into a path where you feel like you may not be happy if you offer them surgery, anybody who has degenerative disc. So non-specific low back pain is really unable to diagnose because of secondary gains. You have to take that into consideration. There are psychological issues as well. You have to take that into considerations. Okay, first we have to eliminate red flags. Older age, significant trauma, and such, and all that stuff. So once you eliminate red flags, then you start, going down to say, what can we do? Treatment options, my colleagues previously, they spoke about all these different things, and really what you get out of them is a combination of things you offer to the patients. Maybe, maybe not. Not everybody will get better because of the different etiology of this back pain. So referral to surgery. The clinical question that you might want to ask is, what are the indications for referral to surgery based on the effectiveness of surgical treatment? So if I'm going to refer somebody to a surgeon, is he going to get better or not? And based on what? So you have to compare if you're going to operate on them versus not operate on them, and then to look at how much they're going to get better with pain, functional disability, or psychological distress, right? So clinical outcomes, how do we measure it in spine surgery or spinal disorder? ODI, the disability index, SF36, VAS, and such. But these are the main ones that we usually talk about. And there's the radiographic outcome. Means somebody comes to you, you offer them surgery, you do the surgery, and you get the x-ray. It's like, voila, there's a good fusion, but the patient's like, I'm still in pain. I didn't improve, but the picture looks good. So that's radiographic outcome. And then you have to kind of go into this, and then, so there's a big difference between the two. So in between, when you offer somebody surgery, complications, length of stay, and adherence to protocols, how are you going to do things when you talk about it? Now, how do we clinical efficacy? If you offer somebody something, it's like the minimal clinically important difference is the amount of improvement that has actual utility. Really, patient recognize that really he got better, meaning like, does that function in society or not? So it's different from statistically significant because, you know what? You can have a statistically significant difference in something, but to the patient himself or herself doesn't mean anything. Somebody has COPD, you increase their oxygen by 10%, but yet they still walk the same 50 meters that they used to walk before the medications. So it has no difference. So in lumbar surgery, 454 surgery patients from the lumbar study group with 1-year follow-up, pre-op and post-op, they did all that things. And what you see, if you have a clinically significant difference to change, is you need 13 points change in ODI, 5 points for the physical component in the SF, and 1.5 for VAS, back, and leg pain. So if you don't accomplish these things, meaning you didn't really offer anything to the patient to make their life better. So success of spinal surgery, we know if you go straight to these things that we know that they have big problems, the success, 90% in AIS, the scoliosis in adolescents, cervical disc, lumbar disc, ischic spondy, degenerative spondy, they all high numbers, they improve. Single level degenerative disc, if you offer them and you feel like this is really discogenic pain, 60% will improve. But if you have multiple levels, the success rates start going down. If you do revision surgery, the success rate goes down to almost 40. Right? So chronic non-specific confounding factors, and these are some studies that people looked at, like how to choose your patient when somebody comes to you with non-specific low back pain. Really, so 65% were diagnosed with at least one current psychiatric disorder compared with only 15% of the general populations. So whether there's a direct relationship between the pain and have psychiatric problems is a big question. So major depression, substance abuse, anxiety, and personality disorder. Second, another paper said if you have a single lumbar fusion for chronic nonspecific, mental component. So there's a relationship between the physical component and the mental component. Patients who they score bad on the mental component, they're not going to do well on the physical component. So this is another thing. So so the psychological component has a negative impact on the clinical outcome of these patients. So fusion versus non-operative management of chronic neck pain, so psychological disorders affect chronic low back pain with depression, all these things, you really have to preferentially try not to offer them surgery because, again, this is another study in just in a different way. If they have psychiatric problems, really you have to stay away from surgery. Probably they're not going to do very, very well with these things here. So how do you select your patients? If there's litigation, you have to be careful with these things. Probably in the Western world is different from here. Social demographic is not a factor, but fusion may have better outcomes than non-operative treatment, basically. Okay, so surgical treatments. Let's look, what does the literature say? Okay, let's go over some big studies that have been done in the past and see what they do. So the first one that most surgeons talk about when somebody comes in and they refer to is the Fritzl study, right? So they basically have non-surgical and surgical patients, and they offer them surgery, whether it's just without instrumentation, means no fusion, but they didn't put screws and rods. They put screws and rods where they did circumferential, means go front, back, or they did intradiscal surgery as well. The complication is not less, it's not low, 6%, 16%, even 30%. So you have to. So all surgical techniques were found to reduce pain and decrease disability substantially. Now there's a problem with this study here, is the criticism is how the surgery was chosen and the physical therapy. So they offer patients physical therapy, but they didn't follow. So I write a prescription to a patient, tell them, go do physical therapy, come back in 4 weeks. Whether they did it or not, but on the record it says that I offered him physical therapy, and I'm not sure how well he did with the physical therapy, whether he did it or not, how many sessions he did, and what did they do with the physical. So it was not structured. So surgical group more felt better, able to go back to work, okay? Another one, the Fairbanks study, and the conclusion from this, really, surgery, they did a little bit better. The estimated mean difference between the two is about 4 points, but there's a significance with that. And basically, another study, the Brock's one, and again, but this is different. They did cognitive intervention, means in addition to physical therapy, they did cognitive rehabilitations. And actually, the conclusion was between the two groups, actually, there was equal improvement. So there was no difference between the two groups. So if you do meta-analysis on this, what does it say is spinal fusion should be reserved only for a small group of selected individuals who fail to respond to a combined physical and psychological intervention, and where referral for an opinion on spinal fusion may be appropriate. So you go through the physical therapy, psychological assessment, and this was like a routine where I used to work in the US in Houston, is where somebody comes in with chronic low back pain. You really always get a psychological assessment to see how they do and what's the expectation from this kind of surgery that you want to offer them. So again, here results, another one is meta-analysis. Surgical procedure may be more efficacious when compared to unstructured non-surgical treatment, however, not so when compared to structured or cognitive rehabilitation. So if you offer a chaotic physical therapy, they're not going to do well. Surgery will be better, obviously, but if you structure the physical therapy and cognitive rehab, there may not be a difference. So this is all to put it all together here, and just to show you, in the ODI change, really, there's not much difference if you compare the two groups here when it comes to this. All right, so long-term follow-up on these studies, if you look at it, so this is 11 years, mean about 15 years, between 8 to 15. And actually, the conclusion with this is surgery should not be favored in healthcare systems where multidisciplinary cognitive behavior and exercise programs are available. So if you're in a society where they have a good rehab programs, cognitive rehab, psychological assessment, and treatment, maybe surgery is not the best thing to offer them. But maybe it changed, I'm not sure. So the consensus at last, just the title says it here, fusion is no better than non-operative care in improving pain and disability in chronic low back pain. Okay, and the other one here, this is another article which it tells you like the reason for this is, if you look at the kind of trials they're doing, and what my colleague was mentioning, is the kind of trials you're doing here, the indication trials, meaning what to do and what kind of treatment you need to offer, is different from the technical trials, meaning like you offer ALIF, come from the front, back, the side, all that stuff. But we haven't even yet answered the question whether low back pain needs to be treated with surgery or not. All these clinical trials is what they're doing. Okay, I'm going to try this kind of an approach to this back pain, but we don't know whether that's the right way of doing it. So there's a problem in the clinical trials, as you can see, is indication trials is very low. So if you look at 2006 and before, only 4 clinical trials. After 2007, only 2 clinical trials. So refer for surgery, this is from England actually, and this is their recommendations. You consider refer for an opinion on spinal fusion for people who, because this is a universal healthcare system in England, so that's why most people go to family practice first and then they refer them. Have completed an optimal package of care including combined physical therapy, psychological treatment program, and still have severe non-specific low back pain for which the patient is willing to go surgery. So you really have to ask the patient, are you willing to go for surgery for this or not? And offer anyone with psychological distress appropriate treatment prior to refer them for fusion or for surgery. So you have to do not refer people for any of the following procedures: the IDET, the percutaneous intradiscal radiofrequency thermocoagulation, or radiofrequency facet joint denervation. Sorry, but that's what they are. Christina was looking at me. So. Anyway, so this is kind of a simple algorithm for surgical referrals. If you have pain for a few weeks and you have pure low back pain, you really have to go through psychosocial evaluation, intensive physical therapy, cognitive rehabilitation. If there's improvement, continue with that. If not, think of surgical referral. If you have radiculopathy and then like nerve pain and all that stuff, that's a completely different topic, obviously, and it has its own path of treatment. So back to our case, why did she do very well? I think my case, and I think just if you several reasons for this is could it be removal of degenerative disc and basically decorticating the end plates, eliminated the pain source. No, the second thing, decreased facet load, the axial load, because now you can look between the two. You really distract a little bit the facet joints. And 3, normalize the adjacent disc shape. If you look at the disc shape between the two, you can see maybe so there's less disc bulge on her, okay? And not much muscle injury. You went from the front. Maybe she would have a lot of muscle pain from post-surgery, failed back surgery or so. Increased focal lordosis, less stress on the adjacent disc like we talked. So in summary, low back pain, 90% of the people will experience it, high cost to society, and it's still rising, can be difficult to nail the underlying cause and subsequently diagnose it correctly. Psychosocial overlays, low back pain without radiculopathy, no one treatment has been convincingly shown to be effective. Combination treatment appears to be the key. Empower the patient to take control and be an active participant. What about surgery? I leave this message. There's some evidence to suggest in carefully selected patients with a defined diagnosis may benefit from surgical intervention. Careful attention to the diagnosis, eliminate, minimize psychosocial negative factors before you offer surgery. And thank you.
Thank you, Dr. Ames, for this interesting and very clear presentation.
You want to introduce yourself? Now, I'll introduce my colleague, Dr. Joseph Mahraoui, who is an associate professor at the Jesuit University, Hotel Dieu. He's a neurosurgeon there. He's a director of the Lab of Neurosciences and Faculty of Medicine. He has multiple diplomas in neurosurgery, general medicine, and he's a fellow in functional neurosurgery from Lyon, France. He has a microsurgery diploma from St. Joseph University. He's a pain specialist. He's a master in neuroscience. He has a PhD in neuroscience as well. He has a university diploma in medical sciences in education level 1 and 2. He has a habilitation for research direction from Claude Bernard University, Lyon, France, and he has multiple publications, more than 65. And actually, I need to commend him for the last prize he got from CNS, actually. Neurosurgery has the best research paper done in 2018. So congratulations again, Dr. Mahraoui.
During this presentation, I will talk about during this presentation, I will talk about the indications and updates of neuromodulation in the so-called failed back surgery syndrome. About disclosure, since 2008, I'm proctoring spinal cord stimulation and intrathecal baclofen, intrathecal pump implantation with Medtronic in all Arab countries and North Africa. I will begin with some clinical cases. As you see here, this is a male of 37 years old who presented with a right sciatica, and as you see here, he had a classic lumbar disc disease at L5-S1. He was operated in Lebanon by a surgeon who did a discectomy, but I did not why he do a lumbar fusion at L5-S1. After surgery, right sciatica disappeared, but the patient is suffering now from a left sciatica, and he was referred to me for spinal cord stimulation as neuropathic pain. And when I did a new MRI, as you see here, the screw touched the left L5 nerve root. So, of course, in this case, I will not do a spinal cord stimulation. I remove the screw and reorient it, and the patient after did very well. Another cases, we are seeing too much of these cases in Lebanon. This is a case of an extreme obese patient. As you see here, the surgeon put 3 screws. I showed only 1 screw, put three screws inside the lumbar canal. And it was referred for a spinal cord stimulation. So first of all, we have to remove the screw from inside the spinal canal. A second case here of a patient having a L5S1 classic disc disease. The surgeon put this device, interspinous spacer, without removing the disc. So the patient had the same sciatica after the operation, and all what I do, I remove this and do a classical microdissectomy. So this is not an indication. All these patients were referred to me for spinal cord stimulation. You see this case also. This patient was referred also for a spinal cord stimulation. He had right sciatica, and as you see here, his surgeon put 8 screws, but missed the only symptomatic disc disease. He did not treated the L5S1 spondylolisthesis with the disc disease at this level. A last case here of an excellent post-operative L4, L5 PLIF, but the disease was at L5S1 and not at L4, L5, unfortunately. And as you see here, around 60% of my spine activity is redo surgery because of either bad indication or bad result. So the indications of spinal cord stimulation are very rare. What is neuropathic sciatica in the context of what we call the failed back surgery syndrome? As you know, this is an abnormal clinical evolution after a surgery for a lumbar disc disease. First of all, as you see before in my examples, we have to rule out persistent compression before considering a functional neurosurgery for pain. The typical clinical picture of what we call neuropathic sciatica are delay of onset, that is, the patient is operated today, the pain will appear in several weeks to several months. It is typical. The pain is non-mechanical. We have a persistent pain with paroxysm. This is typical of neuropathic pain. Sensory deficit is very important to prove in a patient with a neuropathic pain. And finally, when we do imaging, we have no persistent compression or what we call epidural fibrosis. I am surprised in some cases, I see colleagues proposing for the patient to what we call dissect the epidural fibrosis. Epidural fibrosis is not a disease. This is a signature of the instrument of the surgeon. So the disease is inside the nerve. So if they dissect this fibrosis, the patient will be worse after the surgery. Spinal cord stimulation is indicated especially in what we call neuropathic sciatica. I will not go through the mechanisms of neuropathic pain. They are very complex, but to give you a schematic approach, the neuropathic pain results from an imbalance between excitatory and inhibitory pathways, and neuromodulation techniques act by enhancing inhibitory pathways. In the past, some authors have considered spinal cord stimulation as a placebo surgery. My patron in neuroscience, Garcia Laria, was the first to describe a physiological effect after the implantation of spinal cord stimulation in France. And as you see here, the R3 spinal nociceptive reflex was decreased under spinal cord stimulation, which means that spinal cord stimulation is not a placebo. It is a procedure which will yield to a physiological effect. Technically, spinal cord stimulation implantation is done in 3 steps. The first step is the implantation of a lead, either percutaneously or surgically. The second step is to do what we call a trial period with an external generator for 1, 2, 3 weeks, depending on our habit. And finally, if the trial period is positive, we will proceed with the final implantation of the generator. Of course, we have false positive and false negative, but this is the procedure. The percutaneous technique consists of introducing of a lead using a Tuohy needle inside the epidural space, and we navigate inside under fluoroscopy in order to reach the optimal site of stimulation. The optimal site is where the patient will have induced paresthesia covering the territory of pain. The advantage are that we can rely on the cooperation of the patient to implant, to choose the exact site of the stimulation of the lead. And of course, it is a mini-invasive technique done under local anesthesia. But the major inconvenience of the percutaneous technique is that we have a high risk of lead displacement. The surgical technique is very easy for a neurosurgeon. It is done using an interlaminar approach, and we will insert the lead, the surgical lead. The advantage that we have less risk of displacement, but the major inconvenience that this is a surgical approach. And second, if we want to reposition our lead, we will do another surgery for the patient. For the percutaneous test, that is the lead connected to an external generator, the criteria for permanent implantation of the generator are paresthesia covering the painful territory, of course a positive effect on pain, and finally paresthesia which is well tolerated by the patients. But what about patient selection criteria? As you see here, we did not implant a spinal cord stimulation before 12 or 18 months of evolution of a chronic neuropathic pain. Especially, we do implantation especially when we have predominant radicular pain and not low back pain, when we have absence of residual treatable cause of pain, and when, of course, we have a well-documented lack of efficacy of the classical anti-neuropathic drugs. Of course, absence of psychiatric or surgical contraindication, normal central conduction time on SSEP, which means somatosensory evoked potential, and finally, as I stated before, a positive, what we call a positive percutaneous test. As you see here, these are the result of a published article by my patron in neurosurgery, Marc Sandou. As you see here, when we have abnormal central conduction time on SSEP, we have 0% of the patients which are relieved more than 50% after a spinal cord stimulation. So somatosensory evoked potential are very important in order to select our patient for spinal cord stimulation. Here, my personal series, not updated since several years, is of 58 patients with failed back, with the so-called failed back surgery syndrome. And as you see here, 35 patients of the 58 has normal style of life after surgery, and 32 of them has resumed their work. It is like the classical picture in the literature, perhaps a little morbid, excellent result, because I am very selective in my indication for spinal cord stimulation. 2 cases of infection regarding complications. So we have 2 cases of infection, 2 cases of lead migration or lead rupture, and only 1 case of transient CSF leakage after the leakage syndrome, of course, after the implantation. Now, what about the new methods of spinal cord stimulation? Till now, I did not use them, so I have no experience with these new modalities. The first of them is what we call the dorsal root ganglion stimulation. Now, we have several evidence in the literature about their utilities especially in the complex regional pain syndrome. They may provide greater pain relief, fewer paresthesia, and better outcome. And the most important is that we have less rate of migration by percutaneous technique, and especially lack of positional side effect, because after spinal cord stimulation, especially the percutaneous technique, the major problem of our patient is sometimes when they move, they feel the paresthesia sometimes very unbearable for them. So it is a major problem after spinal cord stimulation. The second new technique of spinal cord stimulation is what we call the high-frequency spinal cord stimulation. It provides, theoretically, a pain relief without paresthesia. As you know, the problems of conventional spinal cord stimulation is variability according to position, the variability of paresthesia, and the limitation by maximal tolerable amplitude. So we cannot sometimes increase the amplitude because the paresthesia induced by the spinal cord stimulation are unbearable by the patient. So maybe the high-frequency spinal cord stimulation without induced paresthesia offer here a advantage over the classical spinal cord stimulation. And as we have no paresthesia at all, there is no need to a paresthesia mapping during the procedure, so the procedure is very short when we implant our lead. And for the surgeon only, this is a very easy procedure. We don't have to map anything. In the cervical spine, we put our lead from C2 to C7. It will cover all the spinal cord. And for the lower back and for radicular pain, we put the lead from the thoracic level 8 to thoracic level 11. So it is a very easy procedure. And according to the literature, I have no experience, I told you, in this new modality. They said that it is at least as effective as the classical spinal cord stimulation. In conclusion, in order to get the best result after a spine surgery, we have to avoid the misuse and the overuse of instrumentation in spine surgery, which is a major problem nowadays in Lebanon, and I think it is a worldwide problem now. We have always to keep in mind that the objective of a spine surgery is especially to relieve a nerve compression, of course, except for spinal deformity surgery. But when we have a problem, a patient facing a radicular pain, our objective is not to put 10 screws or 4 screws or material in his back. Our objective is to relieve his radicular pain. So in the absence of, when we have a patient with absence of residual anatomical cause for his neuropathic pain, spinal cord stimulation can be very effective to control especially the radicular pain, but in most cases the low back pain is also controlled, but in well-selected patients. So in order to get good and excellent result, we have to respect the indications for spinal cord stimulation. And the new techniques of neuromodulation are attractive and need, of course, to be validated in the literature. Thank you for your attention.
We'll move on to the following talk by Dr. Tariq Sunnah, who is a clinical instructor here at AUB in the Division of Neurosurgery. Dr. Tariq will speak to us about the minimally invasive spine procedures in the treatment of back pain.
So, good afternoon, everyone. Thank you, Dr. Kanaza, first for inviting me to this conference. So, I'm going to give you a quick view of some of the minimally invasive approaches that we use in the treatment of radiculopathy or in back pain secondary to degenerative spine disease. So, like in any new approach, whenever we want to use a new surgical technique or new approach, I think that the main question that I'd like to ask is why would we want to go there? So the first question is why would I want to go minimally invasive instead of the regular open approach? So mainly the main advantages are the approach-related morbidities like the muscle retraction, the damage, the denervation of the facets, the blood loss, the chances of infection, post-operative pain, early mobilization, and hospitalization duration. So there are many studies dating back to the 70s that showed that open approach or muscle injury intraoperatively, even with a minimal retraction or denervation, most biomechanical studies have shown at least 30% decrease in most of the parameters relative to the normal values after surgery. So what can be done minimally invasive? The surgical methods, we can do decompression, fusion, instrumentation, altering alignment, the sagittal balance, tumor resection, infection, and trauma, aiming to relieve axial pain, the neurologic pain, to restore balance, and to prevent adjacent level disease. So surgically, the indications are for disc herniation, if people present with central stenosis, foraminal stenosis, fractures, instability, and even for tumors and infection. So the eligibility criteria for people to undergo an MIS is quite wide. So for those who are not familiar with the MIS approach, just to give you an overview of the equipment that we use. So these are the dilators on the, which one is the cursor? Okay. So these are the dilators that we use going up depending on the size of the tube that we want to use, depending on the pathology. And then we insert the tube here with the source light along with the retractor arm to hold the tube in place. Of course, the marking and the operation is done under fluoroscopy guidance and with the help of the operating microscope. So for many people, even spine surgeons who are classic spine surgeons, they consider that minimally invasive spine surgery is the same spine surgery but through a smaller hole. It's actually what I teach my residents is that it's a completely different anatomy, because what you're actually looking, if you're operating through a regular approach, would be something like that. However, when you're operating through a tube, this is what would you be actually seeing if you're doing a TLIF, for example, or this is a 22 millimeter tube. Through this, I usually resect tumors or do a TLIF through this size of a tube. So it's not actually the vision that you would expect in comparison to the open approach. On top of that, if you're doing a discectomy, the view that you would be seeing is this small. So it is not the same anatomy that you would be seeing on the open approach. So that's why it is a steep learning curve to be doing these operations. Our incisions are paraspinal. We don't do them in the midline, depending on what the pathology is. From 1 centimeter if it's a disc to 1.5 centimeter if it's a disc disease, up to 4 to 4.5 if we're doing a TLIF or a percutaneous screw. So just to give you a couple of cases, for example, this is a disc disease. Patient presented with L4-5 disc, tip radiculopathy. After failing conservative treatment, the patient was referred to a MIS microdiscectomy. So the patient underwent MIS. Here, I just wanted to show you, under fluoroscopy, we mark where our tube needs to be to make sure on AP and lateral views that we are on the right level. And the incision in this case would be approximately 1.5 centimeters, and through which the disc can be approached using the regular microsurgical techniques. And there are many studies in the literature that showed that the clinical outcome of minimally invasive tubular microdiscectomy is comparable. This is very important because no one is claiming that MIS achieves a better surgical result. It should achieve an equal surgical result to open approach, however, with less approach-related morbidity. And another pathology that is very important in MIS are far lateral disc herniations. So this is a case where this patient had a far lateral disc herniation. Now, some surgeons There are two approaches that are used to resect these herniations. Some people go through the regular paramedian incision, where they would end up removing the facet and then reaching the fragment, ending up fusing the patient. Other surgeons, they do the Wiltse approach or the paramedian approach, where they would do a huge incision, especially in obese patients, in order to be able to reach these herniations. However, with MIS tube, all you do is just do a simple incision, 2 centimeter incision, because this is the area. This is the area where we need to be. Okay. So this is the nerve root exiting. This is the lateral aspect of the pars, and this is where the herniation would be. So putting the tube, this is what we would be seeing. Again, this is the lateral aspect of the pars, the superior aspect, the superior TPs. The root would be here, and the fragment would be here. This is the view through an 80 millimeter tube, 1.8 millimeter, 80 millimeter tube. So this is here, we can see the nerve root and the fragment just in front of us. And we did not even have to remove a single millimeter of bone to remove this disc fragment. Thus avoiding this destabilizing effect of surgery and fusion for the patient. Facet cysts are my personal favorite, because these patients, most of the surgeons that are operating these cases are ending up fusing the patient, because they go from the ipsilateral approach, they go through the facet. Already, the presence of a facet cyst is a sign of destability and instability in the spine. So to go ahead and destabilize it even more by removing the facet, these patients will end up, if not at the same procedure, but soon afterwards requiring a fusion. So what I actually do for these patients is I do not go from the same side. I go from the contralateral side through a small laminotomy. And then I drill the base of the spinous process, and then I go flush in front of the cyst, not removing any part of the facet. The same thing, the same approach I use for foraminal stenosis. We have many patients that present to us with scoliosis, kyphoscoliosis, that have a very bad spine, but their main complaint is radiculopathy, just leg pain. For example, it's a foraminal stenosis at this level. So most surgeons would offer these patients a T9 down to ilium or T4 down to ilium cases to relieve their leg pain and correct their scoliosis, while all that can be done for these patients under certain conditions is just a contralateral foraminotomy. The same thing where you would approach the foramen contralaterally and decompress it, as I'm going to show you now. So this patient, my protocol is I do an MRI for these patients. If I see the cyst is hyper on T2, I send them to the anesthesiologist, because usually they have a higher chance of being aspirated under CT guidance. If they're hypo on T2, if they're dark, this usually means that they're not going to be successful in aspirating them. Still, I do send them to the anesthesiologist to give it a trial before the surgery. But most of them, they do fail. After that, we offer the surgery, and I go with as I said, with the contralateral approach to remove these facet cysts. This is the intraoperative marking. We put the tube on the contralateral side to be at the edge of the lamina and the spinous process. And here we drill, as you can see, we've drilled the base of the spinous process and the lamina, and the Woodson dissector, the instrument that's here, it's coming from the left side to the right, reaching the right foramen. So you can actually go completely and decompress the contralateral foramen from the same approach, or remove the facet cyst in this case. So this is the direction that we use. What if we have bilateral facet cysts? Still, we can do bilateral contralateral approach if you want to avoid the patient the fusion, or to give him a higher chance of not getting a fusion. So this patient underwent bilateral contralateral approach. Here we can see the CT scan where it shows a small laminotomy that was done with the drilling of the base of the spinous process that allowed us to go approach the right side from the left and the left side from the right without touching any of the bone of the facets. Thoracic discs are also causes of back pain, where patients present to us like this with a disc herniation compressing the cord. On a CT scan, it was heavily calcified. Most of surgeons, they try to approach these with a lateral approach, since it is called calcified, or anterior approach. However, still we've done these with MIS, posterolateral approach, where we drill the lamina, the facet, and part of the T-piece, and then we drill part of the vertebral body in front of the disc, and then using a Scoville curette or an angled curette, we push it into the vertebral body. This is the marking intraoperatively of the tube, and this is the postoperative result showing the removal of the calcified herniated fragment. So minimally invasive lumbar fusion is one of the approaches that we use to treat spondylolisthesis. We have many approaches: PLIF, ALIF going anterior, or TLIF going posterior. Now, the indications for these are either if we have listhesis, recurrent back pain, discogenic pain. Also, it's a really the indication of discogenic pain needs to be really tailored to each patient, as Dr. Ames said. Recurrent herniated disc, post-discectomy collapse, pseudoarthrosis, post-laminectomy kyphosis, and correction of sagittal balance. These are usually the indications why we would use these procedures. So why would I want to do them MIS? Because roughly, just instead of having this, we would be having these small incisions to achieve the same instrumentation. TLIF technically is just involving removal of the inferior articular process. Then we go into the disc space, we shave the end plates, we prepare them, and then we insert the cage inside, and then we put the percutaneous screws from the back. And we compress the elements to allow the bone to fuse under pressure. So this is a case of recurrent herniation with severe back pain. Again, this patient was planned for a TLIF. So this is the two incisions that we make, approximately 2.5 centimeters in length, with 4.5 centimeters off midline. We usually go with the tube on the more symptomatic, in this case it was the right side. So we go with the tube, we decompress the ipsilateral and the contralateral foramen, as I just explained earlier, and we remove the disc. Here we can see that with the tube we decompressed ipsilaterally. We can see the instrument, it has crossed to the contralateral foramen. We have also decompressed the contralateral side. And then we insert our cage into the vertebral, into the disc space after preparation. And these are the guide wires for insertion of the percutaneous screws. And these are the incisions post-operatively. This is the final result on X-ray. So also listhesis is one of the main causes of back pain. This is a patient who presented with dynamic listhesis with severe back pain and radiculopathy. Also, again, here we can see it on X-ray. And again, minimally invasive technique. Using the minimally invasive technique, doing a TLIF, we can reduce these listhesis and fuse them with, this is the final result. Instead of doing a big incision, we just do them through the small incisions, reducing the muscle morbidity and the destruction of the muscles of this approach. Another thing is for a higher grade listhesis, still MIS is an option. However, we'd like to take a better purchase of both, so we go one level higher in these cases. In this case, we had to go up to L4, where we fused 4, 5, and 1. Also minimally invasive, where we do a discectomy of 4, 5, 5, 1, and then we instrument them and put the cages MIS. Even for a much higher listhesis, this is the final result on X-ray. Even for spondyloptosis, we can do them MIS, and we can actually do a transsacral rod, where we can insert it for spondyloptosis. Not in this case, in higher grades, even MIS, it can be done MIS. So this is the final result with the cages from 4 to 1. Of course, the reduction, I'm usually not overzealous in reducing these patients to grade 0 to avoid having postoperative radiculopathy. So I usually reduce them back to grade 1 when they have high-grade listhesis. Oblique lumbar interbody fusion is actually a new technique. It started in 2012. Most of the studies, they showed that it is safe to do from L2 to L5. They avoid doing it from L5 to S1 because of the iliolumbar vein or the ascending lumbar vein. However, we devised a technique where we actually proved it is also safe for L5 to S1 as well. I'm going to show you that. So the concept of an OLIF is that you want it to achieve fusion similar to an ALIF, which is going anterior, however, without the complications of the ALIF. We don't like the ALIF a lot because it has, first, you're going in between the vessels, and it's dangerous, more dangerous to go in between the vessels. Second, no matter how meticulous you are, I've seen a lot of patients due to injury of the superior hypogastric plexus developing dyspareunia in females and retrograde ejaculation in males. So to avoid that, the OLIF is the new approach to do that. The surgical technique is we put the patient on the lateral decubitus position. Now, if the patient did not have any coronal imbalance, I usually go to the left, through the left side, because I'd rather deal with the aorta rather than dealing with the vena cava. If the patient had scoliosis, then you would go from the concave side to achieve a better, to have an approach to more levels from the same side. So our incision is approximately 2 fingers anterior to the iliac crest. We do our incision down to the external oblique fascia. We open it, and then we expose the internal oblique, going down to the transversus abdominis, and then we dissect using long sponge dissectors until we reach, this is the retroperitoneal space, this is the retroperitoneal fat. After that, I use the suction. I keep suctioning off the fat until I expose the quadratus lumborum. I slide down on the quadratus lumborum until I reach the psoas muscle, where I dissect it and I reach the disc space. Now, this is the approach where these are the iliacs, the iliac artery and vein, and now this is the level of L5S1. People shy away from this level to do it through an OLIF because here at some point you have 1 or 2 ascending lumbar veins. So usually what they do, if they had to do an L5S1 along with their approach, they would do L2 to L5 as an OLIF and then flip the patient and do an L5S1 TLIF. So what we started doing is we started dissecting until we found the ascending lumbar vein. We would clip it, cut it, and then we would expose the L5S1. The only difference is that we use angled shavers and angled introducers due to the promontory of the sacrum and to the shape of the L5S1 disc space. So these are the marking that we do intra-op. These are the shavers. The good thing about the OLIF is you're avoiding to go posteriorly. Sometimes we have patients, like I operated a patient last week. He had multiple surgeries done, decompressions in an outside hospital. He had severe back pain, severe foraminal stenosis. If I wanted to go posteriorly, I would have had to deal with a lot of adhesions, higher injury of dural tear, injuring the roots. So what I did multiple level OLIFs with indirect foraminotomy. I placed huge cages anteriorly where I decompressed his foramens by elevating the vertebral bodies, and I just instrumented him from the back without doing any decompression, and he was completely relieved from the radiculopathy and the back pain. So here we can see that the shaver, we introduce it and we puncture the annulus on the contralateral side. This is very good if we have any coronal imbalance. This would actually, at multiple levels, we actually see the coronal imbalance correct on fluoroscopy intra-op as we puncture the annulus on the contralateral side. These are the cages. This is the Cougar cage that I used. Now there's an Aspinax cage that's also being used in Lebanon. These are the multiple levels of cages that are placed. For just a quick example, this is a patient with multiple level stenosis, foraminal stenosis and listhesis. So Here, instead of going posteriorly, we went through an olive, multiple levels, and then percutaneous screws posteriorly without doing decompression. We published our L5 to S1 in 2017, and we proved that L5S1 in olive is also a safe option, and it has less morbidity than the ALIF. Now, many surgeons, they think that operating, if I am an open surgeon, then what's the danger of doing a minimal invasive surgery? Maximum it is a 1.5 centimeter, but I have seen a lot of complications happen because a lot of experienced spine surgeons get misled and get into the wrong spaces due to the loss of anatomy through operating into small tubes. Thank you very much. Open for questions.
Thank you, Dr. Tariq. We'll move on to the last but not least talk of Dr. Christine Al-Yahshoushi. She is an assistant professor here in anesthesia. She graduated from AUB, followed by a fellowship in interventional pain at Case Western in Cleveland, Ohio. She's active in international pain societies, served on the Educational Board of Spine Intervention Society, and recently appointed as instructor in this society. She will talk to us about intrathecal programmable pumps in treatment of back pain.
Thank you, Dr. Ames. So I'll talk briefly about intrathecal pumps. So in the past, the only device we had was the Medtronic one, the Synchromed 2. In 2014, the FDA approved another device of Flowonics, Prometra 1. Now we have a Prometra 2. Still, the Medtronic is the only one with a PTM that allows the patient to give himself a bolus, similar to the PCA or PCEA we have. For intrathecal pumps, initially it was introduced as a salvage therapy. Indications now are changing. We can consider intrathecal therapies for all the patients who have the following. We have an objective evidence of pathology, who failed to achieve adequate results from oral opioid therapy, or who cannot tolerate anymore the side effects of the opioid. Of course, patients should undergo a psychological eval. We don't need to implant such an expensive device for patients who have underlying psychological problems. It's important to divide the patient between cancer or non-cancer pain, because the outcome will be different. As a matter of fact, localized or diffuse pain is also an important thing to differentiate when implanting those patients, and young population or older population, and the starting dose of opioid is also an important fact. We do have current limitation for intrathecal delivery. The most important thing is the CSF flow, or our ignorance to the CSF flow. So the traditional flow that we were taught, the bulk flow of CSF, is now controversial, and we know that the CSF is pulsating rather than flowing in a bulk flow, and it varies between diastole and systole. And the CSF is really oscillating in a craniocaudal way, and rather than the traditional flow that we were taught about. And the famous Bernard pilot study, animal pilot study, it tells us that the medication around of the tip of the catheter will stay confined. They will not really disperse, and we have a posterior predominance, posterolateral predominance, and the medication will not rotate and reach the anterior catheter. As you can see here on this graph, when we're using the low rate, similar to the rate we're using in the pump, we do have a predominance posterior flow, and there is no real circulation between the posterior and anterior. However, when the patient is giving himself a bolus, the flow will be in a different way. So our ignorance to the actual CSF flow is a limitation, the current limitation for for our use to the pump. Another limitation is the pharmacological pharmacokinetics and pharmacodynamics of the drugs, either from the concentration. We have limitation of the concentration of the drug. We have different pharmacodynamics, including liposolubility and all the other kinetics of the drug. So it is important to notice that when we're using a high lipid soluble or if you're using a high lipid soluble drugs, the medication tend to stay around the tip of the catheter, and in opposition to when we're using a hydrophilic drugs, the medication will tend to move a little bit more of the catheter. And knowing this, it is important always when we're implanting the catheter to stay next to the generator of the pain source generator. So we can see here that in order for the medication to act, they need to reach the receptors, and most of the receptors are in the dorsal horn, and that's why it is important to leave the catheter in the posterior, as we can see here, in the posterior space and not in the ventral space, so that we keep the medication next to the receptors. And as I thought before, the more the drugs, the lipophilic are, they will tend to move away from the catheter. However, if you're using a more hydrophilic lipophilic drugs such as morphine or fentanyl, the medication will stay confined to the tip of the catheter. So it's important to know the drugs we're using and the pharmacokinetics of those drugs in order to know how they will be moving in the intrathecal space, so we can help the patient more when implanting those. So we have a lot of medication currently used. The morphine and the ziconatides are the only FDA-approved drug for intrathecal implants. Morphine is not FDA-approved, commonly used in the state. It's a local anesthetic, sodium channel blocker. It has a high lipid solubility, and then it will stay confined to the tip of the catheter. It, as you all know in anesthesia, we have a different sensory to motor differential block when we're using it. It has a synergistic effect when we put it with morphine, and often it is used as second-line agent in intrathecal and continuous intrathecal infusion. This slide was presented before. So in this study, it was shown that the addition of morphine to morphine and intrathecal pump will not statistically decrease the pain. However, what it will do, it will decrease the escalation of the opioid. We all know that similar to the oral way, the intrathecal morphine needs to be escalated when the patient is developing more tolerance. So the morphine will prevent this fast escalation opioid and chronic non-cancer pain, as you can see here, for patient implanted with morphine only in comparison of patient implanted with morphine and morphine. So other than the bupivacaine, we do have opioid to use in intrathecal. The morphine is the only one FDA approved. It has similar side effect when we're using it in an oral path, such as pruritus, urinary retention. But the most common fear for complication is the formation of intrathecal granuloma that can be seen here at the tip of the catheter. And the risk factor of formation of this granuloma is using a higher dose at a higher rate and higher concentration. And it may occur in 3 to 8% of implanted patients described most commonly with morphine, hydromorphone. None of the other drugs has been described to form a granuloma. So we can see here that with higher dose, all these studies showing that with higher dose of hydromorphone, there is a higher chance to form an intrathecal granuloma. However, we do have cases of granuloma with very low doses. Ziconatide is another FDA-approved drug. It is a kind of weird drug. It is difficult to titrate, has cognitive side effect. It adheres and goes to pump hole. It is an expensive drug with limited efficacy. However, it's still showing as a first-line therapy in all the consensus of the intrathecal pumps. The FDA here looked at the efficacy of this drug, and it really shows high efficacy when compared to placebo, 14 versus 7%. And here also, patient implanted with ziconatide, around 30% will report complete or a lot satisfaction with therapy with this drug. Clonidine is another drug, not FDA approved. It has a difficult titration protocol, and withdrawal symptoms of this drug are really bad. So some of the practitioners will try to avoid implanting patient with the clonidine. We don't have real guidelines for implantable device, specifically the pump, but we do have consensus formed by all these people who are leaders in North America in intrathecal pumps and neuromodulation. And the last meeting of this consensus was in 2017, and they agreed that intrathecal therapy should be used for active cancer-related pain, and this is evidence 1. For non-cancer pain implanted with opioids, it should be level 3. Implanted with ziconotide, it's a level A. And there is special guidelines or consensus agreement about the drugs that should be used. And here again, ziconotide is always shown as a level A drug to be used in localized, nociceptive, or neuropathic pain, as well as diffuse, localized, and nociceptive pain. The only difference between localized and diffuse pain is that the second-line therapy can be here fentanyl. However, it's always morphine or hydromorphone in the second. So these are like people gathering and agreeing on the best drugs to be used, and on multiple consensus, ziconotide is still showing as a first-line therapy in concordance with morphine. Trial is a part of this consensus. It's not mandatory. It's recommended, and the best way to do it is to taper patient from opioid. Like an opioid-free trial for 5 weeks is mandatory. So we should wean patients off oral opioid and then do the trial, which is, as Dr. Marraoui talked, like implanting an external device, catheter inside, the pump is outside, and admit the patient and see how they are doing, titrate the medication. And the average effective dose has been shown to be around 140 microgram of morphine per day, or equivalent doses, in order to have adequate relief for chronic low back pain, non-cancer pain. As we can see here, as I talked before, like similar to the PO or the oral way, the most fearful thing with opioid implantation is the escalation and the need of escalation of the therapy in order to have the similar effect. And we can see here that there is like a huge need to escalate the opioid. And as I said before, if we combine opioid to local anesthetic, this escalation will be less and less. So this is a case that was implanted, a funny case for intractable trigeminal neuralgia with the catheter going up at the C2 level, dripping fentanyl and morphine at a very low dose. Yeah. Halik. Another limitation of our knowledge through the intrathecal pump is the equipment itself, and this is the actual pump. And we do have like a rate of 9.03 of device failure, of motor dysfunction reported failure. And we can see that this rate will be more and more with years of implantation. It will peak around 5 years. And this is really a significant rate, 5.3% for such an expensive device. So what we need in the future is a more reliable hardware and like a better understanding of the way it functions and of the way the CSF is circulating and functioning. We need like a patient-centered guidelines to differentiate between cancer, non-cancer pain, have different guidelines for patients with localized or diffuse pain, and better psychological stratification to avoid implanting patient with underlying psychological problems. And of course, we need better drugs, and here in Lebanon, we need better concentration of the drugs because we lack like adequate drugs. So in conclusion, intrathecal therapy in chronic non-cancer pain, it lacks level 1 evidence. It's still an option for patients who failed other therapy. Drug distribution may be limited. The catheter tip location is important. It is important to know the pharmacodynamics of the drug we're using and to segregate the patient between different categories. We need better equipment and this is a nice algorithm that can guide us when to implant the patient. So like disregarding patient with cancer pain, if we're looking at patient with non-cancer related pain who failed less invasive modality, trying to avoid implanting young population with opioid if the patient is more than 50 years and and a favorable psychological profile with all the inclusion criteria we met before, he's a good candidate for intrathecal implant. Thank you.
So thank you, Christine, for this excellent presentation. I never implanted a pump for a low back pain. Never.
So
that would be my question.
Never.
What are the indications for that? I mean, or implanting both a dual spinal cord stimulator and then later followed by an intrathecal pump if you don't get the adequate result. Have you done these?
A pump for a low back pain or chronic low back pain with or without radiculopathy. In cases of lesion inside the coda equina, post-traumatic or other, we can consider this. But for real chronic low back pain or failed back surgery syndrome, I never implanted a pump. But because I know that we will not have a good result, one, and second, we have to consider psychological problem in these patients more than organic problem. No?
I totally agree, yes. Yes.
Have you had a dual implantation and the spinal cord stimulator has failed? And then
So I didn't, but I had a good same talk like Dr. Marawi, failed back surgery, where I've seen patients who had deformity where they had a spinal cord stimulator and like a couple of them actually, one and then a pain pump and still not able to do very, very well. I think this is one of the things is you go, I'm a surgeon, so you think everything is, a knife will treat everything. In specialists with pain management, you think you can do everything with the needle. Family practitioner will do it with the pain medications. Really, I think it should be multidisciplinary whenever you do anything, especially nowadays, because there's so many subspecialties. It's almost impossible for us to know everything. So somebody once you, I mean, there's a clear indications for a few things you can do them, but I think once you go beyond that, I think you should start consulting other people before you get to the final decision how you manage a patient.
What is amazing in the intrathecal pump therapy, in some indication, I do always a test before the implantation, yes, not for failed back surgery syndrome. And I always use morphine and placebo, not for research, for clinical trial, for clinical selection of patient. And always we have really a dramatic response on morphine, and on placebo the patient 10%, 20%. With morphine they are improved of 100%, even they did not know that we give placebo or morphine. But the problem is the long term. Always we implant the pump for a special indication, 1, 2, 3, 4 months. The 5th month, 6 months, the patient begin to have the same pain. We increase the dosage and we go through the same problem. So I don't think that.
So mainly pain pump were introduced for terminally ill patients, right? I mean, usually after a year or two, and they lose their efficacy.
The same problem.
The study was done, I think, at Hopkins, with Facet that looked at, implantation for terminally ill patients. We need to have, to be cost effective, we need to have like a 6 months, survival. Less than that, it's too expensive to use.
3 months.
Cancer patient with severe intractable changes.
I had last year 3 indications of terminal patient. The time to convince the family and to take decisions, the patient that.
We're talking about more than 3 months survival.
To get approval بالضمان like that.
ليك هلا مشيناها مشي الحال، ما بعرف طالع اذا هون صار في 100%. بالاول كانت 50%، هلا صار الضمان ياخذها، صار لها كود 100%. بس المشكله المستشفى مش الضمان، لانه ولا مستشفى بتقبل تحطها بسعر.
Thank you.